Bwrdd pawb, welcome to this extraordinary board meeting of Hywel Dda University Health Board. Thank you for finding the time to attend. I'm conscious it's a bit of a marathon event today and tomorrow morning, but hopefully we will feel that we've discharged our statutory responsibilities effectively at the end of this period. I appreciate the time that you've given up to do this. I'm conscious it's quite a lot of time to dedicate and devote to this. I'm also conscious that lots and lots of people will join us over the next day or two, including our clinicians, and you too will be giving up time to attend this event. I'm very grateful and appreciative of your time. I'm also conscious that the public will also be actively engaged in watching or participating in the event, and similarly I'm grateful for the time that you've given to this and your commitment and your passion for health services in West Wales. You'll know that the event has two very distinctive pathways. We have today's, which is very much around listening to the detail and giving full consideration to each of the 9 clinical services that we're looking at. So today is about understanding, it's about factual representation, it's about inquiry, it's about discovery, it's about ensuring that we are applying appropriate principles of good governance to the process, and it's giving us an opportunity to process the kind of complex information that we're being exposed to. And then tomorrow morning we will spend our time making decisions on how we feel it's best for us to move forward. And hopefully by tomorrow lunchtime we will have reached a clear direction of travel in terms of some of those very fragile services. Let us remind ourselves in terms of where we've come from and how we arrived at this point. It was 3 years ago in March 2023 that the board was first, that the 9 fragile services first came to the attention of the board. And that was a consequence of investigative work across the health board and an appreciation of the fact that actually our services were fragile and needed to be in some way remediated. Since then, obviously, we prepared a plan, and in the late autumn of 2024, we agreed a process of consultation. I think what I want to stress is that this just hasn't happened in the last 12 months or the 12 months before that. This, in fact, has been part of a 3-year enterprise. So today we sit here building on the knowledge that's been developed over this period. Let us try to also understand some of the reference points for what we will be doing over the course of the next 2 days. You will know that at every board meeting, I try to reinforce a set of design principles that help us to think about how we make decisions. Those design principles broadly focus on ensuring that our decisions are fair, that when we make them, they are affordable and sustainable. They are consistent with our strategy. They do not set an unhelpful precedent, and that they are fundamentally decisions that lead to safe health outcomes for our patients. Similarly, during the course of the next 2 days, we will be thinking about those broader values and principles that underpin the work of the Health Board, which are not dissimilar to the ones I've just said to you. Those are services that are safe, accessible, sustainable and kind. So what we want to do is ensure that when we think about making decisions or our considerations, that we apply these two kind of levels or filters in relation to our decision making. It gives a robust framework for us making decisions, and it makes us accountable, and it also makes us consistent in the way in which we make those decisions. Finally, the reference point for me that I think I've been thinking about fairly regularly over the last few weeks is that we very much focused on these changes in West Wales. So the 9 services will impact upon all of our hospitals and the way we deliver our services. But it isn't really just West Wales. In fact, it isn't really Wales. In fact, it's as large as the UK, if not bigger than that. Hospitals have profoundly changed over the last decade. They will profoundly change over the next decade as well. This is an opportunity for us to start to work out how we influence those services and take them forward. Every hospital in this country will change, and they will change as a consequence of some important trends and patterns that we see emerging in the way in which we delivered healthcare. Firstly, and probably most importantly, is we have seen phenomenal advances in the delivery of healthcare over the last decade. The life chances and the opportunities that it's presented to improve patient outcomes has absolutely been enormous. And we've seen that across all the major disease profiles. And we will continue to see that. So advances in healthcare have really kicked forward this process. Secondly, we know that advancing healthcare is about research, it's about excellence, it's about bringing teams together, it's about enabling individuals to develop shared insight, shared understanding, shared expertise. So what enables hospitals to grow well and advance their practice is that ability to bring people together, to bring our clinicians together to share their expertise and their insight. And that would be true across the whole of the country. Secondly, the reason why I think we'll see profound changes in our hospitals is because of the shift towards primary and community services. So many of the services that conventionally and traditionally would have been delivered in a hospital setting are and will in the future be delivered through primary care and community services. We will see more and more of the services that conventionally was delivered in a hospital environment delivered in our communities, delivered at home, delivered with the patient, delivered through our communities. And I think we're all keen for that to advance as quickly as possible. And then the third reason why I think our hospitals will change is because of the phenomenal growth in digital, AI, automated applications. So it presents both an opportunity and a risk for us in many ways. The opportunity is that we can create an ever greater connection between ourselves and patients. We can run services from different environments across the health board. We can employ technologies, AI technologies, to be able to assist us in the delivery of good health care. Inevitably, there's lots of risks in that as well, in as much as we need our patients and our communities to come with us. They need to understand those changes and what they will mean for them. We need to build a trustful environment where we all advance healthcare outcomes together, both communities, people who serve those communities within that health board, and ourselves as the health board. So for me, that's fundamentally important. So that's the broader context that I think it's important for us to be aware of when we think about the 9 services that we are going to be looking at over the next day or two. It is about those 9 services, but the broader trend is that hospitals will change. Hospitals will change as they have in the past and as they will do in the future. Just to set some kind of housekeeping rules around how we will work, we are running a simultaneous translation service in Welsh today. Those who are around the table will have devices for them to be able to hear Welsh translated into English if they so wish. All you have to do is place them on your ears, and then the dial is just a volume dial on the front of those. We'll also be running a sign language service as well, which I think is being run from a different part of the country. We're very grateful for our advisors and supporters in delivering this. Thank you very much. So what we will try and do is be as accessible as possible in terms of how we work. You'll know, people who are sat around the table, that there is a very tight timescale this morning. So we will be brutal in terms of closing particular sections of the meeting in order to move on to the next. We can't compromise some of the things that we will need to look at later by just allowing the meeting to roll forward. So we will structure it as much as possible in order to ensure that we spend appropriate time and attribute enough thought and energy to each of the 9 clinical examples. I begin with an appreciation of those who have worked hard to bring us to this event today. Whilst the board can hopefully engaged fully in this process. It's really a consequence of an enormous amount of hard work that's been delivered across the Health Board in terms of our consultation with the wider community and the preparation and involvement of our clinicians in that process as well. And for that, I'm extremely grateful. Let us begin by just focusing on any apologies we might have received.
Sure, Chair. So we've got apologies from Donna Coleman and Clyde. However, we're grateful for Alison Thomas, who's here today representing. And just for the minutes, Alison kindly sent in a letter last night from Clyde, which has been shared with all board members and is available on the website, and I know will be picked up as part of today's conversations. We've also got apologies from Bwrdd, our aspiring board member, Dr Jonathan Arthur, the Health Professionals Chair. We've got Sharon Daniels, our Executive Director of Nursing, on Zoom. However, Cathy Steele is in the room to support and to deputise for Sharon where needed. And Winston Weir, our Independent Board Member, and Michael Gray, our Associate Board Member Chair.
Thank you. Thank you, Joe. Really helpful. Just to also share with everybody that Sharon, Director of Nursing, will be on, Executive Director of Nursing, will be online this morning. She unfortunately is unwell. And Cathy, I think you've joined to represent Sharon in the room. Thank you very much for joining the call today. Thank you, Joe, for that. Can I ask if there are any declarations of interest or conflicts of interest?
Oh, thank you.
Yes, please, Chantal.
Thank you, Chair. And so it's in relation to the item on cellular pathology, as I'm an employee of Swansea University.
Of
but
course.
I will withdraw from that.
Of course. Thank you very much for informing us of that. We will
Get that tomorrow, Chair.
tomorrow at the end of the meeting. Thank you. Okay. So, without any further ado, I'm going to hand over to Lee Davies.
Diolch, Cadeirydd. Thank you, Chair. So I'll be fairly brief in the introduction. We've got a lot of information to get through, as you'll have seen. So I'll just make 3 quick points. So firstly, I just want to offer my thanks also to everyone who's been involved in this process over the previous years. So we do have Sarah, Nikki, Alex, Ben and Yvette in the room with us today, which have all been integral to developing the work up to this point, and you'll see the quality and the depth of the work that's been produced to support board decision making today. Beyond that, though, there are a wider team of people who've been supporting this endeavour, to include Helen, our head of the Transformation Programme Office, and Hannah, Julian, Mike and Rian. So my thanks also to all of those. We also have Cathy from Hyco here today, who's been very helpful with throughout the process, and our thanks go to ORS also for their contributions. I would very much like to thank our clinical and operational leads and the leads from the different support functions for their work as part of the Options Development Group over the course of the last couple of years. Also their contributions to the consultation events that we'll hear from later, and the feedback we've had from our public, and of course in many cases their attendance today also at a busy time. So very grateful to everyone's time and willingness to contribute to this. And finally, I'd like to just thank our communities, as you mentioned, Neil, and our public for the way in which they've engaged with the topic. I was personally part of many consultation events, and I think we'll see as we go through the conversation today that everyone's feedback will be invaluable to our deliberations through the course of today and tomorrow. The second point I wanted to just make was that, as you mentioned, Chair, this isn't a process that has started recently. We've been looking at this for the last few years, but actually the origins go back to 2018 and previously, when we were clear within our strategy that many of our services were unsustainable and we needed a new model in order to deliver healthcare for West Wales. Much of that is aligned with the points you've made, Chair, around use of digital, primary community, but also we were clear that our hospital configuration would need to change. We've seen, prior to the commencement of the CSP work, during the CSP, and I'm sure following this process, we've seen some urgent service changes that we've needed to instigate to respond to fragilities within our services, and that reflects the ongoing pressures that many of our clinical and operational leads need to contend with on a daily basis to continue to provide services. So what we're doing through the course of today and tomorrow is seeking ways to respond to those service challenges in a proactive way rather than responding to urgent service change as they arise, and actually raise our aspirations as an organisation and as West Wales communities for our healthcare services. We don't just want to survive and keep delivering services on a day-by-day basis. We want to achieve the highest possible standards for our population, and the intention through the clinical services plan is and always has been to set the right foundations for that to be possible, so that we can deliver high quality, safe and resilient services for our population for the long term, not just for the next 12 to 18 months. The final point I just want to make before we commence with understanding the consultation feedback and looking at the individual services is today and tomorrow are important days in this process, but they are just the next stage of this process. We won't suddenly be making radical changes to clinical services in the next days and weeks. We have to think carefully about how we implement any changes, and we'll be bringing those plans back to board in due course, subject to board decision making today. So I guess just to reassure public listening and members of the workforce that there won't be a rapid change tomorrow in the way services delivered. We'll be looking to develop that over a period of time and taking account of all of the feedback that we've heard and points of concern that we've heard in relation to any particular service options that the board considered today and tomorrow. So with that, I will pause. I'll hand over to Ben, I think, to take us through the next bit. Thank you, Ben.
Thank you, Lee. Mr. Chair, could I check, are the slides being shared at home on the public?
I think there may be. Ben, I think you need to pull the microphone to you.
Oh, okay. Sorry, Mr. Chair. I was just checking if the slides were being shared at the public.
I think so, but they're already online, so...
Okay.
We've got access to the slides anyway.
Okay, thank you. I just wanted to check if everyone did have access to what we're talking to. So the first couple of items, sorry, bring that a bit closer, just wanted to cover today is the number of products that we have covered in the programme. So that's reference to the next slide about the post-consultations activities, slide 1 and 2. So what I really wanted just to highlight again is that draw your attention to the key programme materials produced following the consultation, as well as the analysis developed during phase 2 of the Clinical Services Plan programme. So this included an independent consultation report from Opinion Research Services. It included the alternative options previously shared with our Strategy and Planning Committee. It included the findings from the Quality, Safety and Experience Committee and the extraordinary sessions that took place with reference to the services and the Clinical Services Plan. It included the informing plan and the processes of conscientious consideration, which you all supported. On the next slide, for part 2 of that report, there were a number of other products that were produced by the Clinical Service Plan programme post-consultation. Okay. Apologies, I'm just bringing that up on the screen for you now. So if you look to the screen, what you can see is several other products that were produced post-consultation. This included the Phase 3 closing report, and this brings together our key programme outputs, including the alternative options appraisal, the shortlisting workshops that took place, and is supported by updated programme impact assessments covering quality, health, equality and environmental impact assessments. And it also includes estimates and indicative assessments for capital, workforce and financial estimates, and they underpin the option evaluation. Together with all of today's materials, these represent only our top layer of our information pyramid. Give me a second, my notes have dropped off the screen. And we encourage anyone with specific interest in the services discussed to explore these documents as a minimum further. Before we move on to more detail, I'd like to introduce Cathy from Hywel & Co Associates, who are providing quality assurance based on the Centre for Consultation Framework today.
Thank you, Ben. Thank you, Chair. It's a pleasure to be with you all this morning. So I am just going to explain the process of quality assurance that we have applied to the consultation process. So the first stage of our quality assurance is looking at what happened before the consultation was actually launched. So that looks at the depth and extent of engagement, it looks at the options development appraisal process, and very importantly, it looks at who was involved within that. So were the right stakeholders engaged throughout that process in order to build those those options and assess them appropriately. So what we do there is just look for that evidence base. The next stage is about scoping and governance. So that looks at exactly what is up for influence, making sure that there is a really clear definition for the consultation and the process. And it's about recognising that you as a board know exactly the decisions that have already been taken that your stakeholders cannot influence. It's also about lines of accountability. So what is it that officers are responsible for and can do, and which decisions are left to board, and those lines of communication between the two. Then we look, and I'm saying then, so some of these stages are not in a linear process, some of them are concurrent, so such as our consultation information and the planning. These two really go hand in hand. So consultation information, Ben has just talked about the information pyramid. So we're looking here for really clear, accessible pieces of information that are going to go out into the public domain, but yet that the public and stakeholders and others are clearly signposted to all the technical intelligence that you have that helped you build up your options that are being consulted upon. We also assess the consultation planning. So how have the stakeholders been analysed and mapped? How are you going to communicate with them? What are the methods of engagement? Are they all fit for purpose to ensure that it is an inclusive process? So then we move into consultation delivery. So at the consultation planning stage, we provide basically our recommendation if the consultation is ready to launch. Are all the pieces of the jigsaw in place to ensure that there is a defensible and robust process? So the delivery is about the extent to which people are being engaged, if there are any complaints being raised, any further requests for information, how are those being addressed? What we're looking for here is to make sure that you're getting wide representation of input and feedback back into the process. It's making sure that there is no misinformation out there, and if there is, how that is being addressed in real time. And we have two kind of milestones within that process, a midpoint, which then allows us to help pull together an action plan to address any points of clarity or any complaints, and then a closing point review, which is about 10 days before the consultation is due to close, to make sure that it can indeed close safely, because you are engaging with the right people, getting the information required. Then we move on to analysis and reporting, and that is reviewing the consultation report that ORS provided to make sure it is a fair representation of everything that was heard, that there's no bias within that report, and that you are getting the wide range of views included. And that really brings us, I suppose, to where we are today, the feedback and the decision making. To be clear, we are not quality assuring any decisions that you're making. What we are doing is looking at the process, that all the information is being considered in a timely and robust way, and that where there are queries or questions, that they are addressed. So it is about the process. And then stage 8 really is just completion from our perspective, where we will write to you to inform you of the conclusion of the process. So next slide. Oh, I've got it. Sorry. So we're pleased to report that all stages have been, in our view, completed in a robust and vigorous manner. You will have had the letters from ourselves. So the first one, there was only one recommendation, and it was a suggestion really, and that was because during the options appraisal process, the output and product of that was 4 programme options, but then a decision was moved to go out to consult separately on the options for each of the 9 programmes. So it was just about testing that information again to making sure that it was easily understandable in the public domain, and that was done via the use of a readers panel. Scope and governance. So we provided a letter of assurance for both scope and governance and consultation information in June, and we were able to confirm that both these stages had been completed successfully. Consultation planning, there were robust plans in place. We were able to see all of the stakeholder analysis activity that had been taken, and just we understood how the process was going to be monitored and reported throughout.
Cathy, you have 2 minutes.
Thank you, Chair. Then consultation delivery, we had the 2 meetings as I described, and I have to say we were, I suppose, blown away by just the commitment of the team at attending those meetings. We had every member of the team that were able to answer all our queries and questions, so there was a real dedication and commitment there. And we were assured that the consultation could close as planned. Analysis and reporting, we were able to provide some advice and guidance on that to ensure that the final output report provided by ORS was provided all of the information without any kind of gaps for other interpretation. And as I said, we are now here at point 7 in the decision making. So over to you, Nikki. Thank you so much, Chair.
Thanks so much, Cathy. So I'm now going to spend a few minutes talking through and summarising the consultation report. So as you'll all be aware, we went out to consult at the end of May last year for 13 and a half weeks to gather the views of our population on options across the 9 services. During that time, we received questionnaire responses from more than 4,000 people across our population and neighbouring areas. And we also spoke to more than 4,000 people to understand and listen about what they think around these options, and also to give them the opportunity to provide alternative options to the ones that we consulted on.
Which is almost 1% of our population.
Yeah.
Very good.
So you'll see highlighted on these slides some of the key cross-cutting themes that we heard during our conversations and in the questionnaire responses we received. We've tried to summarise some of those cross-cutting themes, so where they consistently appeared across multiple service areas. As we move through the day, we'll be talking through service-specific feedback that we heard during the consultation. But highlighted here are some of those things that we consistently heard across those 13 and a half weeks. So as you'll know, in reviewing the consultation report that was pulled together by ORS, travel, transport and our rural geography was one of the key themes that we heard consistently in our conversations with our populations. There were concerns raised that where services would be brought together and people would have to travel further to access them, that could mean long journey times for people. Some respondents also raised concerns that our public transport network here in West Wales and into Mid Wales
is challenging. It doesn't meet the needs of our community, and the infrastructure to connect our hospital sites isn't there, and that could widen inequalities for some of our communities. One of the other key themes that we heard was linked to staffing challenges. So whilst they could see how some options, by bringing them together, could help address some of the staffing challenges that we face in some of the 9 services, there were concerns that it wouldn't address all challenges, and that we need to ensure that in any future model for any of the 9 services, that we ensure that the staffing is deliverable and that we can achieve what we hope to achieve in terms of improving those services. Interdependencies was another key theme. So how the different services speak to each other was what a lot of our respondents picked up on. There were also concerns that if some services were removed from some hospital sites, how that might impact other services and beyond the 9 services included within the clinical service plan. So that should be a consideration for the board today. Our current estate and infrastructure, so how our buildings are currently, was another key theme that we heard from our population. There were concerns that they aren't in the best condition, and there were also concerns that where there were proposed options that would bring services together on some of our sites, that actually there might not be the space to do that, not just in terms of the service, but also in terms of having increased visitors to those sites, and parking was another one of those key themes that came across. During our conversations and in the responses to the questionnaire, we also heard consistently concerns around trust and confidence in the process, and that being fragile, particularly with some of our communities. So that's something that we need to work with our populations to help build. There were concerns that the clinical service plan was really complicated and difficult for some of our communities to understand, but there were also fears raised that we had already decided what the future service models would be, and that that what they were sharing wouldn't be heard during this process. In terms of mitigations, we heard consistent messages around the ability to better utilise digital and virtual services, and that could be one of the ways that we help address the challenges where people may have to travel further to access services. But they also raised we need to make sure we don't leave anyone behind, and that where we move to digital services or virtual services, that it's appropriate, and that where that's happening in an online space, it's right, and where we still need to have face-to-face interactions with our patients, that can still happen. And finally, in terms of some of the key themes that we heard, it was around the importance of protecting quality, the Welsh language and our rural communities, and how often impacts can be compounded together, and so where certain communities may face greater barriers to access, that actually in moving services together we're making them more accessible, so we need to be thinking about that in our decision making. So I'm now going to hand back across to Ben to talk about the process that we went through linked to the alternate options we received during the consultation.
Yeah.
Thank you, Nikki. So what you'll see on the screen is quite a significant response we had in terms of alternative options from our community. We actually had 287 ideas. So I just want to talk to you a little bit about that approach very briefly and what we did. So initially, obviously, to capture such a vast amount of feedback, we had to create a very techie version of an Excel document called an alternative options log. We had to capture every single person's idea, and that came through in a range of ways to us. Mainly, they came through the survey responses that Opinion Research Services shared with us and analysed. And once we collected all of those options, we had to test those options back with our task and finish groups, which were our services. Their role was to check whether options were duplicates, whether they represented genuinely new ideas, or whether they fell outside of scope of the Clinical Services Plan programme. After this bit of the process, we applied the hurdle criteria. At this stage, we were assessing whether each option was clinically sustainable, deliverable, accessible, and strategically aligned. That included also an analysis of financial sustainability at that point. Based on the information previously shared with the Options Development Group, across this step, 190 options were considered against the hurdle appraisal criteria. And we did that in October last year. Following that session, the task and finish groups carried out a more detailed assessment using our evaluation criteria, which my colleague will go through in more detail in a few slides' time. This was done through using a strengths, weaknesses, opportunities and threats analysis, and which you will see later in the service-specific presentations, where we draw out some of the key benefits and risks of some of the options. Each SWOT analysis shows where service felt an option had a really positive, negative, or unknown impact against the key evaluation criteria. And during this option scoring session, all of the alternative options, along with the options that had been to the public consultation, were scored in the same way against the evaluation criteria as what we did in phase 2 of the programme. So those options were considered in the same way. All this feeds directly into what's been presented back to you in board today, and that is a total of 48 potential options for consideration across the 9 services. What I did want to highlight to you, Chair, was that out of these 48 options, 22 of them have come through the alternative options process and have been generated through our public consultation and have ideas that have come back directly from our communities in Hywel Dda. So that shows that our clinical teams have absolutely listened to the ideas that have come back from our communities and applied those to the same rigorous process as been through in phase 2 of the programme. I'd like to hand over to my colleague, Yvette, now.
Just for clarification, so it seems to me that we reached a really healthy outcome in terms of the public contributing ideas or suggestions as to what we would do. We've completed that process, and obviously they will form part of our consideration as we talk through today. The point I would make, though, and I think Clive brought this to our attention recently, is if we agree, if we think there's an option that has been made as part of a public suggestion that we would want to take forward, but wasn't part of the original consultation, then we would need to reconsult on that option if we wish to take it forward. Just for clarification purposes, so everybody's aware. Nikki, we say something.
Yes, I was just going to say, obviously, as we go through the day, we'll be talking through those alternate options. In some instances, the alternate options that have been presented by the public and have passed hurdle assessment are very closely aligned to the options that we consulted on. So we'll need to look through that in more detail. There are some options, however, that have been presented as alternatives and have passed the hurdle assessment that Ben just talked through, that are considerably different from those that we consulted on. So where we wouldn't understand or have the information about some of the impacts of those potential service models, so where we would need to fully understand what the potential impacts, should the board want to proceed with those options, have for those communities, because they wouldn't have had the opportunity during the consultation to share those views with us.
Great, thank you for clarifying. Lee, did you want to say
it was the same point, really. I think we just need to make a case-by-case assessment when we've taken a view on what we think the right approach is, because, as Nikki says, some of the options, alternative options, are very similar to what we've already consulted on. So.
Great, thank you. Thank you, Ben, for bringing that to our attention.
Is next, so she's online.
Sharon, I don't know whether Sharon will.
Can you?
Great. Okay, we can hear you.
Excellent. Thank you, Chair. Diolch yn fawr. So I'd like to give you a summary of the deep dives that the Quality, Safety and Experience Committee undertook during the autumn of 2025, where they focus on the 9 services in the clinical services plan that were identified as fragile. Before I go any further, I just want to emphasise one point, in that these deep dives were entirely separate from the clinical services plan. They weren't part of the CSP process, and they didn't shape the CSP options. and they weren't influenced by them. So their purpose was very simple: to give the board and the public assurance about the quality, safety and experience of care happening right now in our services. So the deep dives allowed QSEC to ask some very direct questions. Are patients receiving safe and compassionate care today? Where are the risks? And what's being done to manage those risks while we await the longer term decisions? So if I summarise what we found aligned to the key themes that are aligned in slide 13 of the slide deck. So firstly, in terms of CSP neutrality, everything we examined was about the current delivery of services, not the future model. So not the options. So this protected the integrity of both processes. So the deep dives were informed assurance, and the CSP informed strategy. So QSEC took a very structured and consistent approach. For every service, we looked at the nature of the fragility, the quality and safety of the issues in front of us, what is improving, what is still at risk, and what mitigations were in place. So this gave us a really robust and fair comparison across all the 9 areas. So second, you'll see on the slide that assurance was mixed. Across the 9 services, we did take assurance, often strong assurance in several areas. But in some services, particularly dermatology, critical care and emergency general surgery, the level of fragility meant that assurance was only partial. So the teams are doing their very best, but the risks remain significant and visible. So dermatology, for example, is one of our most fragile services. National consultant shortages, rising cancer demands and limited estates all contributed. So Quality, Safety and Experience Committee only took partial assurance in this area, and the risk then was escalated to the board. In critical care, again, this is a committed clinical team working under significant pressure, and the fragility remains real and under active review. And again, in emergency general surgery, the services had a long-standing rota instability with the Bush, including periods of agency reliance. So whilst recruitment approvals have progressed and agreed, and the getting it right first time actions have been completed, the service does remain fragile. Nikki mentioned workforce, and this is the thread that runs through every single deep dive, whether we're talking about consultant numbers, SAS doctors, specialist nurses, therapy staff in stroke, or sonographers in radiology. The biggest constraint across all our fragile services is workforce, and without stabilising those posts, fragility will continue. QSEC identified that there are real improvements to celebrate. Endoscopy has reduced waiting times from over 100 weeks to 8 weeks. Urology has eliminated all patients waiting over 52 weeks. And Orthopaedics had improved prehabilitation, communication and reduced incidents. But, and this is really important, the Quality Safety Experience Committee was acutely aware that these gains rely on things like weekend activity, insourcing, temporary outsourcing and a lot of goodwill. So they're positive, but they're not yet robust. The 5th bullet point talks about interdependencies and these matters. One of the strongest messages coming from the deep dives is that fragility rarely sits neatly within one service. Diagnostics affect surgery, theatres affects orthopaedics and urology, radiology affects stroke, and cross-site flow affects both critical care and emergency general surgery. So in a dispersed geography like ours, these interdependencies amplify risk. Apologies, my sound is it's feeding back to me now. Do you hear me?
We can hear you.
Hear me?
We can hear you, Sharon.
Yeah. So,
go ahead, Sharon.
My apologies. Can you hear me, Chair?
We can, well, actually, you're quite faint. I
Thank
think
you.
we've
Okay.
been fiddling with the
So-
sound this end, and it's got worse, not better. We'll just see if we can quickly have someone look at it.
Okay.
May I say something?
Of course.
I'm having messages to say that you can hear me.
Yeah,
We can.
You can, lovely.
Yes.
Okay, I'll carry on. So if I go to the 6th bullet point, the patient experience bullet point, it does remain strong where access improves. So where we have improved access, particularly in endoscopy, urology and orthopaedics, patient experience is consistently positive, and patients are quite clear that staff on the whole are kind, compassionate and committed. Where frustration remains is that there's almost always they are almost always about access, not about the quality of care once that's received. So finally, CUSEC identified very clear priorities going forward into 2026. Namely, we need to continue our efforts in recruitment and retention for the hardest to fill roles. Then we need to protect the temporary enablers that are supporting recovery. We need to strengthen our governance in areas like critical care, standing operating procedures, stroke performance and emergency general surgery, rota risks. And above all, we need to maintain close oversight while the CSP decisions move towards implementation. So across all 9 deep dives, the message was consistent. Care is being delivered safely and professionally by dedicated teams. Improvements are visible, but not yet resilient. And workforce fragility is the dominant system risk, sorry. So some services require continued board attention, particularly dermatology, critical care and emergency general surgery. And this work provides an independent baseline of assurance that sits alongside and not within the clinical services plan. So finally, I want to reflect that although the services are fragile, the professionalism of our staff come through strongly in every deep dive. These deep dives give us a clear picture of the present, independent of the clinical services plan, and help us to understand the context in which tomorrow's decisions will land. Diolch, Cadeirydd. Thank you.
Diolch, Sharon. Thank you very much. I'm just going to come to you, Phil. Is anything you want to add to that?
Just a couple of points. Thank you, Sharon. Dear Sharon. I suppose it's really important that we have the view of the Quality Safety Experience Committee on our fragile services as part of this process, because clearly this whole process has been driven by us wanting to make improvements in our services and our concern over a number of our services being fragile. So it was just to make the 2 points. One is for the public that QSEC means our Quality Safety Experience Committee, to just decode that for the public and others. So that is the committee that, on behalf of the board, considers all matters relating to quality safety experience. The other point was to make, because this is complex, is that where our Director of Nursing is highlighting the fact that there was partial or mixed assurance, that relates to our concerns around those services being fragile, and therefore is a driver in itself for the whole of this process that we've followed over the last few years. It isn't in relation to concerns about assurances around the process.
Thank you for the clarification. Arwela, did you want to come in?
Diolch yn fawr, Cadeirydd. Can I invite those who don't yet understand Welsh to wear your headphones, please? Diolch yn fawr, Cadeirydd.
Thank you very much, Chairman. I thought it'd be very important to confirm that we have considered the Welsh language as well as part of this process, understanding that this is above and beyond the compass of the work of CUSEC, but we have taken action to go to the Welsh Commissioner for Welsh Language to make sure that we have some assessment studies to see of any effects that this would have on the Welsh language. We have mapped out where our Welsh language speakers are across our geography and across our services. But naturally, because any option that we would choose depends on individuals. When we've made those decisions, it's very, very difficult for us to measure what this effect would be on those changes. So must I agree with the commissioners, Welsh Language Commissioner, we've put some assessment effects in as life processes, and when it comes to make the decisions and action the work to put the plans into action, we would do it to make sure that we can promote the Welsh language. If that means that we have to recruit staff. If staff want to move, or then we could take action to support staff to strengthen their Welsh language or to learn Welsh. We're not talking about buildings here, but we're talking about individuals here and their linguistic skills, and we would be there to support them along the process and to making sure that we reflect the needs of our communities as we go forward. Thank you.
Okay, thank you, Almena. Thank you, Sharon, for your presentation. Shall we move on? Alison, did you want to? I saw your hand go up.
I was just wondering, in relation to the gathering of patient experience, was there any significant variation across the services that were part of the deep dive?
Good question. Colleagues, Nikki, would you overview on that?
I think we might want to bring in Sharon's got a hand up. That got a hand up on the screen.
Okay, Sharon.
Thank you, Chair. There wasn't, Alison, there wasn't significant variation. Quite often with patient experience, we tend to get very positive feedback from patients, and our focus is very much on the areas where we need to improve. I think what came across from the feedback in the deep dives was that patients were generally content with the compassion and the quality of care that they were receiving, but access was the main issue that they were reporting negative feedback about. So, but there was no specific variation that I recall from the deep dives.
Is that okay? Great, okay. Okay, in the interest of time, let's move on to informing plan.
Yeah, lovely. Thank you. Diolch Cadeirydd. Is it possible to share the slides again? Great. Diolch. So during November and December, stakeholders reviewed the draft consultation report and the presentation of the key headlines. And were invited to give feedback on whether the findings reflected what they expected. So this slide provides a high-level summary of that feedback, which informed the development of the informing plan. The informing plan also outlined any significant changes since the issues paper was published in 2024 and included feedback on the alternative options. So stakeholders raised a series of reoccurring themes, and these closely align with what we heard during the consultation. So, as we've already heard today, travel and transport remain the most significant and consistent concern, strong views around infrastructure and for rural, older and more deprived communities. Centralisation of services created widespread concern, particularly around disproportionate impact on areas such as Ceredigion and Pembrokeshire compared with more central locations. Issues of fairness, accessibility and the practical challenges of longer travel were all raised. Stroke services attracted the strongest opposition, with stakeholders highlighting risks to timely access, especially the golden hour, and concerns about family access during rehabilitation. There was also uncertainty around how the treat and transfer model would operate safely. Workforce fragility remained a prominent theme, with pressures in therapies, radiology and specialist consultant roles highlighted as critical risks to deliver any future model safely. Many felt the proposed options may not fully address these challenges. Service interdependencies were emphasised as stakeholders saw clearer explanations of how radiology, therapies, pathology and primary and community care would fit together with the proposed models and what mitigations would be required. Equality concerns continued to feature strongly, including concerns about deprivation, the Welsh language impact, which Alwena just covered, digital exclusion, transport barriers and impact on vulnerable groups. Suggested mitigations we heard were consistent with that of the consultation findings. So in January of this year, board members met to conscientiously consider the draft consultation findings and the work that was done on the informing plan, which were shared in advance with board members. So this slide summarises the key points that were raised during that discussion, and full details of that work is within the closing report. So changes to services since the issues paper was published in 2024 were not viewed as significant. Nothing that has happened alters the need for change or the overall direction of travel. The weighting of responses needs careful consideration, as feedback from more populated areas should not unintentionally carry greater influence. This is not a popularity exercise, and rural perspectives must not be overshadowed. Service interdependencies require careful interpretation, as an impact noted in the feedback does not necessarily mean a service could no longer be delivered. Further clarification on clinical interdependencies is needed, particularly in understanding how different services rely on one another within the proposed models. Travel and access, again, remains a complex issue, especially when balancing proximity and quality. Expectations differ for urgent and planned care, and the quality impact assessments are important in understanding potential impact and required mitigations. There's also a need to balance community concerns with clinical, workforce and financial realities, and to demonstrate alignment with wider organisational strategy, while recognising that financial responsibility still matters, even though finance is not the primary driver. Representativeness was also discussed with reflections on lower participation from children and young people, and the need to ensure seldom heard voices and insights from face-to-face engagement are considered alongside the survey data. And finally, no single option will satisfy all stakeholders. Clear and sensitive communication will be essential, with a continued focus on achieving the best possible outcomes for patients.
Diolch. Thank you.
So that brings me on now to the evaluation criteria that Ben referenced earlier. So throughout the clinical services plan, the phase 2 and where we are now, we've had these 16 criteria. So these were developed with the aid of our clinical reference group, who looked at best practice examples from elsewhere, things that we'd used previously for similar bits of work. And these 16, when we brought the board previously, there was a good conversation amongst yourselves around how these can be applied to the services, because we do have 9 very different services with different needs, different patients they're treating, and so they need to be looked at separately, individually almost. So these 16, although they set out how we would assess the options, there is a bit of subjectivity. So when we talk about compliance and attainment of standards, for example, we know that different services are working to different standards. What we've done is made sure that we've applied that criteria equally across those, so that we're doing that balance and checks. And in terms of how we've done that, we have previously submitted the metrics that sit behind. But it's a blend of things we can measure, so the quantitative, so we can measure differences in travel time, we can measure differences in activity, and some of them are more based on professional judgment. So compliance attainment standards, again, that's a professional judgment from the services with support from our wider teams around, if this were an option that were to be implemented, how do we feel this would impact our ability to meet those standards? So those 16 were used across the two. And then in terms of the weighting, so at the moment those 16 are equal. So they have equal impact if you were to score an option. And so it would mean that an option that focused on improving standards may not necessarily be reflected as well as an option that improved workforce sustainability. So we use the weighting to work out what's most important. What would a good option look like through the weighting? And to do that, we asked our wider options development group in phase 2, so that included patient representatives, third sector organisations, to support us with that scoring exercise. So they provided those weighting scores, we added those up, so that when you see the scoring later on as part of the service presentations, that weighting has been applied. And then in terms of the criteria, so we originally, and you'll see on the next slide, aligned them to our principles around the Healthy Mid and West Wales. So those principles of safe, sustainable, accessible and kind services. But we also looked against the duty of quality around aligning them to the principles of STEEP, so safe, timely, effective, efficient, equitable and person-centred. So we feel confident that the criteria allow us to meet the duty of quality. They're aligned to how we have previously tried to organise and arrange services. And then in terms of the criteria, so you'll see that the top scoring criteria there are mainly in the sustainable. So that's around 2.1, the clinical demand. So actually, are these the services that we need to deliver the population? Will there be the patients there to support our workforce to develop those skills? Workforce sustainability. So actually, is this something that we can sustain, that we can deliver longer term? And the last one there in the safe criteria there is actually compliant with attainment standards. So actually, will these service changes support us to meet the ways of working that we would want to deliver? And the next three then are around financial sustainability, the workforce sustainability, and then we've got at the end the population health outcomes. So will these options support our population to be healthier? And then lastly, around the options and scoring. So Sarah will give a recap after the break before we go into the service presentations, but this is really to help understand the flow of what you're going to receive and how this all fits together when those services provide the presentation. So it will begin with a case for change. So why do we feel that we have to make these changes? What's the information that we're using to inform that? And more importantly, following that is why does this matter? So actually, what does that mean then for our staff? What does that mean for our patients? What will this do? We'll then have a recap of the options that were presented in the consultation. So that was the work from phase 2. And then the actual consultation findings, as well as the engagement feedback. We'll then share the alternative options that came through as a result of that work, and then the scoring of those options. So how they look when they're applied against those 16 criteria, what the options development group felt how they best met those criteria. And then we'll show the options that best meet potentially those criteria. So it's not limiting the discussion, but it's probably helping you to look in more detail at options that could do that job. And then we'll be looking back to hand over to you to have that discussion. So in those options, though, when we get down to that options for consideration, when we almost put that focus on there, it's worth noting that we've used the top scores from the option development group scoring. They don't always align with the consultation outputs. Some options, there is very clear alignment between what our public and staff felt in the consultation and what our option development group feel. Others, there is some difference. And where we talk about phasing, so we noted at the end of phase 2 that actually to deliver some of these options, we would need to work around identifying the finance or the workforce to deliver those. We said 2 to 4 years, and we said that through the consultation, but it's worth noting that 2 to 4 years may take longer to actually identify that. So it's a commitment to the idea, but not necessarily being able to make that firm commitment to delivering within the 2 to 4 years. We'd have to make sure that we can do that sustainably and safely. And then lastly, we also talk about a longer term, the 4+ years. So that's where some things we know there'll be a significant capital investment required, such as development hubs as proposed in some of the options, or potentially alignment with our longer term strategy of health in Mid and West Wales, where actually we wouldn't be looking to do that necessarily immediately, but it's where we've said previously we want to go. And then lastly, there's an overview of the options. Now, we appreciate this isn't very legible. We have shared this in other documents, but it's put here as a visual representation of where we've got to at today. So the first column there in green is actually what all the options have in common for each of the services. So you'll see there is some degree of commonality there. And then in the coloured boxes, those are the options that we went out and consulted on. So those are the ones that we spoke to our public and staff about. And then to the right of that, you'll see the options that came through as the alternative. So Ben mentioned earlier of the options today, 22 came from the public work. And actually you can see that for all the services apart from dermatology, we have alternatives to consider. There were alternatives for dermatology, but they didn't meet the hurdle criteria. But you can see that our public were quite heavily involved in presenting, putting forward ideas that we'll be discussing today.
Thank you, Alex.
So that concludes the first section, Chair.
Great, okay. Right, we're going to take a break now, but before we do, I just want to offer a short summation, I think, of what we've just heard. I feel confident, I'm hoping the board does as well, that the process we've engaged in, the consultation, has been rigorous. It feels to me quite dynamic, in as much as it's generated lots and lots of alternative suggestions. It's been genuinely undertaken, and it feels to have been an honest process. And I think the fact that we've got assurance that it's met the standard for engagement provides us with that reassurance as well. It's not just a process, it's an opportunity for us to reflect on the insight that it's generated in terms of thoughts and ideas, alternative suggestions, and just the sheer insight of our communities and what they can bring to the way in which we develop our services, which I think is deeply important. And as someone who engaged in a number of the consultation events, I personally found them enormously useful in terms of just understanding patient perspective. We think we understand it, but actually it's only when we're talking to people that we get an authentic, genuine, first-hand experience of what those services mean to people. It doesn't make our job any easier as a board. We have to manage a whole series of tensions here. Those tensions are the insight that has been developed and the concerns and the anxieties that communities have shared with us in terms of the changes that perhaps we would wish to make to some of these services. We have to balance that against our statutory responsibility to ensure that the services we are delivering meet the highest standard of healthcare. We cannot, as a board, knowingly and willingly accept the fact that our services are less than the very best that needs to be provided to the population of West Wales. We understand that sometimes it's not always possible to do that, but where we are empowered to take decisions that will deliver better services, then we are compelled to do so. We are compelled to do so. And I would hope over the next 2 days that we would reach that conclusion. My point is that there's an enormous tension in us thinking that through. The decision-making process is wrought with tension. Those tensions are largely around ensuring that we can work with the expectations and the anxieties and concerns of communities and continue to deliver safe, accessible, fair, kind and robust services. I suggest at this point we'll take a break for around 15 minutes and then we'll reconvene with the first service. Thank you. Great.
before we start, if anybody has got a mobile phone, can you move, it's really picking up the difference. Do you either put it on airplane mode or move it away from the phone?
Can you also make sure that when you're using a microphone, you pull that microphone towards you so we can all hear? No fighting over it, though.
Those speakers. Okay. Yeah. Yeah. Indeed. Diolch yn fawr pawb for coming back on time so that we can kick off the next session. I'm going to hand over to Lee to start the process.
Thank you, Chair. So we'll now move into the section looking at the individual services in a lot more detail, and we've got colleagues who have joined us from those services. So in the first instance, I'll hand over to Sarah to describe the order in which we're going to take the services, and then we'll move into emergency general surgery.
Great. Can I just ask that everybody introduces themselves before they speak?
So, Bwrdd, good morning. My name's Sarah Isaac, and I'm the clinical lead in the transformation.
Sarah, pull the microphone towards you.
Sorry, can you hear me now? Okay. Bwrdd, good morning. My name's Sarah Isaac, and I'm the clinical lead in the transformation programme office.
Great. Okay. Thank you for that. Sorry for the interference. I mean, what we are really keen to do is to ensure that those who are listening have a very clear experience. They can hear everything. But go ahead.
Okay. Thank you. So on this slide, we're setting out the order in which we'll take the board through the decision-making material today. First, we begin with the acute services, so emergency general surgery, critical care and stroke. These services are presented first because they have the highest clinical interdependencies and influence the configuration of subsequent services. Decisions here shape the feasibility and flow of options across the entire system. We then move into planned care, ophthalmology, orthopaedics, dermatology and urology. We look at how each option performs against the evaluation criteria, what people told us through consultation, and the operational considerations linked to sustainable delivery. Following that, we consider the diagnostic services, endoscopy and radiology. Diagnostics are critical enablers, and changes here directly affect both acute and planned care pathways, so it's important they follow sequentially. Finally, we look at the role of the main hospital sites. This brings together the interdependencies, the consultation feedback, and the strategic fit, helping the board consider the implications at system level before moving into decisions. So overall, this order is designed to support a logical flow, starting with the clinically interdependent services and ending with the whole system implications for the estate and site roles.
Okay, good morning. My name is Andrew Deans. I'm a consultant colorectal surgeon.
Andrew, pull the microphone towards you.
My name is Andrew Deans. I'm a consultant colorectal surgeon in Hywel Dda, based in Glangwili Hospital. I'm here with my service delivery manager, Caroline Lewis.
I'm Caroline Lewis. I'm the service delivery manager for general surgery, ENT and audiology services.
So, thank you, Mr. Chairman, for the opportunity today to come and discuss some of the challenges that we face in general surgery and hopefully allay some of the concerns around the proposals. I'll try and go through the slides as efficiently as possible so that we can have a maximum time for open discussion at the end. Before we go into the proposals in detail, I think it would be useful to touch on why we need to review the emergency general surgical service. There are two key drivers for this. Firstly is that currently we have 2 acute surgical takes in the south of the Health Board, and both surgical takes have very fragile consultant and middle grade rotas. Despite 2 recent consultant appointments to Glangwili, we still have fewer consultants on the on-call rota than we did 15 years ago. The situation in Withybush is even more fragile. For many years, there has been a reliance upon NHS and agency locums to maintain the rota. These come with a great cost pressure and variable quality and performance. We have recently had a consultant appointment to Withybush. That has reduced the requirement for an agency locum, but a 1 in 4 rota is still going to be a very precarious situation. The second key driver is that in the recovery from COVID, general surgery engaged with the GIRFT process. Okay. We engaged with the GIRFT process. One of the key recommendations from GIRFT is that the Health Board should have a single centre in the south of the Health Board performing emergency general surgery. They commented that both the Glangwili and the Withybush services are dealing with very small numbers, and by amalgamating the service, we would become a higher volume centre, and that inevitably drives quality and, most importantly, improves outcome for our patients. The final thing to mention is you'll see a lot of our options are very dependent upon SDECs. In the 2 years that the
Andrew,
SDEC
describe SDEC for the people who are listening.
It's an area, in this SDEC stands for same day emergency care. Since in the 2 years we've had an SDEC in Glangwili, it has had a very marked proven effect on patient flow through the emergency department. The model that we have in Glangwili is currently in the process of being scaled up to increase capacity, and is a model that could easily be rolled out to other sites. Next slide, please, Ben. So, in the initial process, 2 options were identified. We'll all be familiar with those. The key of option A is that this aligns us with the GIRFT recommendations of developing one high volume, high quality service. It would strengthen the on-call rota in Glangwili, and by having an SDEC in Withybush, it still means that a large number of the patients that would currently be presenting to Withybush will still be able to be seen and assessed locally. Option B is something that, as the group of consultants, is a least preferred option. It does not align us with the GIRFT recommendations. It keeps us having 2 rotas and does not address the fragility of the service. The original concept was that the surgery would be conducted on alternate sites on a week basis, but because Glangwili has certain services that are not provided within Withybush, there would need to be a 24/7 provision within Glangwili, with the emergency surgery being transferred to Withybush as appropriate. So I'll now hand over to Nicola.
Thanks so much, Andrew. So I'm now going to share with you what we heard from our population, our public, our staff during the consultation. This is going to be presented in a couple of different ways. So I'll start by sharing what we heard in terms of questionnaire responses, separating out where responses came from NHS employees. It's important to note here, when we say NHS employees, this could be members of staff in Hywel Dda, but it could also be other NHS employees across the system. And then how that's separated out with other individuals. Again, it's important to note here, there could be members of staff that chose not to identify as NHS employees and have therefore responded under the other individuals category. So in terms of responses to the questionnaire, you'll see from the slide that with our NHS employees, there was a preference for option B, whereas overall other individuals had a preference for option A. As Yvette mentioned earlier, the other important consideration is this is not a popular vote. So whilst it's important to note how different groupings had preferences on options, that should be considered as part of all of the information that's being presented today. So moving on to the next slide, again, this is around preference to options, but here the breakdown is linked to nearest hospital sites, as that draws further information for the board to consider around where someone is located in terms of nearest hospital site has impacted their preference on option. So here you can see that people living closest to Bronglais, Glangwili, Prince Philip Hospital, option A was the preference over option B, whereas people living closest to Withybush Hospital, option B was the preference over option A. So as a brief reminder, as Andrew just talked through, option A is where the service in the South Corridor would be brought together at Glangwili, whereas option B is that rotation between Glangwili and Withybush. So in terms of what else we heard during the consultation, this includes the conversations that we had and also the responses we received to the open questions within the questionnaire. Travel time and distance, once again, was a big theme when it came to emergency general surgery. Here, there was particular concern for respondents in and around Pembrokeshire, around ensuring timely access to emergency general surgery, should option A be the chosen option that is taken forward. In addition to travel time and distance, transfer time was another significant concern. And there were some respondents who told us they were worried that there wouldn't be sufficient resource in terms of ambulances to be able to transfer patients from one site to another, as well as concerns that on arrival there wouldn't be sufficient beds. In terms of that alternating service model, so that option B, there was some confusion raised from a public around not knowing if that was the chosen option for the service model moving forward, where those surgeries were happening on a weekly basis. Staff shortages were also raised as part of our conversations with our communities. And this was around concerns that actually this ongoing uncertainty for the service could have a knock-on impact in terms of being able to recruit and retain staff to the service because they don't know where that service may be provided in the future. Accessibility, as we heard in the cross-cutting themes, was also raised, linked to emergency general services, with limited confidence that mitigations would help ensure that services remained safe, concerned around capacity to transfer, as I mentioned earlier, and bed availability were also mentioned. And finally, one of the key themes that we heard linked to emergency general surgery was fear around erosion of services. So where we talked earlier around independencies of services with emergency general surgery, if the option was chosen to not retain part of that service at Withybush, what knock-on effect that might have on other services offered at Withybush, with particular concerns raised by residents in and around Pembrokeshire about how that might impact the A&E at that site. I'll hand back across to Andrew.
Thank you, Nicola. So during the consultation process, another two options became available for consideration. Option 155, as you can see, is exactly the same as option A, with all the benefits that that brings, but with an enhanced SDEC service within Bwrdd. As you'll see in a couple of slides' time, this is maybe something that doesn't need to happen straight away. Bwrdd numbers that they see on a daily basis are still relatively low, and therefore a dedicated surgical SDEC may not be required, but it may well be incorporated into a longer-term, bigger plan of having a general SDEC within Bwrdd Hospital. Option 222 is very much more of a option for the future. If the health board ever goes to a single site of general surgery, we would clearly need to have pathways to move the patients back to local hospitals for rehab, and to be undertaken closer to home. Whilst we're maybe not considering that at the moment, we certainly are learning some of the lessons for repatriation of patients who have travelled from the Withybush area into Glangwili, so that they can have their recovery and recuperation back in Withybush, closer to home and family.
And what lessons are we learning?
That if the patients need to travel to Glangwili for the emergency surgery, but once they're out of the immediate threat of their condition and well into their recovery, they can then go back to the Withybush site to complete their recovery.
Right.
So this slide shows the total scoring for the four main criteria groups, and it clearly shows that option A and option 155 scored first and second in all four of the groups, and therefore these are the options that is the surgical consultant body we believe should be what we are looking at predominantly. So as I mentioned earlier, option A can be implemented very quickly to bring us in line with GIRFT and develop the high volume surgical unit in Glangwili, and then over a period of a couple of years, the SDEC concept in bronchiolitis will then evolve. I would just like to touch on a couple of issues. No doubt in the next day you're going to hear an awful lot about travel and transfer of patients. The points I would make about general surgery, transfer and travel for the patients is through the SDEC and Withybush, we recognise that about 3/4 of the patients will actually be seen, treated and discharged from Withybush on an SDEC basis. So therefore the majority of patients that are currently seen locally will continue to be seen locally. Only the sickest of the patients will need to travel, and it has been well documented that patients do not mind travelling even very long distances if they know they're going to a centre that has better outcomes. We know also from various studies that travel and transfer is very safe, especially if there's an expert unit at the end of that transfer. For example, our own health board, Prince Philip does not have on-site surgery, so all the Llanelli patients have been travelling up to Carmarthen for at least 15 years. Telford and Shrewsbury Health Board have been through the GIRFT process, and they have amalgamated their acute surgical take onto one site, so patients from Telford all transfer to Shrewsbury. And historically, the Scottish aneurysm study showed that transfer of patients with abdominal aortic aneurysms had a much better outcome if they were transported to a vascular unit undertaking that sort of surgery on a regular basis. In terms of impact on WAST, I would hope that by developing pathways, we will be able to direct the appropriate patient to the right hospital. So at the GP referral point, the registrars receiving the referral will be able to identify which patient is likely to need admission, and that patient will go directly to Carmarthen rather than going to Withybush and then requiring it into hospital transfer. So I hope we can minimise the impact on WAST. In terms of dependency on the other services, both options A and 155 keep a surgical presence within Withybush. This allows us to continue seeing patients there, but also importantly continue to support the emergency department, critical care and the other acute specialties such as the acute medical take. It's important that we have an ongoing service on a daily basis in Carmarthen, because currently paediatrics, obstetrics and gynecology and trauma all come to Glangwili, and therefore we need to be able to support those services. So in summary, I think we've demonstrated that options A and 155 will bring about improvement in patient outcomes by creating a high volume acute unit in Carmarthen. It will allow us to develop robust and resilient rotors, and the model is a safe one. Thank you.
Thank you very much, Andrew. That was very helpful. Before I open it up to the board for questions or points of clarification, anything your colleagues want to add? Fine, I take that questions as no, you've heard it all and you're happy with that. It may be that you'll come back in if we need to clarify through questions at the board level. So fine. Phil, before we open it up.
It was just to clarify, there are a few words and acronyms which are familiar in NHS territory, which might not be to the public. So the two probably I think people have picked up is GIRFT and also takes, which I know what both mean, but I'll maybe let you explain, or Mark explain what they both are.
Mark.
So a surgical take is essentially where patients are taken into the hospital and reviewed by the specialist team, and then GIRFT is getting it right first time, which started out as an English programme to get it right first time for our patients in the delivery of hospital services. And it's a massive programme that we're very much engaged in Wales.
Great. Very helpful. Thank you very much. I'm going to open it up for questions from the board. I would remind the board we are not making a decision. That is not the purpose of today. All we're doing is deepening our understanding, strengthening our ability to be able to appreciate the circumstances here regarding this service and what the wider population have said in relation to the changes we're recommending. Sarah.
Thank you, Chair. Thank you, Andrew. It's just a question really about some of the options talk about strengthening our same-day emergency care. Could you explain what that would look like, please?
Yeah, so same-day emergency care is a concept where patients come into the hospital and are seen, investigated and treated on the same day. The vast majority of patients do not need to be admitted as an inpatient. The Withybush figures that they provided me with for last year showed they only had a 1 in 4 conversion rate to admission. So we would imagine that people would come into the SDEC area, and because our numbers are relatively small, we tend to combine an SDEC with a surgical assessment unit. Larger centres like Cardiff have separate areas, but we tend to have a sort of a multi-function area. That's how our with Glangwili area works. Patients who have sort of slightly less serious or more chronic conditions, such as the abdominal pains, maybe suggestive of gallstone disease, could be asked to take some painkillers at home and then be asked to attend the SDEC in the morning at 8 o'clock when it opens, and then could go and have their ultrasound scan, make a diagnosis, be given appropriate treatment and discharged.
So when we say we're looking to strengthen the SDEC, what's the change? What change is that from what we have currently? Sorry, I'm not quite clear on that.
So within Glangwili, it's just making it a larger area, so we can accommodate more patients, so that we can take more patients from the ED, and then if we are seeing more patients coming down from the Withybush area, we can accommodate them there. Currently, Withybush don't have a formal SDEC area for those patients to be assessed in, so we would be looking at creating a specific area for them.
Okay, that's great. Thank you.
I'm going to come to Alison and then Michael, and then Mark. Alison.
I'm asking this once, otherwise I'll ask it in every single proposal,
Okay.
and that relates to travel and transfer, given that this was such a significant issue in relation to the consultation across all services, and actually it's a significant issue on a day-to-day basis for people living in rural areas. I think it's reasonable to expect that there would be, rather than an individual response per service, a more strategic response that looks to set out how travel, transfer, accommodation, all of these things that make such a fundamental difference to people when they're looking to access services and where they might need to travel further. I can't see anywhere in the documentation that strategic response, or what conversations there's taken place with WAST in relation to ambulances as well as non-emergency patient transport services. So how is the public to be reassured that overall, across the whole programme, that the Health Board has got a strategic grip on that, and that whatever options is chosen will be aligned with that improvement in transfer and transport?
I think that's a very, very helpful challenge. I think you're right. There isn't in place yet a strategic overview of how those detriments and disadvantages would be overcome if we were to think about changing those services. I suspect there would be a conditionality between developing that and thinking about what we do in the future in relation to those services. You raise a very important point, and thank you for just raising it once. I dare say we will come back to it certainly tomorrow, and we will think about it throughout the day, but you make an important point. Michael. Ben, did you want to come back on that?
Yeah, it's just to add some value from programme assurance lens. Evaluation criteria 1.4 looked at impact on external services. It was considered through the strengths, weaknesses, opportunities assessment and was equally scored, as been shared with you for the options development group clinically led scoring. We had WAST, Welsh Ambulance Service Trust. We had a non-emergency patient transfer service, and we had the adult critical care transfer service support our phase 2 process, and they fed into those strengths, weaknesses, opportunity assessments, and they fed into the programme process. So they've been very active, though they might not be in the public domain, but they have been quite key in the formulation of the assessment and the evaluation criteria. So I just wanted to add that little bit of assurance.
Great, that hasn't quite translated into the strategy that I think you're talking about, but I think a good point, well made. Michael.
Thank you, Chair. I was interested in the rehabilitation closer to home point. I mean, is that something which can be fairly straightforwardly developed if that was the route of travel, direction of travel, or is that something which would be a big effort in itself, or is it something I say which could be easily, or not easily, is probably the wrong word, but could be developed if we were going down that route?
I think within the options A in 155, where patients are travelling to Carmarthen for emergency surgery, repatriation back to the Withybush site would be very straightforward. The plan would be to continue to have inpatient beds for surgery within Withybush, and moving patients back would be very straightforward. I think option 222 of having a formal rehab unit in Prince Philip is then something that would take an awful lot more organisation. But just simple repatriation to Withybush from Glangwili, I think, would be straightforward.
Thank you, Michael. Mark.
I just wanted to add a bit of context. So the surgical services in Withybush and Glangwili have always been interdependent, and more so the Withybush service on Glangwili, simply because of the size of the teams and the clinical expertise that exists in that larger team in Glangwili. So patients are currently and have always been transferred from Withybush to Glangwili for care because of that team. And I think, again, because of the differences in specialities, we will be able to reduce lengths of stay because you have quicker access to a specialist individual. Same-day emergency care will allow patients to be assessed, investigated, discharged and followed up, hopefully the same day, which will reduce the numbers of admissions. And with an enhanced service in Withybush, that will currently reduce the numbers to be admitted compared to what they are now. So the numbers of transfers, as Andrew described, into hospital transfers will be low. There's also been a significant change in surgical practice in the last few years in that we actually operate on a lot less people than we did historically. Even conditions like appendicitis, we manage that without an operation now, and therefore a lot less patients will need transfer to Glangwili for an operation.
Thank you, Mark. Very helpful. Colleagues, further questions or thoughts? Oh, sorry, Chantal, and then I'll come to Eleanor.
I just wanted to ask a question, or at least I wanted to have understanding around workforce constraints as part and parcel of this presentation. I think if I heard it right early on, you were saying that less staff. Okay. We have less staff than we did 20 years ago. So is that an issue with the fact that we can't recruit to that particular area? Or is there because something else has happened in between and that we will be able to recruit in order for us to be able to make good in terms of this, of the change that we're proposing?
Okay, thank you, Chantal. By the amalgamation of the take of the acute surgical service into Glangwili, we will actually be able to strengthen our on-call rota within Glangwili. The recent appointment to Withybush is a dual site appointment. It is accepted that the 3 current substantive and NHS locum consultants in Withybush would not be expected to form part of an on-call rota within Glengwili, but all new appointees are due to be appointed on a dual site basis and therefore will undertake emergency work on site in Glengwili. So we have appointed 1 person already. We're out to advert for a 2nd person. Historically, we've not been able to recruit to exclusively Withybush positions, but actually we've had a great deal of success recruiting into Glengwili. Last year, we appointed 2 upper GI surgeons, 1 for Glengwili, 1 for the dual site role, and a very good colorectal consultant. So,
Andrew, why do you think there's more success recruiting into Glengwili?
I think because Glengwili is seen as, I think geographically it's more desirable. A lot of people like to live out towards Swansea, and going to Withybush is perhaps a step too far for them. Also, the fact we are a larger unit, so for example, as colorectal surgeons, we still do all the cancers within Carmarthenshire. So I think the repertoire and the type of surgery that's done in Glengwili is more attractive than the slightly limited repertoire from Withybush.
Thank you for that. Lisa, do you want to come in on the workforce issue before we move to Eleanor?
Yes, please. So a general caveat, which will be for all of the services that we go through, we've only been able to undertake a certain level of workforce impact. And we've not been able to identify any therapy requirements in the models for here, but there are 2 of the options which would require significant additional workforce in a circa around 40 whole-time equivalents. So certainly 2 are deliverable in the shorter term. Others would need to be workforce planned.
Has that answered your question, Chantal?
Yes, thank you.
Great. Lee, did you want to come in on anything we've said before I come to Eleanor?
Well, I'll just make 1 point because it hasn't come up in the discussion. So I guess building on Andrew's points, but also in relation to then the quality of services we're able to provide. So the trend across the UK and within Wales has been for larger centres to specialise further into upper GI and lower GI. Mark and Andrew can explain that in more detail. But what that means is obviously is that surgical teams then can have 2 separate rotas aligned with their specialty interest, which is more appealing then for those individuals because they've obviously been trained in one particular area. But the second benefit from a patient perspective is obviously you then have experts who are dealing with those conditions day in, day out when you're presenting as an emergency. So this doesn't allow us to do this at this point, but it sets the foundations for the potential for us to develop in that direction in the long term, which is now becoming the standard across Wales and the UK.
Okay, thank you for clarifying that point. Eleanor, Alison, did you want to come back in? Great, Neil, you come in there.
Diolch, Cadeirydd. The one first direct question you asked already, Chair, which is about the ability to recruit into the twin sites. The second one, Leah started to touch on around the quality for the individual patient. I am fully supportive and fully understand people's concerns around transport, and it's important that as a board we develop into our strategy help and support in that. The question I have for Andrew and Caroline really, are you both persuaded that either of the 2 options suggested, A or the second one, would be better for the patient and give a better outcome for the patients that you treat and serve?
Before you answer that, can I, because I think sometimes there's a bit of a gap between process and experience. So I think it's possible as a clinician to describe a optimal process, but there's something about how patients experience that. And I want you to think about that in relation to how you might answer Eleanor's question.
I mean, I think certainly option A and option 155, by concentrating the patients requiring emergency surgery. And don't forget, these can be very complicated surgeries enables not just the consultant surgeons but the wider team to have a bigger experience, much better have people who are performing the surgery on a regular basis. By concentrating into one area, we'll find that the surgical middle grade rota becomes more experienced, the theatre staff become more experienced, the anaesthetic teams, critical care, are more used to looking after these potentially extremely sick patients. The other thing, of course, is that all of the elective colorectal surgery is being done either through Glengwilliam Prince Philip Hospital or up in John Gleis, and therefore the emergency surgery, colorectal side of emergency surgery, which often is more difficult than elective planned surgery, is being done by the people who are doing elective colorectal surgery on a day-to-day basis in their elective work, and therefore available to hopefully get a better outcome in the emergency setting. That also goes for the upper GI surgeons who currently are all based in Carmarthen.
Thank you. If you'll indulge me a moment, Chair. I'm trying to paint the picture for me and a layperson. So somebody who has to come in with complicated emergency surgery needs, you feel will get the best care by having the one team look after them, but then they could be transferred to recover nearer their community, so they are in a more familiar setting and their family could visit them in an easier way. So the picture for me is urgent treatment you recommend in one place, and then care nearer home.
Yes.
Thank you.
Okay, you needn't qualify that any further because we're short on time. So I'm just going to go to Alison. If you asked your question, I'm going to come to Neil at the same time and then answer them together. Yes, please.
Thank you. Looking for reassurance, really, for people who are naturally concerned about Withybush and the fear that it's death by 1,000 cats. If you take part of services out, then it makes the whole sustainability of that hospital under threat. Can you give us reassurance?
Yes,
in
I can.
relation to the options?
I hopefully can give you great reassurance. Today we're talking about emergency general surgery. So the fact that we're looking at enhanced aesthetic activity shows that we are committed to maintaining an emergency surgical presence within Withybush. The facilities that are freed up by not having emergency surgery within Withybush means that within the general surgical long-term plan, we are actually making plans to expand greatly the elective surgery that is undertaken within Withybush. Withybush have excellent theatre facilities, they have excellent frailty service and care over the elderly, and so we would be looking at doing a lot more of the complex high volume surgery within Withybush. So I would hope within a few years' time there'll be an awful lot more elective surgery being undertaken in Withybush.
Thank you.
Has that given you the assurance you were looking for, Alison? Thank you. Okay. Neil.
Thank you. Thank you. Very briefly, is this on or off here? That's...
Go ahead.
Good, thank you. Very briefly, because I think it's been answered to an extent, but it was around the options under consideration don't look at surgery. I just wondered whether it might be explained a little bit more detail what the challenge is around alternative weeks. I turned it off. Okay. Sorry, you would have thought I'd have worked this out by now. I do apologise. Very briefly, let me recap that. So I'm interested in coming to the preferred options, or the options under consideration rather. I'm interested in the challenges around the alternate weeks emergency general services being operated from 2 sites. I think it's been hinted at, but I wonder whether it could just be made a little bit more explicit. And I'm asking that question because of some of the regional variances from people who have responded to the consultation. Thank you.
So I think we've explained the benefit of having a larger unit in terms of having a resilient on-call rotor rather than continuing with two extremely fragile rotors. By having relatively low numbers going through both sites, that enhanced expertise is not developed. Elective colorectal surgery isn't done in Withybush, and therefore the surgeons down there would be their only major colorectal surgery would be in the emergency setting, which is much more difficult. And there will be a degree of confusion for people being referred in. So the primary care team would find it confusing which hospital they would be referring to. A couple of years ago, we did have an interim period where Withybush was covered alternate overnight by Glengwili and Drongleish. That was at a time when the rota was just unsustainable. There was great confusion of whether the patients were going to be sent up to Drongleish or across to Glengwili. And that created more angst than anything else.
Okay, thank you. I think you're demonstrating very well, Andrew, the fact that sometimes we complexify the situation thinking it's leading to better outcome, but actually it creates more opportunity for demand failure in that process because things go wrong. Inevitably, things go wrong. I'm going to, in the interest of wanting to make sure we cover all our services fairly and equitably over the course of the day, I'm going to close at this point. What I would like to ask actually is if the board, in its ruminations, has any other questions or thoughts. Perhaps they would be able to contact you between now and tomorrow to answer any potential questions, if that's the case. Because inevitably we've had a useful session now, but it may be as we reflect further, there's something else we would need to come back to you. That would be very helpful for us. Thank you, colleagues, Andrew, colleagues, for your presentation and for helping us understand exactly what some of these services will mean in terms of their changes. Nikki, thank you for representing the wider public in terms of their anxieties, concerns, and thoughts and views on this matter. At that point, I'm going to close the item. Thank you very much.
Thank you very much.
Great. Okay, just 1 minute break, and then we'll start the next one. Okay, can I now move us to our next service, which is critical care.
Can you hear me okay? Yeah, sounds like it.
Michael, introduce yourself.
Hello, my name is Michael Martin. I've recently been appointed as clinical director for critical care and anesthetics. I've not really been involved in the process because I've just recently been appointed, but I've got more than 20 years of experience as a critical care consultant, so I think I can give an opinion. Yeah. Why is the change necessary, which is our first slide. I'm not going to go through the individual points. Traditionally, critical care was provided by anaesthetists with a special interest in critical care. And they sort of were the troubleshooters and safety net for the whole hospital. And that's what the old model is based on. Since then, we've had a massive advancement in critical care medicine. In 2010, the Faculty for Intensive Care Medicine was founded. ever since then, we're basically going in the direction of having anaesthetists and intensivists. And we no longer have the general hospital anaesthetist that does everything. And this has led to big problems for the small hospitals, because these newly trained consultants, they want to work as an intensivist with all the standards of a modern intensive care unit, or as an anaesthetist. This all came to a head in Prince Philip when we had really significant problems in recruiting consultants and filling the consultant role in PPH. We also have the guidelines for the provision of intensive care medicine. We're now in the third version, which are significantly different from the traditional intensive care unit. So the standards have gone up massively. We are a lot more successful with that as well, in getting critically ill patients, well, to survive and have a good quality of life afterwards. But that comes with a huge investment and an increase in quality standards. To run an intensive care unit now, you need a trained intensivist in charge. So in a way, the consultant anaesthetist with a special interest is no longer good enough. You need allied health professionals, you need a dedicated pharmacist, dedicated physio, dedicated speech and language therapist. There's a much longer list than that. The bottom line is we're not able to provide that in 4 small units. So we cannot meet the standards and we cannot recruit, because the newly trained consultants that are coming out expect to work in a larger unit that meets the standards. So we're in a bit of a dilemma here, and that is the reason for change, really. So we need to be able to provide good quality intensive care, and that means a much higher standard than we had 15 years ago, and that's basically what our old model is based on. And we need to, and if we don't meet the standards, we won't be able to recruit. And more or less, that's the bottom line, and that's why we need to change.
Good morning, my name's Diane Knight. I'm the Service Delivery Manager for Critical Care. I thought I'd better just clarify for, I guess, our audience, and just a quick reminder on the levels of intensive care, because we're going to be talking about enhanced care, and I always get asked the question, so I thought I'd just start with that. So obviously the Faculty of Intensive Care Medicine, technically there are 5 levels of care now. Level 3 is obviously the most seriously ill patient. This patient would have their own nurse. A level 2 would be slightly less critical, but would be one of 2 patients assigned to a single nurse. The new level is 1.5, which is also known as enhanced care. These patients tend to be either a 1:3 or a 1:4 nurse-patient ratio, tend to be in a dedicated location, can be subspecialty, are not necessarily an intensive care unit, and are ward-based. And an example of that would be the surgical enhanced care unit currently on Ward 7 in Prince Philip, which was established in June 2022. Level 1 patients in our current location would be, they're practically wardable. So they're practically ready to go back to the ward. And a level 0 patient is definitely one who is already on a ward. So I just wanted to clarify that.
Did you say 5 levels?
Yeah, that's 5, but they're 3. So 0, 1, 1.5, 2,
okay,
3.
Fine.
Yeah.
Okay, right. Good.
That's why I thought I'd say it.
It was designed by doctors.
It's contradictory, isn't it, in the numbers? So obviously, in getting to our first 3 options, we did have a multidisciplinary team from all our critical care locations, consultant, SAS, nursing. We also had some allied health support as well in our discussions and decision-making. Obviously, a great deal of anaesthetists in one location generated a great deal of discussion, but we were able to refine down to 3 options in the end. Obviously, option A would be one where we would centralise pretty much everything into Glangwili Hospital, with Bronglice retaining its ICU, but with overseen probably from Glangwili. And we would look at enhanced care units then in Withybush and Prince Philip. We also would want to develop an enhanced care unit within Glangwili, because we've got 18 bed spaces in that location, and we figured that if we bring more patients in, what we would need to do is look at the enhanced care group, which is currently looked after in ICU in Glangwili. We would need to put them in a location.
Dan, just for clarification, enhanced care group is 1.5?
1.5, level 1.5, okay. Yes. So ideally, we would look to lift those out of the current ICU in Glangwili and put them into their own location. And those discussions have been ongoing with Glangwili site team, and they've got their aspirations of their own in that direction, which are already in play. Option B would leave intensive care units in Bronglice, Glangwili and Withybush, but with an enhanced care unit in Prince Philip. And then option C would be intensive care unit in Bronglice, Glangwili, with an intensive care unit in Prince Philip, where we would transfer the sickest patients, which is kind of contraindicated really, because if it's an intensive care unit, you should be able to look after level 3, 2 and 3. Withybush would have an intensive care unit. That's probably Nick.
Thanks so much, Diane. So we're now going to turn to what we heard from our public, so members of our community and staff during the consultation, linked to those options that Diane has just talked through with you all. So first slide, as we did with emergency general surgery, respondents is split across NHS employees who identified as NHS employees and also other individuals. So with the responses for critical care, option C was the preference across both of those groupings. So that is that option that retains those services at their nearest hospital sites, so ICUs across Bronglice, Withybush and Glangwili, as well as PPH, but with the sickest patients being transferred to Glangwili. Moving on to the next slide, as we did with emergency general surgery, this is broken down based on nearest hospital site. Again, across all acute hospital sites, respondents' preference was that option C, so retaining those ICUs at those acute hospital sites. Where there is a difference based on postcode, so nearest acute site, is with the second and the third preference. So for people living closest to Bronglice, Glangwili and Prince Philip Hospital, after option C, option A was the second preference and then option B. In contrast, at Withybush, after that first preference of option C, at Withybush, option B was that second preference, so obviously retaining that ICU unit at that site, and then option A. We'll then move across to what we heard in our conversations and in those open boxes to give a broader picture of what our communities told us. So patient transfers and travel times, again, were raised strongly linked to critical care services, and there were real concerns around the movement of critically ill patients across parts of our health board area. Critical care during the options, it talks around the adult critical care transfer service. Again, there was uncertainty about the role of this service and also whether there would be sufficient capacity to be able to move the patients should there be less intensive care units across our health board area. Staff shortages were also referenced, specifically linked to critical care, with concerns around the sustainability of staffing models and what was realistic given the current workforce pressures that exist across the service. Staff interdependencies were also raised, and critically here was around the importance of the wider multidisciplinary teams needed for critical care services, and how any changes to how this service is delivered across our health board area would take into account those broader teams. Service independencies were also referenced, so linking into stroke, which we'll be talking about next, but obviously emergency general surgery, as well as orthopaedics and emergency departments, and the risk of having less intensive care units across our health board area, and how that could potentially destabilise these pathways was something we heard from some of our respondents during the consultation process. And finally, around accessibility, and how often with accessibility it can have more impacts, and it can worsen people's ability to access services safely, was another theme that came across during the consultation. So I'll now hand back across to the team.
So following the public consultation, there were several options that were brought to the critical care team table. And through a process of elimination, we came down to one which we felt was a viable option, and that was option 246. In all fairness, 246 is a variant of option B. The change is quite subtle, really, in as much as that would be more looking at the workforce across the 4 locations and how that workforce was employed. So it's about peer support. It would be about potentially the introduction of telemedicine. It's also about how we might then cross-cover in order to work towards meeting the GPICS 3 guidelines. So this would be looking at things along the lines of GPICS has a whole area around rural intensive care provision, and there is a list of standards in there that they would be looking for us to do. So that's one that we thought was quite viable. Because it is something that cross-site working is something that we clearly are going to need to do going forward, as Mike alluded to in the conversation earlier on. Obviously, in the options appraisal, as we'd anticipated based on the discussions at the Task and Finish group, 246 and option B did in fact score the highest across all of the discussions. We had anticipated this. And as you can see, obviously, across the 4 principles, 246 scored the highest. Throughout all our discussions, when it's come to critical care, we've alluded to transport, transfer on a number of discussions, and as alluded to earlier on, it will be discussed across multiple portfolios today. Clearly, our challenge is not just about our patients, but it's also about our patients' families. And we do recognise that if we were to centralise ICU, there would be travelling for families. And how would we do with that? So again, we talked a great deal about transport. Where ACS is concerned, so the acute critically ill transfer service, as Ben alluded to, they were very much part of our discussions and came to our days. So they would recognise that they would need to expand their service in order for us to be able to facilitate some of the options. Clearly, there's an interdependence with emergency general surgery, and obviously, as you've already heard, the decisions that will be made on that will impact. Clearly, at the moment, we have no enhanced care unit at Withybush, therefore, emergency general surgery at the moment goes straight into ICU. Not in high numbers, I might add, but that's where it does go. So obviously there's an influence on that. There is an A&E department. I think if we looked at our numbers, and I appreciate I haven't looked at the recent numbers, but a portion of our admissions into intensive care do come directly from ED, and therefore the workload that's undertaken in ED, the type of patients that are going to ED, any kind of emergency surgery changes that might divert the workload would in theory impact on the volume of patients going into ICU, potentially. And obviously any change to critical care will have an impact potentially on the hospital function as a whole. At the moment, as Mike has also said, is that anaesthetics and intensive care are often the first port of call when there is a deteriorating patient. They are part of that stream. If there is a flow at the moment that a person meets a certain deterioration and is transferred somewhere else, then there is a pathway at the moment for that patient. And what would that mean if we change certain processes within critical care? Longer term?
It's my job. So, looking at what I understand the long-term strategy is with eventually having a big acute hospital in South Wales, it would obviously make sense to go to option A, so have a centralized unit there, and the other sites would no longer be sort of acute hospitals, and they would, if they actually have intensive care patients at all, they would need to be transferred. In the whole thing, one of the tricky bits obviously is what we need to provide safety, and patients cannot be disadvantaged because they end up in one of the peripheral hospitals. So that's one of the key considerations. This can be done in different ways, but obviously we are well aware of that, and we will ensure that this happens, right? But there's a lot of detail involved in that, and that cannot be part of this discussion, really.
Okay, I'm going to close it there, or at least your presentation. Thank you, Michael. Thank you, Diane. That was really helpful in terms of the kind of consultation, insights and views. Questions, comments? Bwrdd.
Diolch yn fawr, Cadeirydd. Chi gyd yn rhoi'ch clustau arno. Just a question sy'n gyda fi. Mae fe'n
question here. It's something that's on the paper,
opsiwn A byddech chi'n ffafrio, ond fel bwrdd i ni'n
board, and we make a decision tomorrow when we look at all
a
the
just
options.
edrych ar un o'r sylwadau gath i wneud.
That's one of the comments made. Do you have the capacity to provide any of those three options? What is your ambition? And if we look to the other ambitions as well, do you have the future capacity to provide those? And also, the estate, we all know that the estate is not in an ideal state. That needs improvement, and whichever improvement we would go for, would that be a feasibility?
Okay, so if I understood the question correct, it's about having enough space for a centralized unit. And we're quite fortunate in Glangwili that the unit was designed as a very big unit. So it's currently run as a 10-bedded unit. There are actually 16 or 17 physical bed spaces. So in terms of the space, we do have enough space. The other thing I would need to say that critical care in our organization is a lot of things that if you follow the guidelines, it shouldn't be doing. And it should be done by enhanced care of other specialties. I'm talking about things like non-invasive ventilation. We should technically have a respiratory unit doing that. We're talking about acute dialysis, which is something we do. So patients in renal failure, we have dialysis unit, but if somebody comes in as an emergency, the units cannot provide anything for them. So critical care has to do it. And which is also, according to our professional bodies, something we shouldn't be doing. So there's a huge capacity in a way to reduce our number of patients and focus on the really, really sick ones. But at the same time, we do have a lot of physical bed space available for a centralized unit. Not necessarily the staff, I must add.
Okay, thank you, Michael. Colleagues, other thoughts? Questions? Yes, please.
Thank you, Chair. Thank you, team. I just wanted to offer some information for the board and members of the public who may be watching. So we've heard some of the concerns from the team around workforce. For people that have read the papers, the term allied health professions is a collective term that refers to a group of professions often referred to as therapists. What we've done in Wales is we've tried to clarify who they are. In this situation, some of the allied health professions who would be in this service would often be physiotherapists, occupational therapists. There would be psychology. They would also be dietetic input, to name a few, including speech and language therapy, and our support workforce are quite integral to this agenda. My question, based on that information, is do the options that we've got as a board allow us to consolidate the expertise we've got, enabling us to have effective rehabilitation early in our patient's journey? Yeah.
I would say that's one of the points of centralization for us to be able to do that, because that is an area where we're really struggling to get enough expert staff, and this is also a highly specialized work in that area, and it's difficult to get really qualified staff. And just like everywhere, they need to see a certain number of patients to become good at this, right? And that is also a key consideration.
Thank you. Michael.
Thank you, Chair. And thanks, Michael and Diane, for that very helpful taking us through it. Just a point of clarification. So if I'm a patient and I'm poorly enough to be an ICU candidate, I must have had a pretty serious operation or be pretty seriously ill. So am I right? I'd be being treated by a very specialist team in that instance, i.e. in the acute setting. So I'm not going to be, am I, unlikely to be in the SDEC setting. I'm going to be in the more specialist acute setting if I'm going to be an ICU person straight after the initial treatment. Is that right? And then and following on from that, if I'm in ICU, where do I step down to after my ICU? Presumably, I don't suddenly just walk out the hospital after ICU. I'm stepped down to maybe enhanced level or a different level. So what happens? Do I stay in the ICU building in the same place, or do I get stepped down to
level zero?
home?
I think that's level. Yeah. I think that's your level 0, isn't it?
Or level 1.
Yeah.
Well, I'll try to take you through the journey. So you become critically ill. Let's say you're in Prince Philip Hospital, where we no longer have an intensive care unit. You get critically ill. Now we have pretty senior doctors there on call 24/7 that do work as senior doctors in Glangwili as well. So they sort of stay in touch with intensive care medicine. So they are part of the intensive care rota in the central unit. They would be, so your care would be discussed with the critical care consultant on call in Glangwili over the phone, and you would be then attended to by this also very senior doctor in Prince Philip, who would then stabilize everything that needs to be stabilized in terms of organ function and arrange a transfer to Glangwili. Hopefully you'll be better in a couple of days, or maybe it takes a bit longer. And if it was a surgical problem, you would probably then end up going to a surgical ward, and that would need to be decided by the parent team. If it was a medical problem, if let's say you were from the Prince Philip area, we would then transfer you back to the enhanced care unit, which is somewhere in between normal ward care and intensive care. So that sort of would be the plan.
Okay. Mark, did you want to come in and add anything to that?
No, I think Michael's covered it off, but it's not SDEC. SDEC patients will generally walk into the hospital and need tests and go home the same day. These patients are critically ill patients, yeah.
Other questions? Yes, please, Neil.
Thank you. It's a point of clarification, really, and just to help my understanding, there's two things. I wasn't quite sure that I was clear on what health board-wide meant in practical terms. And the second part is I'm struggling to reconcile how we've got to two options for consideration that kind of seem to be opposed to an extent. And the bit that I was really interested in your opening presentation around the case for change, around the intensivist and special interests, and which I guess plays to the long-term sustainability. So what I'm struggling with slightly is how we've come to 246 as an option, which scores very highly against sustainability, and how we've got to option A. So I guess it's a point of clarification around the health board wide and how we've come to those two options. Thank you.
I think there's the practicalities of where we are with the situation, and then there's the theory behind it. So in a way, if you ask me personally, I think, well, why should PPH be treated differently to Wittybush? Same size hospital, yeah, maybe a bit further away, but we have an acute problem in PPH, and sort of that is the compromise at the moment. But if you're talking about sustainability, because what we've got now is still the old model, like in Wittybush. It's not sustainable once these consultants retire. And the same is true for the middle grade, so the resident doctors who are actually looking after the patients. It's very difficult to replace them. So going forward, I really see us only having one unit. But what you always need to consider is what's happening around the units, because in small hospitals they need the support traditionally from the anaesthetist, critical care doctors, and if, let's say, having emergency surgery there or not has a massive impact on the needs for critical care, just as an example. So it's interconnected. So you have to, I cannot really give you a straight answer to that.
Thank you, Michael.
Yeah.
Thank you. That's been very helpful. I'm going to come to Alex, who might be able to add a bit more to that.
Yeah, so the services given the
Alex, pull the microphone to you.
Sorry. So what we've done as a programme is put forward these options for consideration at the end. Now, that doesn't mean they're the only options, that you've seen all the options. But what we've set out is, as the services described, that 246 is being presented as an option that could meet the implementation and the improvement phase. And then what we're suggesting is, in the longer term, we have our existing Healthy Mid and West Wales strategy and that clinical strategy that looks at fewer sites and what that could look like. Now, I think this is where it gets tricky in trying to manage 9 services and 190 options, through all this. When we did the options scoring on the day, we scored the options against the here and now. So in terms of safe and sustainable, it would arguably be a poorer scoring option to not have those services supporting sites if we have emergency departments there. So it would reflect as a poor option. What we didn't do is have a second scoring which showed a future state of fewer hospital sites, fewer medical takes where you wouldn't need those services. So that's why the scores are different. It doesn't necessarily mean it's not a good option, but I think what the score shows, it's not a good option for now because of those other interdependencies.
I think for me, and I think, Neil, you're getting to the nub of it, it feels to me you presented, Michael, a compelling argument for why the specialisation of these services means it's much more challenging for us to recruit to those roles. And yet the options in themselves, some of those under consideration, would not address that issue. And it feels to me that's unsustainable in the sense that they might have appeared as relatively sustainable, but they're not. They're not if actually this profession is changing and we're going to have increasing difficulties recruiting intensivists, as you've suggested, into this space. We've got to be mindful of that. So for me, I can see that gap there, and that's something we need to be thinking about. I'm going to come to Andrew. I think you want to add to that, or Mark, and then I'm going to come to Phil and Eleanor.
Yes, thanks, Chair. It was just to try and help a little bit, I think, with the question around the difference between Withybush and Prince Philip and in this model. I think we already ostensibly have a difference in the service model in Prince Philip Hospital compared to Withybush Hospital. that is the fact that Withybush has an emergency department, and so therefore largely undifferentiated medical take in terms of the criteria of patients that present there, whereas Prince Philip does not have an emergency department and has an acute medical assessment unit. So by definition, the nature of patients that are referred to Prince Philip are not necessarily requiring those highest levels of critical care. So I just wanted to try and help add that into the conversations, help understand why at the moment there is already that difference. Part of the reason the options for the next 2 to 4 years are presented in the way they are because we would, at this point in time, we still have, we would still be planning to have in the as a result of this conversation an emergency department in Withybush. We're not looking to change that at this point in this conversation because that's not something we've discussed anywhere. So that needed to be factored into what the outcome of this conversation and process would be.
Great, and for which we've not consulted anyway. Yep. I'm not going to come to you after all, okay, because we're short of time. Phil and then Eleanor.
Yeah, and I suppose Michael's really clearly outlined the challenges of, as you said, Neil, of providing the new expectations around critical care across 4 sites. Indeed, I think you're describing the challenges we would have across 3 sites, even 2 sites. You know, that is a challenge for us. And it was recognised back in 2018 when we agreed our strategy where we agreed that we would move to a 2-site model for critical care, but it was dependent on a new build. Now we don't have that. So it's a dilemma for us, but we do need to make as much advancement as we can in the critical care service. And I think that's the strong advice we're getting from our clinicians.
Okay, thank you. Eleanor.
Diolch, Cadeirydd. I'll be quick. In looking at these options, this board always takes decisions that are fair, sustainable, based on evidence. And after listening to our communities as well, what I'm hearing is this is a 2 to 4 year option that we will need to think about decision making tomorrow. But the longer term it's part of the journey that this consultation starts. The other thing, I just want to check my understanding. All of these options require an increased number of staff, I understand, to make it safe to continue. Is that am I correct in that?
Hard to say. Well, yes. If we're going to meet the guidelines, we need to increase levels of staff because we're not meeting the guidelines in many areas. Again, it's a bit difficult looking at an interim period where we just sort of have to provide a safe service and make sure no patient comes to harm, right? And then what is sustainable in the long term?
And I guess safe for now compared to what quality would really look like. Okay, I'll take the nodding as a yes.
Okay, I'm very conscious of time and we need to move on to stroke services. So Diane, thank you very much for your contribution to today's discussion. Thank you everybody in the room. Let's close this item and again I would ask if we have some questions during the course of the day or further thoughts that perhaps we can talk to you or the team or Irie about what those might mean for us as well. Thank you colleagues. Let's just take a 1-minute break and then we are going to move to stroke services. Right.
Pushing, which is, I get it completely. Yeah.
Okay, we're just waiting on Director of Planning, the Medical Director and the Chief Executive, so we better not kick off before they re-enter the room. Okay, too late. I'm going to kick off. They'll join us, I have no doubt, in a moment. Senthil, you're very welcome. Beth and I can see you're providing support as well. You're very welcome to join us this morning and to the meeting. Can I begin by asking you to present your initial thoughts and findings?
Thank you, Chair. Good morning, and thank you for the CEO, the respected members, and the exec team for being here. So, stroke, why the change is necessary? I will try and be swift. There is a context which everyone needs to hear, because the stroke has gone through a big transformation in the last 10 years. And at various levels, pre-hospital, acute treatment, rehabilitation phase, post-stroke care, etc. And this is because a lot of evidence which has come through. So, as a result of that, the standards are changing and they're evolving. The services are evolving, and we are not unique. Every health board in the country is going through reconfiguration of their stroke services to adapt to these modern day changes. How are we going to meet these standards? So the traditional one clinician, one geriatrician looking after all the stroke as well as other things in a DGH is not suitable anymore, because of the outcomes these standards are providing. So in the regional context on how we're going to meet that is the biggest challenge, and that's why stroke is in this clinical services plan. We have 4 units. None of our units meet the recommended staffing levels. A couple of units are run with one single clinician, and all the 4 units are run with one specialist nurse in each site. And hyperacute stroke unit is a level of staffing what the national direction of travel is telling us. This is staffing the unit to meet the first 72-hour care with the right amount of staff, so the outcome is much better. The evidence is there, and that's what exactly the Stroke Association is supporting as well. We do not have, as a result, with the current model, we do not have a 7-day cover, let alone consultants. We don't have any specialist nurse cover or therapy covers at all. We have very fantastic teams on all 4 sites going above and beyond, but this is not a sustainable service to meet the modern stroke care. And so that's where the change becomes inevitable. So all these standards are measured very strictly and wonderfully and brilliantly by the Stroke National Service Audit, and they provide results every month, so we can't hide behind the lack or not developing our services to meet the modern needs, because it's obvious for people to see. So we will have to keep up pace, otherwise we will be letting our patients down. So that's the need for the change, and I hope I explained that well. So we went through this clinical services plan, and with all the service leads and the group, the clinical leaders from the health board, it went through a rigorous process, and 2 options came out, option A and B. And option A was is where the 12-hourly units will be in Prince Philip Hospital with the Hospital, while Bronglais and Glangwilly become treat and transfer units. And option B, a bit more ambitious option, is a 24/7 hyperacute stroke unit level care in Prince Philip, with other units becoming treat and transfer, except for Withybush, where the patients will go back after the first 72-hour care. So those are the two options. Next slide to Nikki.
Thanks, Senthil. So in terms of what we heard from our communities and our staff, as with previous slides, I'll first do this by NHS employees where identified and then other individuals. So you can see from the graph here that option B was the preference of NHS employees, while option A was the preference of other individuals, although it is clearly important to note that there is very little in terms of those percentage differences. Where there is a starker contrast is when we move to responses to the questionnaire and the two options presented based on nearest hospital site. So you will see that for people living closest to Bronglais, Glangwili and Prince Philip, option B was preferred overall rather than option A, so having that one 24-hour centre. What is really important to note here, however, and you can see in that table, is that over 50% of the respondents living closest to Bronglais did not select a preference, and we were told during our engagement that is because they did not agree with either of the options being presented to them. For people living closest to Withybush, option A was overwhelmingly preferred over option B. And again, as a summary, that option B was obviously the retention of, that option A was the retention of a 12-hour stroke unit at Withybush, as well as a 12-hour stroke unit at Prince Philip Hospital. So moving across to what we heard in our conversations and during the open boxes in the questionnaire. One of the really strong things that we heard was around retention of services locally for stroke. We had, as all of you will be aware, Protect Bronglais Services had a petition of over 17,000 signatures, highlighting the strength of feeling locally around the retention of a stroke unit at Bronglais. As I touched upon in the previous slide, views varied significantly by locations, with people closest to Prince Philip being more supportive of options compared with those closest to Bronglais and Glangwili, whilst respondents from Withybush emphasised the need for a 24-hour stroke service local to their hospital site. Travel times and access under treat and transfer models was another key theme that we heard in responses linked to stroke services, and there was real concerns around travel to Llanelli and around whether the Welsh Ambulance Service had sufficient capacity in order to ensure timely transfer for patients, and how that could impact safety for patients. As well as that, we heard really strongly around accessibility for friends and family visiting stroke patients, and particularly where patients could be on the stroke ward for a considerable period of time. This theme came up across the health board, but in particular respondents closest to Bronglais talked about the lack of public transport enabling them to visit loved ones should the centre and the service be brought together at Prince Philip Hospital. In addition to that, there were questions around the ability to deliver and resource the service models that were presented in the public consultation, and the ability to have sufficient clinical workforce in place. Finally, one of the themes that we heard was linked to confusion around that treat and transfer model, and also a misunderstanding around the 12-hour service and how that compares to what the service and how it's running right now. I'll hand back across to Bethan and Senthil. Thank you.
Thank you, Nikki. So from the public consultation, two other options then were appraised and went through the hurdle criteria, which is option 106 and 210. Both are quite similar, except for option 210 is where we have the 24-hour stroke unit now in Glangwili, then working and create a regional stroke unit in conjunction with Morrison Hospital,
and Bronglice will keep a 12-hour unit in Bronglice. So therefore, Prince Philip and Withybush will become treat and transfer in 210. In 106, there will be 12-hour service in stroke and PH and Withybush and Bronglice, with then the treat and transfer will be Glangwili only, which means that in option 106, there will be 3 units, which, as we already said, is unsustainable, and 210 is the main stroke unit. The Hazu would be in Glangwili, keeping a 12-hour unit in Bronglice. Next slide. As you can see from the next slide, it's quite evident that option A was the most favoured option, closely followed by 106 and 210. All options have got strengths and weaknesses compared to the others, which I'm sure Sentinel now will go through the risks and benefits of the options.
So we went through the options through the stroke-specific task and finish group represented by all the 4 hospitals, the stroke practitioners, and this is the outcome of what the general feeling was. The option A, which is the 12-hour units in PPH and Withybush, it's deliverable within the time space we are looking at. The benefits means it will improve standards compared to what it is now. Of course, it's not the 24/7 hyperacute level standards, but it will be definitely better than the current standards, providing weekend support. The risk, of course, is Glangwili is not part of it, and which has the AAD where people turn up, walk in, and so there was a question raised whether that's the right option. And of course, there will be moving of therapists between sites, and there's always going to be those workforce challenges. Moving on to option 106, this came out after the public consultation, where we learned a lot about carers, patients' voice, and it was so important for us. And this is one of the options which looks attractive in the sense it's delivery-wise, as Bethan said, 3 units, providing that 3 hours per patient rehabilitation in 3 units. Are we still talking about coming down just by 1 unit? But benefits are, of course, getting patients closer to home after the acute phase, and the risk, again, as I already said, 3-unit model, and there is a caveat with, no, sorry, that's the different option. So those are the risks with this option. And finally, option 210, which is a futuristic and ambitious option, is the delivery of the option. It was felt could be done in a phased manner, but the time period will have to be worked out. Would be by bringing the services together. The benefits is obviously this is work towards the national lines of travel, which is developing hyperacute stroke unit. And option 210 also has Bronglice as providing 12-hour service 7 days a week. And the risks with that is whether we'll be able to get a sustainable medical route to do that. So that's a particular risk associated with 210 model. So then my other slide is, these are mostly the data regarding the patient transfer numbers. In option A, 106 and 210, the average of 8 patients per week could be impacted by these options in the way of traveling to the main unit. Units. In option A, this could impact average 3 patients per week attending Bronglice and 5 patients per week attending Glangwili. In 210, this would be 4 patients per week attending Withybush and Prince Philip Hospital.
Senthil, just tell us that again. Just share those figures with us again.
Sorry. So the patient transfers, option A, 106 and 210, it will impact 8 patients per week. To get these patients, moving them to the units proposed. In option A only, this
could impact average of 3 patients per week attending bronchitis and 5 patients per week attending Glangwili. And option A is a 12-hour unit in 2 sites, PPH and Withybush. So this will impact Glangwili and bronchitis. In option 210, this will be the main unit in Glangwili, and bronchitis will be the 12-hour unit, 7 days a week. This would impact 4 patients per week attending Withybush and Prince Philip Hospital in total. In the merged option, which is being considered of 106 and 210, an average of 11 patients per week could be impacted by these options. The advantages of considering this would be care closer to home for bronchitis, which would be 106, while also addressing the medical sustainability issues, while 210 would be the futuristic model of providing a 24/7 care, working towards it in a phased manner. Am I going the right pace, Chair?
Okay, yep, very helpful.
Interdependent services, national standards clearly have linkages between emergency departments. If you look at there is a mention of co-location with emergency department. Should it be a norm? We have clarified it, and there are examples quoted, one at Shelter, where they don't necessarily have to co-locate it, though it's ideal, because for obvious reasons, people turn up in A&E. So just to clarify that. We also know the other major interdependency, or if at all the mainstay of stroke care, would be therapists, allied health professionals. So those are the major interdependencies. Regional, while we are talking all this, there's a regional, national work going on. Conversations with Swansea. I haven't talked about the Mid Wales. There's a Mid Wales task and finish group discussing proposed changes. So that's my update so far. I'll hand over to Ben.
Sorry, Chair. Just hand it over. Could I hand over to Lee now to discuss another idea in reference to stroke?
Yeah, so thank you, Ben. Thank you, Senator. Thank you. So I think what you've heard through the description to date is, firstly, stroke is a very important service for us. There's a strong evidence base supporting centralisation of delivery of care that leads to better outcomes for patients. In our context, it presents us with quite a significant dilemma. We cover a very large geographical area. We inherit a position of 4 sites delivering that care, and therefore anything that we do comes with advantages and disadvantages, risks and benefits, and we're very conscious of that, and we've been trying to navigate through that as we go through the process. So you'll see from the options that have been presented, there are some particular challenges with each of them. So option A, from the point of view of delivering the most immediate improvement in patient care available to us, that scores very well, which is why it came out top of the options development group assessment, because we can implement it and it would have an impact. It does bring a couple of particular challenges with it, or a few challenges with it. One is obviously the geography and transport and travel point that we've talked about. Secondly, the alignment with the fact that our busiest emergency department is Glangwili Hospital, and that wouldn't have a stroke service. That's not a deal breaker, but it nonetheless is a novel arrangement. And thirdly, the strategic fit. Just to explain that point, we have already agreed a strategy where we would have a community hospital in Withybush, and we wouldn't, and it wouldn't have an emergency department. It wouldn't have a stroke service as a result of that. So therefore, when you connect up the option A proposal with the long-term strategic direction, we end up in a predicament where we may potentially then be moving to just one stroke unit, which would be Prince Philip by default, essentially, which geographically is very close to our border with Swansea, and that was obviously a theme that came up very often in our discussions. So that is a further challenge for us in terms of that strategic fit. We then had other options come through. 106, as has been described, has challenges. In effect, we would have 3 stroke facilities across our patch, which inevitably will be very difficult for us to staff, and therefore will be difficult for us to meet the standards. And then 210 is a similar issue in that we are concerned about whether we'd be able to deliver a 12-hour stroke service in Bronglais. That's obviously an issue we've been dealing with up to this point. So what we've tried to do on this final slide is try to support board with thinking about whether there are any other options that we could construct from the existing options that would best fit the challenges and the opportunities that we've got. So that's not to say this is the doesn't present any risks or is preferred in any way, but it is trying to draw on what we've heard from the consultation, the assessments that we've made of each of them, to help board think about where there may be some alternative ideas around stroke. So we wanted to share that with you because that might help the discussion, but it's in recognition of the fact that we know we have to deliver change to our stroke services, but any option that we come up with has some advantages and disadvantages, and therefore we need to fully consider all of those before we come to a final view on it. So, thank you, Chair.
Great, okay. Alwena, and then Alison.
Apologies. Are you going to speak in Welsh? Apologies, my microphone does not work. I just want to make a quick point here about some of the feedback that we've had concerning the Welsh language when it comes to stroke and patients who want to get better from this condition. We are aware that there's a concern here that there's about Welsh language provision, and we'll be taking this into consideration with the effect that when we assess the effect and when we're choosing an option. I just want to give some confirmation to our families that we've heard this feedback and we've added this to what was said earlier by Nikki. Thank you.
Alison.
Thanks. It's a question about the review of stroke services across Wales, and you mentioned earlier that all health boards are reviewing their stroke services. So the question from me, I suppose, is why is Hywel Dda looking to take a decision now when there are conversations taking place across Wales about the development of stroke services, and why can't it be done in a joined-up way rather than Hywel Dda, UHB going first, and then those conversations continuing?
Good question. Okay, I'm going to, before we seek an answer to that, I'm going to come to Rodri.
Right, diolch yn fawr.
Thank you very much.
Yeah, as was said earlier, I think the feeling, the 18,000 petition and the protest there has been a lot of, and I'm sure we've all had emails from about most of these different services. The biggest worry that's come through looking at the consultation and the responses was, firstly, the treat and transfer. Is that safe? Is it safe to move them after 72 hours? That is one question, and I'll just bring them all together now. And also, I think we have to remember about depends on, obviously there's options there regarding where the stroke, the four, at the moment there's 4 stroke units, and having them perhaps down at the south of the Hywel Dda area for those, because we have to look at those up the top, Tywyn, Meirionydd and all those. And I think this is where I think the equalities does come into it, because you look at some of the information, the literature here, Betsy Cadwaladr, I think they've said they're worried about the potential impacts of patient flows. There's quite a few things that could hinder a decision like this. But I think we also have to remember regarding those that have suffered stroke. Usually, and I know this is the same with any hospital, when the family come in and help to get these patients better. I just think the qualities for the families as well, travelling from perhaps Meirionydd down to Prince Philip, Withybush, whatever, kind of coming down there, that's really a 4 or 5 hour journey, and I think that also needs to be looked at. But a few questions I do have, and the Stroke Association has raised some concerns regarding this, regarding the proposal, and as you've said quite rightly, Alison, there are kind of different options, or the health boards are all looking at this across Wales, but should they be concerned, the Stroke Association concerned at the proposed new model of stroke? That's one question I had. And also, what is our mitigation if we are centralising everything down, perhaps down to the south of the health board? Where is our mitigation regarding transport? I know it's not just down to the health board regarding transport, the local authority. There's so many other people that also Welsh Government need to be a part of this. But until that is in place, it's to do any decision in any kind of organisation needs to have that mitigation in place. And we've heard about transport in the past, and we've heard about it in every one of these cases, really. But it's just a matter of, I think this is well, there's a lot of public unhappiness regarding it, and I just wanted to also ask about the option 210. That would be perhaps closer to the north-south divide, but I just wanted to have a bit more explanation regarding that. But just in general, regarding the Stroke Association concerns, and asking our clinician there regarding how safe it is to transport someone who's had had a stroke then within that 72 hours.
Okay, a comprehensive view there. I think before we come to Senthil, you are eloquently kind of describing that enormous tension between wanting to deliver services to the highest possible standard and a benchmark against which we should be delivering our services, and at the same time not disadvantaging our communities in terms of all the support that patients need to receive from their carers and their families, and the transportation challenges are doing that. I think that it feels to me that is an enormous dilemma that somehow we need to try and navigate our way through in this space. And it will mean, as you quite rightly point out, Bwrdd, that a single decision will be contingent on so many other things happening inside this space to make it work. But Senthil, come back on that.
Thank you, Chair, and thanks for the question. I wish we were never in this position. Unfortunately, we are. And, Betsy and us and Powys, we are the ones with these geographical challenges. We have to face this. And I'll quickly answer yours as well, because you said about every single health board, Cardiff and Vale, Aneurin, Bevan, Cwmtaf, Swansea, are lucky to have their one unit. So they were all somehow reconfigured over a period of time, starting from 2019. Getting into one unit, and then they're working towards HASIA. So it tells, so they're lucky, they don't have a geographical challenge, but we do. And if you look at the quality statement for stroke, which came 2 weeks ago, it's talking about safe, timely, effective care, but also equitable and patient-centered. And this is where the issue is. How do we mitigate the risk of, while reaching the standards? I don't want any north-south divide. It disheartens me as a clinician. The clinical recommendation is we need to work towards HASIA and mitigate the risk by getting them closer to home as soon as possible. And this is where the board will be making those decisions. All I can say is what is clinically the best for these patients. Very quickly, is it safe? It's already proven in a machine, the hyperacute stroke units, and treat and transfer. I would give an example of Yorkshire, North Yorkshire in particular. I will give a specific example of Scarborough, where the travel distance from Scarborough to the York Hospital is 1 hour and 5 minutes. And they treat and transfer, not just in Scarborough. It happens in Airedale, Harrogate, and North Allerton. All these patients between North and South Yorkshire are going to York, Barnsley Hospital, St Leeds Hospital Trust. So treat and transfer, we already do treat and transfers. We treat and transfer. People opt to thrombolysis for thrombectomy centers. Treat and transfer is not unique to stroke only. A lot of time-dependent emergencies, burst aneurysms and all, we stabilize the patient and we get them to the right unit. And we know the evidence, when they're in the right unit under the right specialist who thinks in a stroke way, then you get the right outcome, because it's not just about someone who had a stroke, it's about preventing stroke again happening. Recurrent stroke is the biggest risk in these people. So quick investigations, preventing all this can't be ignored, and we can't let just, and so we just have to look for mitigation. So I'm saying, thank you.
Thank you, Sento. Irie.
Diolch, Cadeirydd.
Sure.
As Sentinel has pointed out, already occurs in stroke, and a lot of the patients are transferred to Bristol or Cardiff for thrombectomy services, and that's been going on for the last 3-4 years. So there's a safe transport mechanism for acute stroke. I'm a cardiologist, so that's something that is already done throughout the whole of Hywel Dda, is transferring the patient to the centre of excellence where those upfront decisions and treatments can be delivered safely so that the patient outcomes are much better. I understand the concerns of the patients of Ceredigion and Meironiaeth. Stroke is something that happens to generally older people, and their relatives are understandably concerned about visiting. And it also has a very long tail, the rehabilitation tail. And so I think looking at stroke, we need to take those things into consideration. The acute care maybe can be separated from the rehabilitation care, and looking at the merged options may be something that does deliver both aspects of the acute care and the longer rehabilitation care, but it's something to consider.
Thank you, very helpful. So there's 3 people want to come in. Nikki, I'm going to come to you, Alison, and then I'll come to James.
Thanks so much, Neil. So the point I was just going to raise, and we touched upon it a bit earlier, was linked to that option 210, which is quite different in terms of where the service could be provided if that option was one that the board decided they wanted to pursue further, because the proposed locations of the stroke units would be at different sites to the ones that we consulted on in both option A and option B. We would need to go back out to further engagement with our communities to understand what could be the impacts, if that was the future service model for stroke services across our health boards, to understand that further. And with the merged option that Lee talked through at the end, again, there would be a need there for further engagement with our communities and obviously further work internally to ensure that that option was tested in the same way as we tested the consulted options and the alternate options that we received during the consultation. So it was just to raise that point. Thanks, Chair.
Thank you, Nikki. Alison.
Just to reaffirm again, that in terms of the affected population, which is obviously beyond Ceredigion, we've heard such a lot from people in Powys and parts served by Betic Hydwalodus, so reaffirming Rodri's point, really. And then the other concern, obviously, that people have who rely on services from bronchiolitis that take a service away, and it affects the overall sustainability of what people see as fundamental hospital as a key part of their overall health care. So there are continued concerns around that too, as you know. And then the final one for me is around that rehabilitation. And has there been consideration in terms of any of the options of, or certainly option 210, of having a rehabilitation unit as well in Bronglais, for example?
Great, thank you. So I think you're echoing some of those concerns that Nikki's identified in terms of what the local population, where the concerns lie in relation to this, and we absolutely appreciate those challenges. And also, I understand the impact where people think we're taking a service away although I suspect we're probably introducing more things in there and potentially could do in the future. But I know that people think their hospital is growing smaller as a consequence of these changes, and that's how, and we have to respect that fact, that that's how people feel in these circumstances. I'm going to come to James, and then I'm going to come to Michael. But is there anything you wanted to say in relation to this issue?
Yes.
Okay.
Should I start then? Or?
Yes, please,
Yeah.
Diana.
Thank you. I did want to bring at the other end of the stroke services. So we're talking that, yes, which I completely agree, and the service will look at the rehabilitation, how we can bring that closer to home, because the acute care, we're clearly hearing that centralization offers a better, overall, more equitable service rather than having maybe more inferior services just because of the geography. So the other end is the prevention. And I would want to ask and maybe assure our board, but also our public, that what we're going to do about the prevention, considering that over 80%, most of the literature, if you standardize for age, maybe about 70% of stroke cases are preventable. And some of them are really immediately preventable with good management of hypertension, with early detection of atrial fibrillation. So if we can consider in the due diligence process of how we take the consideration, how we bring the decision, and we take the decision of how we're going to strengthen the elements of prevention in our community, how we're going to bring that community delivery. There are various forms, as Cynthia, you've alluded to, there are various forms of the services with community workforce that can help our population prevent stroke. And we are embedding the 24/7 model for prevention. I've invited the service to look at how we're going to shift that into the preventative care more. I think those would help us deliberations. Diolch. Thank you.
I think you make a really important point. We would not want anybody to have a stroke in the first place. And obviously what we're thinking about is the consequence of individuals having a stroke. And more work, again, back to that primary community service intervention, more work in that space would help to reduce those numbers even further that I think Senthil's presented us with. Yes, please, James, and then Michael.
Diolch, Chair. I just realised I was channeling my inner Director of Public Health. Get back on?
You were on.
So the point I was going to make was that the stroke pathway nationally, I wanted to respond to Alison's point earlier, which was, could we possibly wait? From a national programme perspective, we have been waiting since 2023 for a position, and more recent conversations, it feels like we're undertaking another benchmarking exercise. And I think at this stage where the team and I have been discussing the options, I think there's something around our population waited long enough to get some of the basic standards of stroke care. So I think that was part of the emphasis, Alison. The next part was we cannot underestimate that the acute part of this pathway is 1/7 of the patient's journey. And it's such a small part, but it's really important. And the bit before it is about prevention, as Diana alluded to. And the second part, the latter part of that pathway is all about rehabilitation to the best quality of life you could possibly experience. So what I wanted to just ask and get clarification from Senthil and Bethan was, does a model, almost a two-stage model, allow us to do that? So what I really mean is, we've waited a long period of time for a national position. Do we take a two-stage approach in terms of consolidating the expertise within our services to level up for our population's health, give them the best opportunity to be rehabilitated in a place that's as local as possible, whilst we're getting that position from a North Wales perspective? And I wonder if that ties into the option that's been proposed, Chair.
Thank you, James. Senthil, before I ask you to come back, and in the interest of time, I'm going to come to Michael.
Thank you, Chair. Yeah, I just wanted, again, focusing on the option with treat and transfer and rehabilitation of bronchitis. So when is a stroke unit not a stroke unit is my question, because that scenario in bronchitis doesn't have the acute bit, does it? See, so, but you're saying it's still a stroke unit. So what is the kind of characteristic of making that a stroke unit? That's what I want to understand, because without the acute bit, it doesn't feel maybe like it's a unit, but it is a unit. So enlighten me on that. So.
Sento, yes, please.
Thank you, Chair. Thanks for the question. Stroke doesn't finish after 3 days. This is the hyperacute phase, and after that comes the acute phase. And we know by data, this is the period where the high risk of aspiration pneumonias and rebleeding or restroking. So this high risk is there. So you still need that clinical presence there while the rehab is ongoing. So that's why it still falls into the acute remit until the clinician decides this is not acute anymore, this is purely rehab. So that's the answer to that question. Very quickly touch on Alison and what James was asking. And the new standards are already there. In the old standards, even in the last year, we were scoring the best between A and E. It was a C in Withybush, and the rest were D, all the units. Now, the current new standards, consistently in the last year, 4 units are scoring a D and 1 is scoring a E. And that's not something we can sit and wait on. We need to, this is a good start. And if we start this now, this is working towards it. So that's the point I want to make.
Thank you. I think you're adding to James's case for a compelling, urgent response to the situation we find ourselves in now. Okay, I'm conscious we've taken more time than we originally allotted for this, but it feels to me a really important conversation. When we think about this in totality, perhaps, Phil, you may want to make a comment before we close. It seems to me there's lots and lots of open-ended issues we need to think hard about when we try to move forward in a way that will help both meet the standards, as you've indicated, because as a board, statutorily, we cannot countenance the fact we are delivering suboptimal standards, especially if there's a pathway that will allow us to move towards delivering them. It's not acceptable for us as a board to operate in that way. At the same time, we do need to listen to the voice of the public in relation to any disadvantage or detriment that's going to cause, because actually it will impact upon the poorest, most vulnerable members of our communities. And that's not something we would want to happen either. So how we navigate a pathway through this will be how we manage to reconcile some of those tensions and difficulties that we can see in the future, whilst making sure we deliver against our statutory responsibility as a board. Phil.
Yeah, diolch Cadeirydd. So my point was to respond really to Rodri's point about the concerns of Mid Wales and also the petition that we received and the concerns that we've seen around particularly Bronglais Hospital. I think stroke services have changed, as Sentinel has said, the expectations around stroke services have changed radically over the last even 5 years, but certainly the last 10 years. And it has moved from what was considered a very general service that every hospital should have to a service that's highly specialised now and requires really intensive input for that period just after you have your thrombolysis. And so at the moment, our population isn't benefiting from that highly specialist service. So I agree with others that it's difficult for us to wait for a national stroke programme. We will need to take heed of that when it reaches a conclusion. But at the moment, our population doesn't get the advantage of that much more specialist service. But it's not the sort of service that you would expect in every single general hospital now. And therefore, it doesn't affect the integrity of all of the other hospital services.
Okay, thank you, Phil. I'm going to close this session. Sentinel, I would ask if we have other questions over the course of the next the rest of today or early tomorrow, that we are in a position to come back to you to seek clarification on anything you might have said this morning, or the team that you're currently working with at the current time. Thank you for your input. Thank you, board. I suggest we reflect further on this, hearing all the messages that we've heard in terms of what potentially we might consider tomorrow when we make our decision. Let's break now for 30 minutes to take some refreshment, and then we'll begin our next session at 10 past 1. Thank you. Good afternoon, colleagues. Thank you for coming back so promptly. I'm intent that we should move forward straight away. We're currently running about 20 minutes late, which we'll try and catch up on over the course of the afternoon. But let's turn to ophthalmology.
Thank you. Thank you. So my name is Victoria Kopak. I'm the Service Delivery Manager for Ophthalmology. Just to note today that I would have had a Senior Nurse Manager here, but unfortunately she can't make this meeting today. But just to clarify that my background is nursing, so hopefully I'll endeavour to answer some of your clinical questions if there are any today. So just to open then on the challenges of ophthalmology, we have significant workforce pressures and national consultant shortages. Many of our consultants are working single-handedly in various subspecialties with no support when they're on annual leave or off sick. So that leaves gaps in our service. We have ongoing staff shortages and retention difficulties, and we frequently have rota gaps, which we are filling with our own staff doing additional duty hours, which obviously comes at additional cost. So capacity remains a key concern for us in ophthalmology, with challenges with the workforce. And we have been working with our regional colleagues in Swansea Bay to strengthen the service, but we still need a lot of sort of change in the service to make it viable. So without making changes to our service, we do feel that our patients are at risk of irreversible sight loss, and we have many patients that demand some support in the service that we just can't support them as regularly as we would like to. So that's the challenge that we have. We do have patients that need regular eye injections. Those patients need to come into the service every 4 to 6 weeks or so, and we want to be able to provide timely care for these patients because they are the cohort of patients at risk of irreversible sight loss. And we don't want patients waiting longer than they have to for operations. So we want to provide the best care possible, really, and that's why we've been working on this clinical services plan to look at how we could improve the service and make it more viable. We are currently working out of 8 sites, which is very challenging. Often we're sending doctors and nurses across site, and they're often working without consultant oversight. So part of what we're trying to do is reduce the amount of sites that we're delivering out of so that our structure is better and that our junior doctors and nursing staff are working under consultants in order to develop and in order to be able to retain our staff. That will also help with patient delivery, because then we'll be seeing patients who are seen by doctors that have got a senior colleague there to refer to, and that will in turn reduce patient visits. Whereas if they're seeing a junior colleague with no consultant oversight, then often they have to be brought back to be seen by a consultant at that stage of their consultation or treatment. So that will bring efficiencies by reducing the amount of sites and making a much more robust service. So I'm going on to the options. The first round of options we had was on option A, B and C. And you can see from the options on the screen that from what we're running currently, option A is proposing to take the service out of Bwrdd Hospital. Is proposing to take the service out of Prince Philip Hospital, and is proposing that in Amman Valley we do cataracts only but not eye injections. So that's the difference with option A. Option B is removing the service from Glangwili. In Prince Philip, we would be introducing day cases and emergency eye care. And it's important to note there that there's no 24-hour A&E, so that would be potentially an issue, and there's no paediatric service which would tie in with ophthalmology, because we obviously see children in our emergency eye care services, so not having any paediatrics on site would potentially be a problem. In option B, we have diagnostics and outpatient injections in Amman Valley, but not day cases, and there is a proposal for a Pembrokeshire site to be confirmed. In option C, then, the difference is from our current services that there would be no service in Prince Philip Hospital. Amman Valley would be diagnostic outpatient eye injections, but not day cases. So it is important to note before we move on that our service has continued to develop in the last 2 years since we've commenced this plan, and we are now moving to a space where we'll be delivering eye injections and cataract surgery in Amman Valley Hospital. So moving on to some of the other options that we've got on the table to discuss today, I'd like just for the board to consider that we've grown in that space, and we would like to continue to deliver both out of Amman Valley, because that's a change to our service since we commenced here. So in all of the options proposed, it's either eye injections or cataracts, but we are currently doing eye injections and cataracts out of Amman Valley. I also wanted to point out, before we move on, that in all our options, we continue with our delivery out of Cardigan Integrated Care Centre, and we would be continuing with our delivery out of North Road Eye Clinic. So although we're proposing moving out of Bwrdd Hospital, that is cataract surgery only. The main delivery of outpatients and intravitreal injections would continue in North Road Eye Clinic in Aberystwyth, so we would still have that facility to be able to deliver to our Ceredigion and Powys population. So just to note. So I'm going to hand over to Nicola.
Thanks so much, Vicky. So as we've done with previous services, I'm now going to run through what we heard during our public consultation. So as you can see from the first slide, again, this is broken down by those who identified as NHS employees, as well as other individuals. I'm aware that some people may have joined the live streaming and not listened to this morning's session. So just to point out that with those other individuals, some of them may be employees of the NHS, but have chosen not to identify themselves as that when completing the questionnaire. And when we talk about NHS employees, that doesn't necessarily mean just employees of Hywel Dda, it could be of any of the health boards. So in terms of what we heard in response to ophthalmology, for both NHS employees as well as the other individual groupings, option B was the preference, followed by option D. Where there was a difference was for NHS employees, that was then followed by option A, preferred over option C, whereas for the other respondents, there wasn't very much difference between option A and option C. As we move into how that differed based on the postcodes of the respondents, there was no consensus between nearest hospital sites and ranking of preferences between options, as we have seen with other services. The preferred option for people living near Bwrdd Hospital was the option that retained that service. And then for patients living, sorry, just give me just 2 seconds. I've just skipped across a few slides, so please bear with me whilst I find that. So if we could just go to, Ben, do you mind just coming back one slide for me on ophthalmology? So for those living closest to Bronglice Hospital, option C was the preferred over B, then option A. For people living closest to Glangwili and Withybush Hospital, option A was the preference over option C, then option B. And then coming down to Prince Philip Hospital, option B was preferred over option A, then option C. Next slide. So when we look at the broader views of what we heard during the consultation, once again, travel times and distance were raised for ophthalmology services. Here there was increased concerns, particularly because of the nature of the service, around longer travel times for patients, and their abilities to be able to travel after treatment was something that we heard across our health board area. In terms of suggested mitigations, there was some proposals from some respondents around subsidised travel, also ensuring that someone was able to come with those patients when they are using subsidised transport, and that again linked to their ability to be able to navigate around the site following treatment. We heard mixed views when we talked about extended hours of the service. So for some, there was in principle support for extending hours, particularly where those individuals were still in work. In contrast, for others, there was concerns that potentially for our older population, travelling later in the evening or during darkness could be a problem, as well as challenges around access to public transport was something that was also raised during our engagement. There was mixed views in terms of how community clinics could be utilised. Some felt that that meant there could be more care closer to home, which was seen as being really important, whilst others were concerned about the facilities available at community sites and if we be able to deliver the same standards at those community hubs as we could in other sites. In terms of bringing the service together at a single site, some respondents saw the potential benefits of that in terms of the quality of care that would be received, efficiencies in terms of the number of people that could be seen in sessions, but there were also some strong concerns about where sites would be located and impacts of travel and transport, again, based on that point. I'll hand back across to Vicky.
Thank you. So just before I move on then to the alternate options, just to make it clear to the board today that we've given great consideration to travel time for patients with ophthalmology, and we've ensured that with all proposals we intravitreal injections in every county, and that we've kept our community sites. The only one proposed to be removed was Aberyron, but we would still have North Road Eye Clinic in Aberystwyth. We would still have Cardigan Integrated Care Centre as well in Ceredigion, and we would still remain in Amman Valley in Carmarthenshire. So just to make you aware of that. The proposal for potentially moving eye operations out of Bronglice Hospital is because we do very little eye operations there. Most of our Ceredigion and Powys patients already travel to have eye operations, and that is a one-off travel. So
Marta, can you give us some idea of quantum?
Sorry?
How many?
How
when
many?
You say you do very little.
Yes, yes, of course. I think in our data in here, it's around about 11 operations per week, and we obviously need a lot more than that for that population. So those patients are already travelling to our Glangwili site and or to further afield for outsourcing, which is based in Swansea. So the impact of that is quite small in terms of what we're already expecting of our patients in terms of travel. But what we were trying to do within the service was ensure that the regular appointments for our patients are close to home, and that one-off operation, or obviously if you needed a second eye, we are doing bilateral cataract surgery now, but if you needed to travel for your second eye, those are one-off travel commitments for the patients, and that their regular appointments are close to home, because obviously intravitreal injections are 4 to 6 weekly, so we've made sure that we keep those close to patients' home. So moving on to alternate options, we've got option 95, which is the same as option A. This option is suggested for extended hours within the service. And again, in this option, it is calling out day cases in Amman Valley, but not outpatient eye injections. And obviously, as I've already pointed out, we've moved on from that within the service currently. The extended hours would potentially be a problem for the service. We struggle with the team that we've got currently within the service to cover all of our 9 to 5 work and our emergency eye care service. So in order to extend hours, that would require a lot more staff and a lot more sort of commitment to be able to do that. So that could propose a problem. And as Nicola pointed out, some of our patients did raise concerns about having to travel in the dark, driving in the dark because of their poor eyesight, or trying to get transport out of hours, which would be another challenge. Option 99 then is the same as option A, but in this option we are including Amman Valley cataracts and eye injections, so that aligns with what we're doing currently. Option 167 is the same as option A, but that is proposing an optometry hub in Bwrdd. And again, not having day cases, having day cases, but not having eye injections in Amman Valley, so either or. With the optometry hub, that would potentially be a challenge because we don't have the optometrist workforce to be able to deliver that out of Bwrdd, so just to make that point. Then we move on to option 173, which is the same as option C, except this is diagnostic outpatient eye injections, but not day cases in Amman Valley, and a diagnostic hub in Bwrdd. This would work for us as a service potentially, because a diagnostic hub could be run by technicians as opposed to the previous suggestion, which would be run by optometrists. So the fact that it would potentially be run by technicians to do patients' tests, and then we could have a remote consultant to review those tests that are undertaken. So that the diagnostic hub in Bwrdd would potentially work for us as a service, and we do have facilities there and equipment there to be able to undertake that. Option 227 is the same as option A, but again, that's around extended hours, and again, that is Amman Valley doing cataracts but not doing eye injections. And then option 263 is the same as option B, again with extended hours. Emergency eye care moving to Prince Philip, and day cases moving to Prince Philip. And I previously raised with option B that we don't have that paediatric cover and we don't have that 24-hour A&E in Prince Philip. Again, it proposes a Pembrokeshire site to be confirmed. And diagnostic outpatient injections, but not day case cataracts. So we did have concerns around extended hours, which I've already mentioned. So I'll move on to the next slide, please. Thank you. So within our clinically led options appraisal, option 99, which is a variant of option A, scored the highest. We had option A then scoring the second highest, and option C third. We then had option 173 which is an alternate option, and that gives the option to the board of retaining a service in Bronglais Hospital for cataract delivery. Option 99 scored highest overall for the 4 domains. So I'm just going to go into a bit more detail about the 2 options, the 2 alternate options.
Vicky, I'm conscious of time, so
Sorry.
If we could make it really brief so that we can give the board the
yes,
opportunity to ask some
absolutely.
questions.
Sorry. Thank you very much. I'm just scanning as to what I can pick out.
It's okay. It's okay.
So I've already mentioned then that option 99, we've got efficiency gains there. It doesn't impact North Road, and that the benefit of that is I need to call out Orthopaedics, because obviously if we were to move the minimal cataracts out of Bronglais Hospital and absorb those elsewhere in the health board, then the orthopaedic service could potentially utilise those theatres with a laminar flow facilities to meet their British Orthopaedic Association standards. So that's an important point for option 99. But the alternate option, which is 173, we feel that the idea of a hub is a good one in Aberaeron, and I would suggest to the board, if we're considering either option, that we would look to combine keeping eye injections and cataracts in Amman Valley, both of those, because that's what we're currently doing, and we can grow the service by doing that, and that we do consider that hub in Aberaeron, which would again give us flexibility for the future growth of the service. So I'll move quickly on from that, and I think that's probably everything that I would need to say to give you time for questions.
Great, okay. Thank you very much. Colleagues, thoughts, questions? Yes, please, Neil.
Thank you. It's thematic, really. This is where we start to see the introduction of more community-based services, which feels to me really important. And it was on the consultation, really, around a bit of resistance to those community. Maybe resistance is too strong a word, but the idea that people were perhaps a bit cynical or concerned about getting care delivered in community. So it's a broader point around, I think, the need to, as part of this whole process, to be emphasising to the general public that this is not just about health care that when you go and get yourself fixed, but it kind of plays to the prevention topic we introduced just before lunch, and the idea that health is something that is not just about when we need to go and get ourselves fixed. So maybe this is more of a comment than a question, but I think there's something in this for me around, as part of the narrative and the story that we produce as a result of these deliberations, that there is something in emphasising the role of community, and that health is more than just getting fixed at the point of when we need it.
Yeah, good point. I think it plays through into the idea that delivering more in the community could be a beneficial thing, even if there's a trust gap between where communities might be and the health board on some of these issues. It feels to me that's quite important. Michael.
Yeah, can I just help me? If I'm an inpatient, typical inpatient, how long would I be an inpatient for, typically, do you think, if I'm in the hospital?
We don't generally have inpatients. It would normally be a patient that has attended another service, for example, general surgery, and they've got a problem with their eyes that would be referred to our service, so we would be able to advise what to do with that patient. So we don't generally have inpatients ourselves. All of our patients tend to be in and out day case admit anyone overnight. Our ward is closed at night and then reopened again in the morning, and our patients come in and go home.
Vicky, you mentioned the fact that currently at Bronglice there's 10 or 11 cases, I think, being dealt with in the course of the week, and and I imagine the majority are going to other sites for...
Glangwili, Amman Valley, and then we outsource to Swansea.
And presumably we're only doing 10 or 11 because that's the availability of staff to be able to undertake that at the current time.
Yeah, it's the clinicians. We've only got one operating consultant in Aberystwyth, and she does a list a week. And then we have a visiting consultant that comes from North Wales, and he does a list for us every other week.
And a position of ignorance from my point of view, but how many on a list would you expect to see each week for a consultant in ophthalmology?
In a main hospital site, we are restricted, unfortunately, normally by the logistics of theatre, and we do 5 to 6 typically. That's part of the getting it right first time recommendations to try and increase that delivery. But in Amman Valley, where we're it's a community site then, and we have a high flow cataract list there, and we've got up to 8 cataracts per list as it stands at the moment. So that's our high flow site, which is why I'm really keen to keep cataracts and intravitreal injections there. It'll be good for the population there to have that the injections close to home, but also we'd be able to build our cataract delivery through Amman Valley and be able to reduce our reliance on outsourcing. So that will actually reduce travelling for patients who are having to go to Swansea currently.
Thank you very much. Sarah.
Thank you, Chair. I think this is a question probably more for Nikki. Given that the two options that we're looking at here, 99 and 173, are both variants of preceding original proposals, will we need, if we opted for one of these, would we need to go back out for further engagement on them?
Thanks, Sarah. I think this goes to an earlier discussion we had around alignment to those options that we consulted on. So where we have options that are very closely aligned to the options that we consulted on, and particularly where it is an addition to the option that we consulted on, so we're almost adding in that mitigation from the impacts that have been raised from the consultation, unless there was something specific that the board felt they didn't hear in the responses that we had during that 13.5-week long consultation, that wouldn't mean there was a need for further engagement. I think it's about where there is in a service we didn't get an opportunity to hear around a particular configuration that has a requirement for us to go back out and further what impacts and mitigations there might be needed if that was the chosen service model.
I feel as if we've got 9 options here potentially, and I'm in my head I'm trying to work out what is the problem we're trying to solve here. Is it about specialisation and skills base? Is it about better efficiency?
What we're trying to solve for ophthalmology would be reducing the 8 sites and getting better consultant oversight for our
yes, but why would we
staff.
reduce the 8 sites?
Because it's very, very difficult as it stands to cover those 8 sites, and we're quite often cancelling. We've got lots of patients that have cancelled appointments that we haven't
This
got.
is because of fragilities around the workforce.
Fragilities around the workforce, yes, and them having to travel to those 8 sites, because quite often they're travelling to those 8 sites, so we're losing efficiencies in travel. And by reducing the sites, we would not have so much travel between sites for staff. We would gain more time on the shop floor effectively, and we would have better consultant oversight, so it would benefit the patient in terms of them seeing that right person at the right appointment. So, for example, if you come into emergency eye care and you're seen by a specialist doctor, you may have to come back for several appointments before you see a consultant. And what we're saying is, if we had a consultant oversight in those clinics, then you could potentially have the specialist doctor consulting with the consultant that's in clinic, getting a clear outcome, being able to go back to the patient and discharge the patient at that point. So the patient wouldn't have to attend 3 appointments and would only have to attend 1.
Thank you. Very helpful. Alison.
I just wanted to follow up on the discussions around community clinics and the trust gap, as you put it, Neil. How would you reassure patients in relation to the aspects that they're concerned about in relation to community clinics around capacity, consistency, facilities and sustainability?
I think looking at all our options, we've kept everything in the community that we can. The only thing that we potentially would be withdrawing would be Bwrdd, but there is a suggestion that we could use that as a hub. So we're keeping all the community clinics we're running now, and also to give assurance to the public that we've been working extremely closely with our primary care colleagues, and we've built an extremely robust network in the community. So now if you have an eye care emergency, what's advised, rather than going to A&E or your GP, that you go to your optometrist in the community. They can forward you on. If they can't deal with you, they can forward you on to a specialist optometrist. We've been training optometrists in secondary care that go out and work at a higher cert level in primary care, and then they would only refer you into hospital if they couldn't deal with that problem. So you get that care closer to home. You're only referred into emergency eye care services then if you're needed to, and the percentage of patients that are being referred into secondary care has significantly reduced, but from introducing that system, the WGOS, Welsh General Ophthalmology Service, into the community.
Sorry, Vicky, I'm conscious we're pretty short of time, so I'm trying to. 2 final comments.
Just one quick point, Neil, on community services is the Hywel Dda Ophthalmology Service is seen as a leader in how we provide community services. We have a really excellent optometric service and with enhanced skills. So we are leaders in community optometry and ophthalmology.
Thank you, Mark. Rodri.
Yeah, and regarding community services, I have to agree. There's a lot of positive feedback from that point. Just one question I had. If you look at that last the options for consideration, the option 99 and option 173, obviously 99 scored higher, but listening to you going through them, it's as if the 173 was more preferred by I don't know, by yourself and the department. Just me being inquisitive, I just want to have your thoughts.
I would say from our perspective 99 is, but we like the Bwrdd hub suggestion, and that's recently come through our SIN, Ophthalmology SIN, to look at having diagnostic hubs in the community, so that would tick that box for us. So it would almost be a good idea to move that into option 99, which would effectively give the service everything it needed.
Okay, I'm going to pull it to a close there. Just 1 or 2 thoughts. So I think what you communicated, Vicky, was a sense that the service has progressed whilst the consultation and the clinical service plan has been in operation. That begs for me a question back to Nikki about if we were to agree an option, would it be within the realm or fold of what we consulted on originally inside this space, or is it close enough for us to be able to do that when we look to make a decision tomorrow? But it's been reassuring to hear what you've had to say, and it seems to me generally the thrust behind these options is to improve access to services more quickly and to ensure better quality service at the point where patients access it.
Yes.
Excellent. Okay. Thank you very much.
Thank you.
Thank you for your time.
Thank you.
Great. Okay. Can I move us on to our next service, which I think is orthopaedics.
Great, okay. So, are you going to say a few words and then perhaps Leanne kind of come in?
Diolch, Chair. I'm Hywel Dda. I'm the Associate Medical Director for Plant Care and Specialist Services. I'll be supporting Leanne. I'm not an orthopaedic surgeon, but I'll be supporting Leanne because our orthopaedic surgeons are busy working today. I'll pass to Leanne.
Okay, thank you.
Thank you, yeah. So I'm Leanne Gregg, the Service Delivery Manager for Trauma and Orthopaedics and Plaster Services. And I'm here today to discuss elective orthopaedics only. Just to mention, I suppose, that the staff group that we're considering here for elective orthopaedics also cover the trauma elements of the service, but for the purpose of the clinical services plan, we're considering the elective orthopaedic element of the service. So starting off in terms of the case for change, and I suppose a similar picture really in terms of ophthalmology, in that when we started the CSP process for elective orthopaedics, we had wait times of 4 years for elective surgery. That picture has changed significantly, and we're currently reporting a 2-year wait for surgery. So we've done sort of we've made significant progress in terms of reducing waiting lists. However, that has only been possible of late in terms by delivering additional activity volumes through various areas, really, from insourcing, outsourcing and additional waiting list initiatives. However, despite all that progress that has happened, the orthopaedic sort of challenges really in terms of maintaining a reduction in elective waiting times still remain. And there's a couple of factors that play into that, in terms of the particular challenge for us being around inpatient surgery and arthroplasty in the main, which requires access to a laminar flow theatre, and it's the available theatre capacity to meet our current demand for that. Alongside that, and just as we were coming out of COVID, the British Orthopaedic Association released updated standards which determined the sort of standards of care really that were required in order to maintain elective inpatient delivery. So it set out a certain group of criteria that needed to be met in order to maintain those standards completely. As a result of that, we're currently delivering elective inpatient surgery at 2 sites across the Health Board, up in Bronglais and in Prince Philip Hospital, with day case activity taking place down in Withybush. At Glangwili, we only deliver trauma surgery, so nothing from an elective inpatient perspective for the scope of CSP. The workforce for us remains fragile, and obviously we rely on a number of other sort of teams and staffing teams to support predominantly anaesthetics, theatre staffing teams and therapy teams. There's been particular recruitment challenges across a number of those staffing groups, which has meant that we've been able to more recently increase our elective theatre capacity, but 2 years ago when the CSP started, obviously we were delivering a smaller number of elective inpatient sessions as a result of those workforce challenges. So why does it matter? So for us, 2 years for surgery is still way too long, and we need to put in place sustainable plans for the service to continue to bring those waits down. It's far too long for patients to be waiting for surgery. The thought, I suppose, is that we, by bringing services together, we can make permanent reductions to waiting list times. So the CSP process for us, I suppose, is to identify where we can potentially increase capacity that addresses the arthroplasty demand, but formalise and embed regional working arrangements through collaboration between us and Swansea Bay, and agree, I suppose, the permanent way forwards in terms of where different activity is delivered across all sites. So moving on to the initial options development. So there were 4 options put on the table initially. a high-level overview in terms of these initial 4 options is that there's no change from a Glangwili perspective. As I said, from a surgery perspective, we don't deliver any elective surgical activity. However, we do deliver outpatients for elective patients, and that remains in all of these options at the Glangwili site. Regional working with us in Swansea Bay is suggested in 3 out of the 4 initial options. In one option, option D, we look to increase our inpatient capacity at Bronglais through additional theatre sessions. And as Victoria helpfully mentioned earlier, the board, I suppose, need to consider that potential trade-off. That would be possible for us to increase at Bronglais should the ophthalmology service come out, because we are then able to access those sessions in exchange. In option B, it looks to increase day case activity at Withybush through extended hours. And in other, so the high-level overview is an increase in elective inpatients in Bronglais through option D through additional theatre sessions, and increased day cases at Withybush in option B through extended hours. So those are the initial options that came about through the options development phase.
Thanks so much, Leanne. So moving across to what we heard in our responses to the questionnaire linked to orthopaedics. So as you can see from the table here, for both NHS employees as well as other individuals, option B was the preference, followed by option D. Where there is a slight difference between those 2 groupings was that option A was preferred over option C for NHS employees, whilst there was very little difference there you can see between option A and option C for those other individuals. As we move across to differences in responses linked to postcodes and nearest hospital site, there isn't a clear consensus between preferences across our hospital sites. So the preferred options for people living near Bronglais Hospital was option D, whilst for those living closer to Glangwili, Prince Philip and Withybush hospitals, it was option B. This continues to feed into what we've been seeing so far as we've worked through the different options, that communities closest to an acute hospital site have a preference for options that retain the service at that hospital site. So as we move into the broader conversations for what we heard linked to orthopaedic services, there was some recognition here from some of our respondents that where bringing orthopaedic services together could help reduce waiting times, that there were some in our community that would be willing to travel further if it meant that they were seen sooner. We did have some strong concerns raised linked to access, particularly for older people and those in rural communities, and how people will get home following being a patient with us on the service. There were also mixed views when it came to regional working. So some respondents told us that where regional working could result in increased capacity or speed of access, so getting that appointment sooner, they could see the benefits, whilst there were other respondents who fed back to us that they felt potentially how our patients could be disadvantaged if they're on sort of combined waiting lists that are across multiple health board area. As we've seen with other services, keeping services local was seen as really important, especially when looking at additional follow-up appointments and rehabilitation, so having that care as close as home as possible. There were mixed views in terms of the future direction of the service, with some calling for services to stay closer to reduce sort of travel and inequality, with some saying actually we'd be happy to travel further if it improved access and meant that we could have those appointments sooner. And both Leanne and Vicky drawed upon this point, and we also heard it really clearly from our communities, which was linked to that point around the interdependencies on services. So if, in order to retain elements of orthopaedic services at Bronglais, that impacts what the service that could be offered by ophthalmology. That was felt quite strongly from our communities in and around Mid Wales, that they don't feel they should have to choose between retention of one service over another where there's a challenge around theatre space. So that's what we heard from our communities. Back across to Leanne.
Thank you.
I mean, just to clarify, I think it's important to say we've mixed this ophthalmology and orthopaedics issue at Bronglais, but that's not the reason for removing ophthalmology from Bronglais. Is not to increase the quantum or volume for orthopaedics. It is because that service can be delivered more efficiently somewhere else. It's important for us to say that. Thank you. Leanne.
Yeah. Okay, so moving on to the next slide, and following the staff and public consultation, there were 5 alternative options proposed. So they've been laid out over 2 slides. There were 2 options that have been merged, which are option 52 and 113 on the screen there. But again, I'll give a sort of a high-level overview in terms of what those 5 options mean. So again, in all of these 5 options, there are no proposed changes at Glangwili site, and no proposed changes in terms of where we're currently delivering outpatient elective activity. But in option 52, the combined option 52-113, this is the only option that proposes bringing back elective inpatient activity to Withybush. In 2 options, which is 129 and 268, it proposes an increased activity for elective orthopaedics at Bronglais. Regional working at Prince Philip appears in 4 out of the 5 options. And option 129 proposes increased day case activity in Withybush through extended hours. And option 178 proposes additional elective inpatient activity at Prince Philip through extended hours. So in terms of the additionality, I suppose, that's proposed, that's being proposed in these options, and where the challenges are seen within the service, certainly option 129 and 268 proposes the additionality up at Bronglais site, and option 178 proposes the additionality in Prince Philip through extended hours. Okay, next slide, please. Thank you. Okay, so which options support the best case for change, I suppose, then? So in terms of clinically led options, option D scored the higher. So just as a reminder, option D was where we look to increase inpatients at Bronglais. A close second were options 129 and 178. So 129 was, again, increased inpatients at Bronglais through additional sessions and increased day cases at Withybush through extended hours. And option 178 was increased inpatients at Prince Philip through extended hours. So looking at the sort of the breakdown of the options by the criteria grouping, option D really scored the highest overall against 3 of those 4 domains. Option 129 scored highest against accessible. It is worth noting, I suppose, the option that does propose bringing inpatient activity back to Withybush is the only option, scored poorly against safe and sustainable, but strong against accessible and kind. So in terms of looking at the options that scored the highest, option D and option 178 have been summarised in this particular slide here. And And again, option D, I suppose, is increase in the inpatients at bronglice, whereas there isn't an increase in inpatients at bronglice in option 178. So in terms of the board's consideration and understanding the interdependency and impact, I suppose, in terms of the proposal in D, that does heavily rely then upon the decisions potentially that come as a result of ophthalmology coming out. As if ophthalmology didn't come out, we wouldn't have the existing theatre sessions for us to potentially deliver orthopaedic activity at that particular site. But again, regional working at Prince Philip features in both of these options. For the service, I suppose what we're trying to create, as I mentioned earlier, is a sustainable reduction of waiting lists for the service. So for us, you know, we would obviously want to deliver as much elective inpatient activity as we can. Obviously, both options look to deliver additional activity for us, but at different sites. I suppose my question would be, is there an option to do both potentially? You know, could we deliver some additionality in bronglice and additionality at Prince Philip through extended hours? I suppose I'm just putting that out there for further consideration as the board wishes to. But I suppose that would be a potential solution that would certainly provide us a greater inpatient volumes and support a faster reduction of elective waiting times. So key dependencies, I suppose Nikki has mentioned some of them, which were certainly consulted on with the public. And again, I suppose there were some concerns raised regarding travel, certainly from those living in rural areas and older people. However, it is important to note, I think, that people were more accepting of the fact to travel further for surgery, and were more concerned that potentially their follow-up requirements were dealt with more locally. So, for instance, after the surgery, where they have the post-op follow-up, outpatient appointment and rehab in particular, rather than travelling for the surgery itself, appreciating that, you know, arthroplasty is a big operation for people. They don't very often have a lot of them. So I think there was that appreciation then that travelling as a one-off for the surgery was more acceptable, where the wraparound support post-operatively was made available more locally. In terms of independent services, obviously, I know critical care has already been discussed earlier today, with the various options being considered through the CSP. I suppose we just need to be clear on the support that would be available for the elective inpatients, elective orthopaedic inpatients, with Prince Philip being our main inpatient elective site, delivering the most inpatient activity for us, as well as the complex and revision cases. But obviously the CSP options are considering that in terms of a critical care perspective at this time as well. Obviously the interdependency with ophthalmology that we've already discussed, depending on what option is chosen. In terms of regional working, we are working towards, I suppose, a regional approach in terms of reduction of waiting list, and the regional orthopaedic programme is certainly working towards developing and delivering a single patient tracking list to support a reduction of the region's longest waiting patients. And as Nikki mentioned, I think there were some public concerns around any potential impact on Hywel Dda patients, and the feeling that they might be disadvantaged within longer regional waiting lists. I suppose we just need to ensure that in terms of the British Orthopaedic Association standards, that we maintain compliance at Prince Philip and improve bronglice to achieve compliance at that particular site. Okay.
Right, we need to kind of bring this session to a close so we can open it up for board activity, but you may want to add one or two comments, but then let's open it up.
Yeah. No, I think I've probably covered everything, to be honest.
Great, okay.
Yeah.
That was very
Thank you.
clear. Thank you very much. Board, colleagues, questions? Yes, please, Maynard, and then Chantal.
Thank you, Chair. You mentioned that in an ideal world you'd like to increase activity both in Bronglais and Prince Philip. Does that have any staffing implications on any of our staffing groups?
So, from an orthopaedic perspective, obviously it will certainly require updated sort of consideration through job planning. At Bronglais, that wouldn't be an issue with our consultant group. And certainly from a Carmarthenshire perspective, as I said, through job planning, that is potentially achievable. I suppose my only reservation would be from an anaesthetic perspective, although I know that there has been a lot of work done around anaesthetics and potentially understanding what the requirements are there in terms of recruitment, albeit, you know, the national recruitment perspective has been somewhat challenging.
Lisa, did you have a view on this?
Yeah, thank you. So the options will vary from either an additional about 5 whole-time equivalents up to 20. And there's quite a number of interdependencies on this one with other services which would have an impact on workforce.
Okay, thank you. Chantal.
I think.
It is on. It was on.
It was on. Thank you. I just wanted to ask clarification around the rationale for having outpatients at Glangwili, because it seems to me that we are only having outpatients in Glangwili in any shape or form. So I've just wanted to understand a little bit more about the rationale for that. And secondly, whether as part and parcel of developing those various options, whether we gave consideration to virtual appointments as well.
Okay, yeah. So in terms of the outpatient activity, we have delivered outpatient activity across all 4 sites for a number of years. I suppose if we're looking potentially to withdraw the outpatient activity from Glangwili, we would have to find alternative space at the other sites. And I know the outpatient space is particularly challenging at all sites. So I think if we were to withdraw from Glangwili, there is a potential, trade, I suppose, that we could do to deliver that at another site. However, the activity, I suppose, has been delivered in that way, and then provide those contact points across the health board, I suppose, in all counties. But that's something that could certainly be looked at, I suppose. But we would have to identify an alternative space at another outpatient site. In terms of delivery of virtual outpatient appointments, so there are some subspecialties where the majority of our outpatient appointments are delivered virtually. So, for instance, our upper limb clinics, shoulder and elbow, all first new outpatient appointments are delivered virtually via video consultation. And we also deliver pockets of virtual activity for first outpatient appointment across other subspecialties. However, I suppose when we're talking about arthroplasty, there's a huge amount of merit. I'm not clinical, but there's a huge amount of merit, I suppose, in being able to touch the joint, feel the joint, to understand and make a more accurate clinical diagnosis in that respect. Thanks.
Colleagues, other questions? Neil, and then Mark.
Thank you. As a point of clarification, really, so many of the, if I'm understanding things correctly, many of the topics we've discussed this morning have been, to some cases, about consolidation. This feels like it's more about additionality. So I'm just trying to sort of square the circle between some of the challenges around capacity, not meeting demand, workforce, and yet it seems like we're, unless I've completely misunderstood this, it seems like we're actually, we've got 2 options, preferred options for consideration, which would suggest this is about additionality.
So, yeah, so there's a couple of things. Certainly, the current demand, far outweighs, I suppose, what we've got in terms of the delivery of the inpatient activity. However, the way in which we're delivering that current inpatient activity has changed since pre-COVID and the updating of the British Orthopaedic Association standards. So, for instance, pre-COVID, we did deliver inpatient activity at Withybush, but currently only deliver it at Bronglais and Prince Philip. So we need to look at where we're able to deliver the inpatient activity across those sites and maximise, I suppose, the throughput that we can put through each of those sites.
Good question, because I think you're right. In a sense, I think we've been looking at issues that are deeply fragile around some of those services. And it feels to me as if this is delivered well, certainly over the last year, because we've met that 104-week standard. I suppose the question for us is, or the imperative for us is to ensure we're meeting standards and to work towards reducing our waiting times.
Yes.
Fundamentally, we need to do that in the most sustainable, cost-effective, impactful way. Great. Okay, Mark.
Thanks. I just wanted to make one point about critical care. Critical care options would negatively impact on any of these orthopaedic options. So, in other words, if for example, at Prince Philip, we were to decide on an option where there was an enhanced care unit, that wouldn't make a material impact on the orthopaedic activity. There's only a very small number of patients that would need a higher level of care, and I'm talking about a handful of patients that we would then identify an alternative pathway for them.
Thank you, Mark. I mean, we may come back to this tomorrow, because I think where those interdependencies start to play out. Ben, yes, please.
Apologies, Chair, just to come in. It's just also to add around orthopaedics. It wasn't just about activity, it's about really bringing to attention that the post-COVID changes to the service, and it's given the service to make permanent those temporary changes that happen post-COVID, specifically around inpatient activity with Withybush, removing and not going back to the site, and also the mandate for the regional change and the regional programme of work for orthopaedics as well that was considered in the public consultation.
Thank you, very helpful. I'm going to close this item. I think we've probably had a fairly useful conversation. I would like to emphasise that point between ophthalmology and orthopaedics at Bronglais. We need to separate these two things. They are not dependent on each other in terms of our decision making at this point, and won't be tomorrow. Leanne, thank you very much. Thanks very much for your contribution. Great. Let's move to dermatology. Very welcome.
Good afternoon, Mr. Chair, ladies and gentlemen. My name is Fred Schroeder. I'm a consultant plastic surgeon. I'm employed by Swansea Bay University Health Board, but I work with the dermatology department. And really, I was appointed in 2021 to dermatology, and I'm the longest serving member of the dermatology department in West Wales. We have really an imperative to discuss this. I'm with my service development manager, Kerry Wisdom, who's probably going to answer most of the questions with the details. I'm here for a sort of overview. Why do we need to change dermatology? The biggest constraints to dermatology have been the inability to recruit a substantive consultant. It's pretty much a decade since Hywel Dda last had a substantive consultant dermatologist. And this has impacts upon patient care, upon the service, training, recruitment, and teaching of our middle grade service staff. It also has an impact on our clinical nurse specialists, which have supported the service for really the last decade. Standard services that most other dermatology departments offer are not offered by our department. So we don't have any see-and-treat clinics, probably the only department in Wales that doesn't offer the service, and we don't do patch testing. We have very limited facilities at Prince Philip Hospital, which is where we're based at the moment, and this is a COVID change where a lot of the services moved from Glangwili to Prince Philip Hospital. I chair the skin cancer multidisciplinary team meeting every week, and year on year we've seen about a 20% increase in the number of skin cancers that we discuss. These are the more significant skin cancers, and this has an impact on obviously our capacity. We're having to see patients to have longer, more difficult discussions and do more interventions, both therapeutic and diagnostic. We have been unable to deliver phototherapy because of infrastructure problems, and phototherapy remains one of the first-line treatments for a number of dermatological inflammatory conditions. We've not been able to see paediatric patients in the proper environment. They've been seen in an adult clinic by a locum consultant, therefore they're in not the right environment, and we're taking somebody out of a clinic that could be better utilised for more complex inflammatory patients. So really, the bottom line is that the fragmented service that we inherited needs to be consolidated. We cannot work as an efficient dermatology team without consolidating services and offering support to consultants to improve recruitment, retention and training, and therefore developing a sustainable and strong dermatology department. One of the big problems is that we don't really have the estates to develop this dermatology service at Prince Philip Hospital either. Next slide. The options that were discussed and brought up by the Options Development Group were options, A, B, C and D. I'm not going to go into them in very much detail. Our current service sees some outpatient clinics at Glangwili, a medical photography based at Glangwili, and if we had phototherapy running, it would be at Glangwili, but we're not able to offer that at the moment. Most of our services are at Prince Philip Hospital. We've not been able to offer services at Withybush because of the RAC issue since 2023, and we have two very good nurse-led clinics in Cardigan, at the Cardigan Integrated Care Centre and South Pembrokeshire Hospital. Just to say that option A takes away community provision in Pembrokeshire, but it does consolidate the service at Prince Philip Hospital, and it adds in a nurse-led outpatient service at Ammon Valley Hospital. Option B, again, consolidates the service at Prince Philip Hospital, puts some operations into primary care and GP practices, but doesn't allow any service provision in Ceredigion. Option C is perhaps the most comprehensive because it keeps community service at both Pembrokeshire, Ceredigion, and has some development as well in terms of some ambition, offering minor ops in GP practices and primary care, and an additional nurse-led paediatric clinic at the Cross Hands Health Centre, which is being developed. Option D is very similar, but doesn't offer the GP service. Next slide. Over to Nicola.
Thank you so much. So what did we hear in terms of questionnaire responses for dermatology? So you can see on the table there that we have some consistency in terms of responses across those who indicated they were NHS employees and the other individuals. So option C was the overall preference, followed by option D when looking across those two groupings. Ben, if you can move on to the next slide. When we then look at that data set based on postcodes and responses linked to nearest hospital sites, again, option C was the preference, followed by option D, and that is across all postcode areas. Where there starts to show a difference in terms of responses was for the second and the last couple of choices. So for people living closest to Bronglais, Glangwili, Prince Philip Hospital, it was option A was then preferred over option B, and in contrast for people living closest to Withybush Hospital, it was then followed, option B was then preferred over option A. So there was a consensus across the preferred options with all hospital sites in agreement there. So in terms of what we heard linked to dermatology services in our conversations with communities and in that open text box that we had it in the questionnaire, there was strong agreement that there needed to be a change to help reduce the long waiting times, and it was recognised across many of the responses that the current access and delays weren't acceptable and timely. There was some specific feedback around phototherapies and that being brought together at Prince Philip Hospitals, with concerns raised by our community around having that at one site, and that site being the furthest site in terms of to the east of our health board areas, and worries around access linked to that. Travel and transport, again, were mentioned, linked to dermatology services, and particularly where appointments may be short or frequent, the need for some of our communities to have to travel further to access appointments was something that was raised by some respondents. There was calls, once again, linked to dermatology for utilisation of digital and virtual solutions as a way that we could mitigate the amount of travel that may be needed from patients accessing the service, and also to help address those barriers for some of our communities. Staffing challenges were also noted, and they've been discussed, as you've heard, by the service, but that's certainly something that was felt by our communities in their responses. And then finally, specifically linked to the idea around elements of the service being provided at GPs, as this was something that was welcomed by some of our respondents. I think there was also a level of concern around access to GP appointments, and actually if we were going to have more services being offered at GP surgeries, would people be able to access those patient appointments to go there? So that's a brief summary of what we heard in the consultation.
Thank you, Nicola. 24 alternative ideas were suggested, which we discussed in clinical options appraisals. None of the other 24 alternatives passed the hurdle criteria. So we therefore remained with the 4 options A, B, C and D, which then went through a clinical scoring. So the clinical-led options appraisal, options C and D were the 2 highest scoring. Option C scored the highest in all 4 of the grouping domains, being safe, sustainable, accessible and kind. Option D scored second highest in all 4 of those categories. But looking at the individual criteria, option D scored higher in terms of financial sustainability, which is understandable, and also on impact on local communities. And really, after Nicola's last comment, I suspect that's how that score resulted. Next slide. So really, from a dermatology point of view, we think option C remains the strongest, the public have agreed, point of view. There's some contingencies that seem to make it work. As a result of COVID, a lot of services had to be consolidated at Prince Philip Hospital. Therefore, it means not going back to another site. The services are up and running at Prince Philip Hospital. Option C also provides some ambition and service development in terms of integrating better with primary care, working with GPs and doing surgery in primary care. It makes sense if you're changing a site to be integrated with the site, and obviously all the reconfiguration work presents an opportunity for the dermatology department, particularly with option C. We do feel that this is a deliverable option and could be delivered in the next 4 years. With an increase in estates, we'll be able to see more patients, more clinic rooms, more surgical rooms. We'll be able to offer see and treat clinics, which have not been part of our dermatology service, as I mentioned earlier, the only one in Wales that doesn't offer this service. We'll see capacity improve to treat patients. By bringing the medical photographer to Prince Philip Hospital, we'll support the management of patients with skin cancer, because medical photography is an essential component of medical record. It reduces the risk of wrong site surgery and is an essential component of that service. So bringing together all of the staff would make the dermatology service much stronger, and that would have a real benefit in terms of recruitment, retention and training of staff. Obviously, there are risks with this. We don't have the space at the moment, and if we don't get the space, we won't be able to achieve option C. We don't have a substantive consultant at the moment, and that remains a big risk. 24% lack of dermatologists throughout the country. So we need to make the department a strong department that can recruit and retain dermatologists. Obviously, the Cross Hands Health Centre hasn't yet been developed, and therefore the paediatric clinics, until that happens, they remain at risk. Next slide. We do realise that consolidating far east of the health board does increase patient journeys, but it will also pragmatically increase the number of activity, or the number of patients we'll be able to see and treat by consolidating the service. So it will strengthen the service. Obviously, as I mentioned, it does mean that we need to have more space for offices, extra clinic rooms, treatment rooms, and it also depends on being able to set up paediatric clinics at Cross Hands. Thank you.
Thank you very much, Fred. That was very, very helpful and comprehensive. Question in my head is this service, you've described a service that we're currently operating and one that we're moving towards, or one that you would like us to move towards in option 3. Are we already at the point where we're delivering much of that option?
We are delivering from a single consolidated site most of the services. We do still have clinics at Glangwili. We're relying on clinical nurse specialists to do the rest of the region. Our fragility lies in the fact that we have 3 locum consultants. We've just appointed another locum consultant, and in the 5 years, I've seen as many locum consultants. So we need to create a service that's centralised, where we support the middle grades, so perhaps they can go through the CSER training route to become certified consultants, and then we're training our own dermatologists. We have a dermatologist, potentially a substantive consultant, who's travelling from Cardiff. So we've got to be mindful of things like travel. So yes, we are delivering a lot, as we currently are, but we're having to insource a lot. So we are not able to achieve waiting lists and numbers with the facilities that we've got, with the staffing levels that we've got. Kerry, have you?
Thank you. Colleagues, questions? Right, Rodri and then Maynard.
Diolch yn fawr, Cadeirydd. Dim ond un cwestiwn sy'n gyfer ran...
One question I have here about option C. Sorry, you have to put your pieces on.
Just around option...
This is concerning option C. You said earlier on that that's dependent on more room, more space in our estate, in our hospital. So I just thought, is that an option to study at all?
You know, just regarding option C.
Sorry.
Oh, it doesn't. Right, you know, regarding option C.
Sorry.
You've said that is very much dependent on extra space within our hospitals, the estate. Therefore, I'm just wondering, is that option C even an option for us to consider? Just for us to be clear on the options we will have to look at and make a decision on tomorrow.
I'm happy to come in on that, Bwrdd. Obviously we've got quite a number of moving parts now with different services and so on. So there's, it's difficult to give a definitive answer on any service until we come to a view on how we want to move everything around. But we have done quite a lot of detailed work around the capital and estate implications of each of the options. So there was quite a lot of information that went to the Strategy Planning Committee in January, which is available for board members to look at in more detail. So we have assessed that for all the options in all the services. In the case of dermatology, as has been mentioned, much of the service is already being provided from the footprint that it would, from the locations that they would potentially be provided from. I think there is a further question for us about our aspiration around creating a dedicated dermatology facility that could build into the type of service that has been described and meet those aspirations. And so I think that'll, depending on where we get to decision making, all the options obviously point to a centralised service in Prince Philip. So that will be one of the tasks for us as we look to the implementation phase, is to understand the time frames of such a delivery, how much it would be likely to cost from a capital perspective, and then we'll need to get into levels of detail around exactly what the space requirements are and have some debate around that. But there isn't a place at the moment for people to move into. That's the case for all the services, but it's certainly not out of the bounds of possibility that we could deliver that within Prince Philip.
Maynard, and then Michael, and then Eleanor.
My question's already been answered in the...
Brilliant. Okay, thank you, Maynard. Michael.
Yes, just a clarification. Just on the kind of nurse-led services in the, I'll say the non main hospitals bit. So the dermatology patient, is there kind of contact with the service? How much of that is in that nurse-led world, as opposed to having to go to the consolidated centre? I imagine there's quite a lot of the contact is in that nurse-led world and potential GP world as well, particularly. Is that right? Is that...
Yeah, absolutely. So my experience with the nurses at Prince Philip Hospital is mainly through the skin cancer pathways, which I'm very, very involved in. So, for example, the complex patient with a new diagnosis will come and see me in my MDT clinic at Prince Philip Hospital to discuss their new diagnosis, the complex treatment with immunotherapy, surgery, etc. They will then have their follow-up closer to home with one of the clinical nurse specialists who've sat on the MDT, who understand what the process for the patient is, but then the patient can be followed up closer to home. So that model works for skin cancers, and it can work for inflammatory dermatology as well, where the initial starting the patient on more complex treatments is done by the doctor, and then the clinical nurse specialists carry on with the follow-up of the patient in the community.
Has that responded to you? Great, okay.
Michael asked the question I was going to ask. That's fine, thank you.
Great. I'm a bit disturbed to hear that we've got 4 locum dermatologists working. It feels to me that our solution, whatever we decide in terms of way forward, needs to move us away from having... That is the basis of our fragility, I would argue, notwithstanding the fact that costs associated with that are just phenomenally large. We have to address that issue fundamentally. That's partly a CSP issue, but it's a broader issue around the workforce and what we're doing inside that space. You were going to...
Yeah, I think my question was going to be about primary care. 2 things, actually. I had 2 questions. One was about primary care, which I think Michael's asked. I just wonder whether how much we can push the fact that we have an interested GP community where the bulk of the work is already done in primary care and community services around dermatology conditions, and in a rural environment like we have, whether there's an opportunity to push that further. That was one question. The other question, given our very long history of having locum dermatologists who we're very grateful for actually providing the service. It's just that we know that having a substantive workforce tends to result in better quality. I wondered how much of this is us designing a service in Hywel Dda and how much of it is a regional service that we are considering here.
So the first point, in terms of GP surgery, on and off during the last 5 years, there have been GP practices that provided very good local services. But as soon as that GP stopped providing that service, the service stopped. And then there was a very abrupt change in the patient pathways, and then they were having to come back to Prince Philip. So it needs to be a very coordinated endeavour, linking primary care with the dermatology departments. And it has to be strengthened pathways and perhaps even SLAs saying, you know, this is what we're expecting from you, and this is what, you know, this is what we're going to provide you in terms of support and training, etc. So that's the first thing. I certainly think it can work. But what we don't want is little silos in various areas where patients are getting very good care from their GP, and then the practice changes because the GP no longer wants to have that special interest, which has happened in the last 5 years. In terms of regional working, I'm a regional worker in that I'm employed by Swansea Bay and I work in Hywel Dda. And it's had a personal impact on me in terms of medical isolation, because I've spent 3 days a week at Hywel Dda and 1 day regularly a month at Swansea Bay University Hospital with my colleagues as part of that department. So I know what it's like not to work in a department where you're supported by your colleagues, by your peers. So I think it's important. That's why we have to establish a department, because we've got 3 locum consultants at the moment, plus we've appointed another one who has the potential to be a substantive consultant. She has family based in clinically, so would be an ideal candidate. But she wants to see how it goes because she lives in Cardiff. If that doesn't work, and we feel that we can't rely on locum dermatologists, well then my fear is that there will be no dermatology service in West Wales offered by clinicians in West Wales, except for isolated general practitioners. Because it's not very sustainable for me personally to carry on doing what I'm doing without any chance of any development or change in the service. I'm retiring in 2 years, and when I go, I go.
Can I just want to understand the distinction between those services that are provided nurse or GP led and then those that are provided that are consultant led.
Yeah.
In terms of the ratio or the difference between those two. So how much would be, because I'm conscious of the services provided out of Cardigan Integrated Healthcare Centre and the South Pembrokeshire service, which is highly regarded locally and well received. I'm just trying to understand the scale of those two parts of the dermatology service.
I will refer to Kerry because she's the numbers lady.
Good afternoon. So within the community, with our nurse-led clinics, it's only the skin cancers that are seen. There's no inflammatory patients that are seen in the community sites. So the nurse-led, there are 2 particular nurses that work at our South Pembrokeshire Hospital and Cardigan Integrated Care Centre. And between them, they probably see about 50 patients a week.
50 patients a week?
That's both new and follow-up patients, yeah, but only skin cancers.
And how many patients would the consultant-led service see over that period?
So if you're looking at the consultant clinics that occur in Prince Philip, and we have a couple of sessions within Glangwili Hospital, adding up, isn't my strong point, but I'll add it up quickly. Probably
It's
between
okay.
about 120 patients.
So the consultant service would see about 120 patients.
It's the, yeah.
And then the nurses would see about 50 patients. Okay, fine. I'm just interested in where that approximation. I'm just interested in how those two things come together and what bearing that has upon a single site service or taking the service to Prince Philip. Thank you very much for your contribution today. I think we've got quite a lot to think about in terms of how we take this service forward. It feels to me that this is a very future-focused thing. So it feels we can agree perhaps tomorrow in terms of how we take it forward, but it's really leaning into the future and deciding how we want this service to be in the long term and how we can improve or optimise its ability to deliver for the patient, which at the current time feels to be immensely difficult because of the level of demand and the service being provided. Thank you very much. Thank you for your contribution. Okay, I'm going to take us straight to urology. Thank you very much for joining us.
Thank you for the invitation.
It's our pleasure.
Hi, I'm Yao Kunso. I'm the consultant urologist, and until recently, I was the clinical lead for urology until November last year, where I've been appointed as the clinical director for plant care and specialist service. So I've been involved in the CSP development of urology service throughout. So since COVID, the challenge for urology has been significant. I think mainly because of the population demography, and we have a large number of elderly patients with likelihood of cancer, particularly prostate cancer. And since the COVID, we have changed our practice because we used to have Glangwili General Hospital as the main hospital for emergency and also elective patients. And since the COVID, we have to change it, and all the elective service has been moved to Prince Philip Hospital. And although we still have some outpatients service and diagnostic procedures in Glangwili, the urology ward has not become urology ward because of the surge of acute patients. So a lot of urology ward also have a lot of outliers from other specialties, like orthopedics, medical patients, and our urology patient now, especially the emergency one, has to outlie in different parts of the hospital. And with urology, is a very specialized specialties, and they need to be cared by urology nurses, and we don't have that at the moment, and it is a challenge. Now, one thing that we are lacking that has been pointed out by the GOV guidelines, which is a national body that look at the standard practice for urology throughout the UK, is that we do not have a urology investigation unit. And the urology investigation unit is very important for us because it helps to consolidate the manpower in a particular site where the consultants, the CNS can work together, and it's shown to help to improve patient care, in particular in terms of diagnosing cancer for patients, and also a lot of outpatient treatments that can be done there. Now, the other issues that we have at the moment is in terms of imaging, because of, as I said before, because of the backlog of patients that we have, we found that imaging is lacking, so much so that currently we have to use, outsource our MRI scan for prostate cancer patients elsewhere. So this is something that we're still looking at to try to improve. And because of the number of patients we have and the workload, the current workforce is no longer sustainable to look after the patient that we have. And this is not only the urology, clinical staff, but also the CNS. So all this has sort of pushed us to try to develop or try to change our practice. So can I have the next slide, please? So this is important because we need to have a proper urology investigation unit where we can focus on all our diagnostic procedures, because it can help to shorten the time for patient to have diagnosis. And more importantly, I think it can also help to focus on other treatments where we can separate the cancer and the non-cancer treatments, and this can help us to improve the overall care. Okay, next slide, please. So currently, the way the urology practice throughout all the 4 hospitals, as you can see, the main emergency and elective patient is in Glangwili General Hospital. But we also, well, some of the elective inpatients is now reduced significantly because of the bed situation. So we have most of our inpatient elective patient now in Prince Philip Hospital. And the rest of the hospital elsewhere, Bronglai, Bush, they have outpatient service and simple day case procedures and simple diagnostic procedures. What we propose to do is to concentrate all the emergency in Glangwili hospitals and basically use Prince Philip Hospital. Again, everybody likes Prince Philip Hospital. So if we can concentrate all our diagnostic facilities, outpatients, and build a urology hub in Prince Philip Hospital, that will help to streamline our treatments and also empower with other South Wales hospitals, because I think we in West Wales is possibly the only hospitals where we don't have a urological investigation unit. So because all the units that I train in South Wales, and I know that each unit, they've got their own investigations departments, and it helps to improve patient service. Next slide, please. Thank you.
Thank you so much. So we're now moving across to the questionnaire responses. So it's obviously key here to note that this was the only service where there was just one proposed option. It was not positioned as a preferred option, but there was just one proposed option. So in looking at the table, it's a slightly different positioned question around whether you agree or disagree with that proposed option. So in looking across the responses, there were similarities across both groups of NHS employees and other individuals, with agree and strongly agree making up over 50% of the responses, whilst disagree and strongly disagree made up under 30% of the responses, and then leaving that 20% with neither agreeing or disagreeing with the proposal. As we move across to the next slide, again, same question, so just that one proposed option. There is some slight differences based on postcode and nearest hospital site. So for those living closest to Bronglais and Glangwili Hospital, most people indicated disagree or strongly disagree to the options. For those living closest to Prince Philip and Bush Hospital, more people indicated agree or strongly agree to the options. So when we turn to the broader conversations that we heard during the consultation, as with other planned care services, we heard that there should be a strong focus in terms of reducing long waiting lists, with some respondents saying they'd be supportive of going further for treatment if it meant that they could be seen sooner. And there was particular mention around urgent suspected cancer there in terms of speed of access to service. As we move on more specifically to urgent suspected cancer, there were some mixed feelings around centralising of the service. So some noting that if it delivers faster, more coordinated access, that could be preferable. However, others were really concerned about impacts with travel and reduced access, particularly with the location being Prince Philip Hospital at the furthest east part of our health board area. Wider travel and transport impacts were also raised, particularly linked to older people, those living in rural communities, and also patients needing to access multiple or urgent appointments. There were also some points raised by some respondents about ensuring that we maintain patient dignity given the nature of some of the conditions treated under the service. There were some proposed travel mitigations linked to greater use of community locations for screening and diagnostics, mobile diagnostics, as well as opportunities to have appointments where appropriate, digitally or virtually. Interdependencies was another theme that came from responses in urology, particularly around concerns with certain independencies and whether the urology service would be safe and viable on sites without critical care or other surgical specialties was something that was raised from our communities as a concern. And I'll hand back across.
Thank you. So, from our options that was given, the other options, there's really not much different there. If you look at the first options and the other proposed options, option 194, 197, is that the Glangvili Hospital, they proposed to have not only emergency care but outpatient diagnostic, and that was the only difference. Instead of just the emergency care, they proposed to keep the outpatient diagnostics, but again, the centralizations of diagnostic hub is in Prince Philip. So that's the only difference there. The next slide, please. So based on the scoring that we had according to the hurdles, all the four domains. So the first option A scored the highest for all four domains, not surprisingly. So I think it just shows that for us to centralize our urology investigation unit in Prince Philip will be the best way to provide an effective and efficient care for urology patients in Hywel Dda. Next slide. So hopefully, if we can have this implemented, then we can start delivering in the next couple of years. And the benefits, as I mentioned earlier, is that because you centralize all the manpower and all the specialists in one area, they will allow the assessment, the urgent suspected cancer can be diagnosed quicker and then treated quicker as well, particularly with prostate cancer. And one of the study that we did, it was a CIU study for prostate cancer, which was run by my colleague, Mr. Ng. And in that study, what he did was from the time of referral to the GP referral to urology, based on the referral itself, we were able to put the patient straight for MRI scan. So patient did not mind going elsewhere for MRI scan as long as they get an MRI scan quick. So we have patients traveling from, for instance, Prince Philip area to Monglas for MRI scans. And because of the short period of turnover, they have an MRI scan and the report was done the following day. So they straight away were able to get a date for a biopsy within the next week. So the turnover for diagnosis was very quick. So patients overall do not mind to travel if they can have their diagnosis done quickly. So I think that's the main benefits of a centralized urological hub. Not only that, but it also helps to for us to deliver outpatient treatments. Now, since COVID, the urology has improved in their treatment of a lot of conditions, and most of them is now based on the outpatient. For instance, a patient that have a stricture narrowing the pipe, traditionally they used to have to come in as an inpatient under general anesthetic to have a procedures to open up the urethra. Nowadays, they can have a small balloon put into the urethra and then dilate and balloon dilate it under local anesthetic. So for that to be able for us to take on, we need to have a urological hub, because this service is already been practiced in other hospitals in South Wales, in North Wales as well. And we are lacking that because we don't have a centralized unit. And it can actually helps to reduce the inpatient need for this group of patients. Hence, then you have capacity to use that for cancer patients. So, we need all this improvement, but it can only be achieved if we can have investment in a urological investigation unit. In terms of interdependencies, obviously, because we currently still use endoscopy unit in Prince William Hospital for endoscopy work, so we may need additional staff for that work in urological investigation unit. I think, there's really not much change compared to what we are doing at the moment. The only thing I'm proposing is that we have an actual investigation unit in Prince William Hospital. The rest, more or less, is the same. Thank you.
Thank you very much. Very helpful. A question for me is, you identified one of the risks would be that although the staff complement is full at the moment, there's a question about whether you would need more staff. In the option proposed, would that require additional staff?
To be honest with you, we still need additional staff, particularly in terms of CNS, because we did inquire a study about CNS. We are very short on CNS compared to Swansea or Cardiff, because in most units they've got a cancer key worker who only do cancer work. For example, in Swansea they've got at least 2 specialist nurses that look at the prostate cancer. Currently we only have 5, 6 CNS because one of CNS gone off sick. And our CNS has to double up not only as a prostate cancer key worker, but they also have to do a lot of non-cancer work. So it dilutes their concentrations, if you put it that way. And they also put on more unnecessary duty on us, because in most units, like the Swansea, Newport, the CNS take on a lot of the follow-ups for prostate cancer, because a lot of prostate cancer need long-term follow-up, and most of them do not need treatment. And that then leave the consultants to do more clinical work. We are really, really down there, unfortunately. So the answer is yes, we need plenty. Yes.
Okay, strange enough, I didn't expect you to say no.
Yes, please, yeah.
Just for clarity, CNS is a clinical nurse specialist, which I think in urology is proving to be quite valuable in terms of some of their involvement in diagnosis work. So they're doing a tremendous job, and we do need more in that space.
They're cheaper as well.
Indeed. Colleagues, any thoughts or questions, any points of clarification? Clearly, we've got one option on the table here, or one slight variation of that in terms of the additional consulted option. But yes, please, Maynard.
A comment rather than think that this, like the previous discussion, is dependent upon capital investment in Prince Philip and changing things there. And I think when we're talking tomorrow about making decisions, we're going to need to be mindful of the amount of investment that is needed and whether we need Welsh Government support for those capital investments.
Indeed, Maynard. The point I would make is that the decisions we make tomorrow broadly give permission to the board to take forward these areas of work. There will still be other contingent factors and circumstances that will need to be addressed as part of that process. But what we are doing is we're endorsing and sanctioning this as a way forward. You're absolutely right. There will be other considerations that need to be brought into this. But if actually there's a business case for improving the efficiency, the volume, the effectiveness, and ensuring we meet standards inside this process, I think that's fairly compelling. The finance director might not agree with that, but yes, please, Eleanor.
Thank you. Thank you, Chair. You started on the question that I was going to go. Is my understanding that you have no staff vacancies in the current complement, and yet to provide a quality service as recommended by the Grift report, you need more people, and also you feel that you would be able to attract better skilled or more skilled people if the decision is made in this way?
Yes, absolutely, because one of the issue with recruitment is that, you know, most units throughout the UK now do have a dedicated urology hub. The reason is because, as Neil said, a lot of the surveys are now run by the CNS, the specialist nurse, and of course they are sometimes quite anxious if there's no consultants about. So with a urology hub, so you've got a CNS working in conjunctions with clinicians in the same building, in the same area. So this helps to basically improve their confidence. And for Newport, for instance, we've got CNS nurse doing flexible cystoscopy, biopsy of bladder cancer, laser bladder cancer. So this can only be possible if we got a unit where they know that there is a boss behind them, you see. So this can help to improve confidence.
Thank you very much. Alison, and then Neil, I'll come to you.
Thank you. It's just a question relating to some people's concerns around the impact on patient dignity of increased travel, given the nature of urology conditions. And I just wondered what the possible actions could be that could address that concern.
I think with dignity, of course, that we'll always speak to the patients first in terms of how they want to travel down, because we do have a CNS that the patient can get in. So what we normally do is that we've got virtual clinic consultations, and where we can have a consultation with the patient first, and then depends on what procedure they need. Obviously, with simple diagnostic procedures like flexible cystoscopy, it can be carried out in the respective hospital. And after the particular procedures, depending on if they need any more specialized procedures, then we can deal with the dignity at that time, so the patient will be confident to travel down to Princeville Hospital if needed.
Okay, thank you.
Very helpful. Neil.
Thank you. It was just an observation, actually, on the whole planned care session that we just heard. I mean, personally, I feel like I've heard some very compelling arguments. I think, having taken part in one of the conscientious consideration sessions myself, there was this tension that had emerged between a local service and a better service. And I think everything I've been hearing in the last, or since lunch, has been around actually improvement and additionality. So going back to some of the opening statements around the public's confidence in the Health Board, I think there's a real opportunity here actually to rebuild some of that confidence and trust by getting it right first time. But there is, of course, still lots to balance with it. But I just wanted to make the observation that I think that's been a really helpful, enlightening session.
Yeah, I would say nothing substitutes for that kind of face-to-face communication. I know when I was involved in some of the consultation exercises, you know, the conversation led to the outcome where people prioritised the quality of service over the travel. And yet they initially started that conversation with wanting, you know, not to travel. But the more they thought about what they wanted, they arrived at a different conclusion. There is something about how we communicate these messages and help people to understand that and work through the consequence of realising what they really want is the best possible service. And okay, as close as possible, that would be extremely beneficial. But sometimes that's just not going to occur. Good point made. Nikki.
Just one additional point I would raise linked to
what we heard during the consultation, while certainly across our planned care services, we heard from more respondents saying that they would be willing to travel further if it meant that they would have access to treatment sooner and obviously linked to a better quality of care. Where we heard that message less was when we were talking about the services we covered this morning around urgent and emergency. That theme didn't come across as strong when linked to services like stroke, critical care and emergency general surgery. So it was just to make that distinction between those groupings of services during the consultation in terms of overarching themes.
Very helpful. So there's a distinction for us between the planned and the unplanned care, and how communities and patients and service users kind of think differently in relation to those two issues and use different measures.
Yeah, and I think what was still consistent across the board was the need to support with accessibility. So even in that planned care space, an expectation from our population for the health board to be able to step in and do more there to make sure all services are accessible to our population.
Very helpful. Thank you very much. That's been enormously helpful for us. Sorry, Lee.
I'll just make one very quick point, just for board awareness. So with the urology, and the same applies to dermatology, back to Neil's point actually, what we're doing in these discussions is reflecting on some of the changes that were made temporarily during COVID, and whatever decisions we make will then obviously look to establish what the permanent arrangement is. So it hasn't come through very strongly in the conversation in urology or dermatology, but we did make changes during COVID that are now consolidated here.
Thank you very much. That's very helpful. Thank you very much. That's been enormously useful. Thank you, colleagues. We'll take a refreshment break for 15 minutes. Thank you.
you go. Yeah. Cheers, Susie.
Life is too short to be explored.
That's yours, yeah, I think.
Thank you, colleagues, for returning from your break. I hope you are sufficiently refreshed to give full and due consideration to our last two remaining services, the first of which is endoscopy. Can I ask you to kickstart the process?
Thank you, Chair. Good afternoon, everyone on the board. So you received the full slide deck. I'll introduce myself. My name is Faiz Ali. I'm a consultant gastroenterologist and clinical lead for endoscopy. I've been the clinical lead for the last 10 years. That's the time we actually really moved from having 4 separate endoscopy units to looking at endoscopy as one service across 4 sites. So all our pathways, all our protocols, everything match all across the sites. Now regarding this, and I've got Sarah Jones with me, our excellent service delivery manager. So the first thing, before we go through that, I wanted to really mention the point of real pride we have, which is Hywel Dda is the only health board in Wales which has JAG accreditation across 3 sites. Now, JAG accreditation really around endoscopy looks at a lot of features. It looks at everything around endoscopy, the quality of the process, safety, appropriateness of the procedure. It has to be patient-centered. It looks at the environment in terms of what the patient's going through. It looks at workforce and training. And really, for the last 10 years, we've been delivering that across the sites. Prince Philip has been the site which hasn't really had JAG accreditation. That was mainly because of the environment. The environment wasn't really set up in terms of patient flow. From point of JAG accreditation, it takes a lot of hard work to really keep on top of the waiting times. That's the biggest challenge, which is delivering urgent cases within 2 weeks and routine cases all within 8 weeks. But after COVID hit, really there was a lot of endoscopy stopped. We're slowly beginning to really get back to standards now, or we have gone back to standards. So now our routines all under 2 weeks. Our urgents all under 2 weeks, and the routines are under 8 weeks. We've got a massive surveillance backlog, which slowly we're trying to deal with. And even those numbers, we think within the next year, will be back within standards. Really, having JAG accreditation from my point of view is really, it's our commitment towards safety and quality to our patients. That's what we're really trying to promise them. Now, when we look at the case for change, as you can see, the biggest issue we have is really this rising demand. And that has been looked at, and it's a 5-year, year-on-year demand. And there's also increasing demand on inpatient endoscopy. And inpatient endoscopy probably accounts for around 10%. Now, because of the amount of elective patients we have, we don't tend to leave capacity for inpatient, we basically fit them in. But the trouble that happens is if you have many referrals on the same day, potentially that can lead to some of the elective endoscopies being cancelled, especially the routine stuff. So really we want a situation where we have enough capacity built in the system where unplanned work isn't really affecting our core activity, because the core activity really is GI. It's 85% of the endoscopy, although as mentioned, we do urology and bronchoscopy. But it's really delivering and really preventing patients' pathway being affected. So this growth happens despite us being very strict with our vetting. So around vetting, we have real policy. There's all national guidance, and we keep looking at guidance. There are some new guidance coming through the National Endoscopy Program, where we are looking at trying to decrease low-yield endoscopy. So the biggest group really is a gastroscopy done in people under 55. You can imagine reflux is extremely common. A lot of people have reflux. GPs are referring them for endoscopy mainly because they haven't really responded to any particular treatment. But we have now systems in place where hopefully we can reduce those numbers with things called a capsule sponge. The biggest thing we've introduced really over the last few years is FIT testing, which is stool testing for blood. This started in secondary care after COVID, but now it's been introduced into primary care. Because if you look at symptoms on its own, change of bowel habit in a 40-year-old, a 60-year-old might not be anything. And if you purely investigate on the basis of symptoms, we'd be doing a lot of investigations. FIT test really prioritizes us to look at the group which are really needed. But it will generate probably a bit more extra tests because more and more GPs will now probably use a FIT test because it is so good at trying to differentiate serious pathology from non-serious pathology. The patients we do get now are getting more complex. And the main issue with capacity is that what we've had to do is our baseline capacity hasn't been able to grow along with the complexity, and it's been really filled by having waiting list initiatives. There's been periodic insourcing. And the trouble with waiting list initiatives, on a short-term basis, clinicians and endoscopy staff can do it, but if it becomes the standard way to kind of respond to that demand, people just get tired. They get tired and burnt out, and we need much more a robust situation where we have that capacity built in. Now, we do look at robust workforce. That, again, is something we've been training. Clinical endoscopists are non-medical endoscopists. They can be trained to do gastroscopies within a year, colonoscopies within 2 years. There's a whole program developed now in Wales, what's called the National Endoscopy Program. And we already have several clinical endoscopists. And the thing about clinical endoscopists is their job plan really suits them to be able to backfill. When a clinician is away on holiday or they're on call, we get a lot of cancelled sessions. And the clinical endoscopists really are the ones who can backfill those. And again, it's a much more flexibility, and they become much more permanent members rather than junior doctors who might come in, we train them, and they, of course, go off somewhere else. So I'll go to the next slide, which is why it matters. And really, endoscopy is quite a critical factor in most, if you look at GI pathways in our hospital. I'll break it down to really 3 big things. So if you look at cancer, GI cancer is extremely common: colorectal, esophageal, gastric, and also pancreatic. A majority of these are picked up on endoscopy. A majority of these, really, to improve the pathways, we do straighter tests. So as soon as they have a significant symptom, rather than people being seen in clinic several weeks later and then have the gastroscopy, colonoscopy, a lot of these things we do as straighter tests. Now, we need to do these within 2 weeks. If you look at the single cancer pathway, we should really do it even quicker. We should really be doing it within a week. So cancer is a very big thing, which endoscopy does. There's a lot of people with chronic disease. There's a lot of people with inflammatory bowel disease, liver patients, and prompt endoscopy really is quite important, because if you don't do prompt endoscopy, these people can present with much more flare-ups. They can present with decompensation, much longer hospital stays. And I think the other big thing, of course, is the emergency of endoscopy. So 10% at least are emergency endoscopy, and this is where the impact on the front door pressures. So if you have a patient coming with a GI bleed, or let's say a food bolus obstruction where they can't eat anything, if we really had capacity within our system, we could scope them straight away. We'd still do that. We do as much as we can, but we need much more capacity built in, especially for the emergency workload. If someone comes in, very quickly we can do the procedure and really get them home even the same day. So less pressure on people having to stay in. And if people are staying in, try to get these procedures done very quickly. So the capacity in endoscopy is very important to be able to deal with these smoothly, rather than really on a daily basis fight how we fit these patients in. And probably finally a word just on infrastructure. Equipment is performing okay, but it does age, and there needs to be proactive capital replacement cycle. And the other big thing that's coming in is AI-assisted diagnosis. Because with AI-assisted diagnosis, we are picking up much more subtle polyps, which really are the precursors for cancer and everything else. And this is just not in colorectal, it's also in upper GI. We suddenly realize that there are a lot of missed cancers, especially esophageal or Bwrdd's, which is acid reflux related. So the more we kind of, I think, dedicate towards endoscopy, the more we have a real backbone for all these conditions. So I'll probably go to Sarah for the next one.
Yeah, good afternoon. My name's Sarah. I'm the Service Delivery Manager for Endoscopy and Gastro. So if I talk us through the options that were developed by the Options Development Group, they're all centred around a form of service expansion to meet the demand that Pfizer has described as the key case for change. So if I run us through what's currently running, this covers across 3 specialty areas, which is gastrointestinal services, urology and respiratory. Just as context for the board, which I think is important, of the activity we deliver in endoscopy, 85% is gastrointestinal, 10% is urology, and 5% is respiratory. So the detail Pfizer and I are going to talk us through today is predominantly centred around the expansion in gastrointestinal services. So current service provision, how does option A differ from that? So it essentially looks at developing an additional procedure room in Prince Philip in order to meet the growing demand that Pfizer's already described. And in Doing that, the proposal looks at bringing together respiratory and urology procedures so that we have a form of consolidation which allows us to make better use of equipment, not having to duplicate equipment across 2 sites for very small volumes of activity. It also then would allow us to increase delivery of gastrointestinal services in Glangwili, which is currently our acute site where we deliver most of our inpatient and emergency work, as Faiz has described. Option B then, again, a form of expansion, but looking at development of a new site in a community setting. So we would continue to deliver services as they are across the 4 hospital sites. And then the option looked at using that new site development for bowel screening. Although as a service team, we have discussed whether there would be benefits to looking to that as a general endoscopy community setting, not just for bowel screening. And then option C then, again, a different form of service expansion, not looking at increasing our infrastructure, but looking at developing evening and weekend sessions in order for us to increase activity. That would also allow us to bring together urology and respiratory procedures at Prince Philip, and again, increase delivery of gastrointestinal services at Glangwili. So just to recap, all 3 of the options developed initially through this process are all centred around a form of service expansion to meet that growth in demand that we have evidenced and expect to continue happening year on year.
Thanks, Sarah. So in terms of what we heard during the consultation and responses to the questionnaire, when looking at responses split between the individuals who identified as NHS employees and other individuals, you can see that option C of the options that Sarah's just talked through was the overall preference, followed by option B, then option A. As we move across to responses via postcodes and thinking about how people responded based on their nearest acute hospital site, you'll see that's where there is a difference in response. So for people living closest to Bronglais, option B was preferred, then option A, and then C. For those living closest to Glangwili, option B was preferred, then option C, and then option A. For those closest to Prince Philip Hospital, option C was preferred, then option A, and then B. And then finally, for those people living closest to Withybush Hospital, option C was preferred, then option B, and then option A. In terms of the wider discussions we had across our communities, there are some continued themes that we've heard throughout the day. So linked to travel, time and distance, there were strong concerns raised linked to how far patients may need to travel to access services, and particularly as we heard in the last service, there was concerns around patient dignity. So that need to access appropriate facilities, and when people are having to travel longer to access services, how that can impact on them as individuals. In terms of the benefits of bringing together the service, there was recognition that by bringing the service together, that could improve efficiency and quality. But as we've heard before, we need to consider the point of access and doing what we can as a health board to reduce those barriers. When options talk to extended or out hours appointments, again, like you heard in a previous service update, there were mixed views. So those who are currently potentially in employment raised that extended hours or weekend hours could be beneficial in terms of not needing to take time off work. In contrast, there were concerns for some of our communities around travelling, particularly for older people who may not want to travel of an evening, and where public transport would be required, noting that that does not run on weekends in the same way, and Sunday in particular was referenced as problematic in terms of accessing public transport if appointments were on a Sunday. You would have seen in one of the options, it was mentioned around a diagnostic and bowel screening hub with location to be confirmed. Lots of respondents told us that it was really difficult for them to share their views on that diagnostic hub and the potential impacts that might have without knowing the location of that hub. And in order for the health board to be able to mitigate that, a clear location would need to be communicated. So I'll hand back across to the service.
Thank you. So this was the public and staff suggested alternative. Now, alternative option 2228 was really option B, but I think they mentioned having bowel screening with the bush. Now, one thing I'd need to probably clarify here is the endoscopy, which is OGDs and colonoscopy, which are done. Really, what decides which is done in the community is really according to patient and the indications. So when it comes to bowel screening, although we say bowel screening, a lot of it could be done in the community hub. There's no question bowel screening still needs to be done in the acute hospitals because we do a lot of therapeutic advanced procedures in bowel screening. We remove very complex polyps. There are also patients who have defibrillator. There are patients with significant factors, frail patients who can't really travel far away. You have to deliver colonoscopies locally. So what we're talking about a community really is an extra site where we do extra endoscopy. Now, the bulk of it could be bowel screening, but it's not exclusively bowel screening. It doesn't mean that bowel screening will not happen in the other sites. We look at capacity and, it's we have the equipment, we have the clinicians. It's about having an extra site to deliver. So next slide. So I think when it comes to the options, essentially option A, which is having Prince Philip, was the one that was preferred. Now this is the one with Prince Philip being a 3-room site. Now when we actually look at Prince Philip, this has been developed before. Prince Philip actually have the space for that 3rd room. I think they have the estate, they just needed the redevelopment. It's something we've discussed with JAG regarding the environment being up to what they expected. And as I mentioned before, when you look at all the other quality indicators, Prince Philip is exactly JAG standards as per all the others. The option C was the next one, which was the extended hours. And again, with the extended hours, it is issues about how how sustainable that may be. And then we had option B, which is having a community hub, another site where we do endoscopy and potentially other services. So next slide. So I'll just go through from what options best fit the needs of the population. So for us, really, it is it's option A. This is something we feel can be delivered over the next few years, and it is about Prince Philip having being reconfigured. So from a 2 rooms at the moment to become a 3rd room. We have a unit that will be JAG accredited. It's a service where I said we can help urology and bronchoscopy do their endoscopy cases with. There will be some capital funding to deal with this. The option B is really something much more long-term. This is more long-term, and it depends on really having capacity for future, because endoscopy is such an advancing field. If you look at what was happening several years ago, a lot of these advanced polyps would have surgery. Nowadays, they're just dealt with endoscopically. A lot of cancer treatments, stents are being put in. So a lot of the surgical things that used to be done, endoscopy is beginning to do. So really, this is more about future development. And what you need really is another site which can actually start doing a lot of the cold, or what we call the low-risk type procedures. The bulk of procedures, we still need the acute endoscopy done in the major centers because they do a lot of the inpatients. So what the community hub does is allows low risk, so straightforward bowel screening cases, OGDs, colonoscopies. It won't be suitable for things which still have to be done in the acute site, like ERCP, which is to do endoscopy in the bile duct. Workforce projections is something where if you do have a hub, I mean, already we're doing extra workload for Swansea around bowel screening. We're basically probably the only health board which are more on top of times for bowel screening. There's a lot of demand for us to try helping out Swansea with their bowel screening workload, and having Prince Philip developed, and again the hub I think will help in that. So yeah, probably next slide, Sarah.
Yeah, so thinking about the key dependencies that we need to consider, Faiz has obviously already touched upon how endoscopy is key as a diagnostic and treatment function for multiple cancer and non-cancer pathways across GI, urology and respiratory. So a key dependency is continual demand modelling so that we can adequately plan capacity to maintain that timely procedure delivery, but also keep pace with annual growth. So we have evidenced over the last 3 years a 5% increase in diagnostic GI work year on year. We anticipate that to continue, so we need to keep at pace with our capacity plans to avoid generation of increased waiting lists. Population changes are also an important factor. The expansion of the bowel cancer screening programme is an example of that. Quality and safety needing to remain central, so Faiz has described the Joint Advisory Group's accreditation and the standards that sets out for high quality, safe and timely endoscopy services, and that certainly is an accreditation we wish to maintain as a health board. Workforce availability and that continued investment in training is really critical to each of these options, so we need the right quantity of staff and the right skill mix of nursing, healthcare and decontamination staff, as well as those medical and non-medical endoscopists. Faiz has touched on the development of the clinical endoscopist role as an alternative service model to increase endoscopy capacity. As a service, we've invested in endoscopy nurses who have trained as clinical endoscopists for the last 3 years. It's a 18 to 24 month training programme, so we need to be on top of that year on year to develop that future workforce so that we can meet the service expansion models we've described. And then the physical estate obviously is really key in order for us to deliver sustainable services. We need adequate procedure rooms, decontamination space, and of course the appropriate supply of equipment. And just one note that we haven't touched on is the option of a community site or the development of a third room in Prince Philip perhaps lends itself well to the development of regional or national collaboration opportunities. Faiz has touched on that we already work closely with Swansea from a bowel screening perspective, but looking at future service expansion models, workforce resilience, looking at regional partnership, which would certainly strengthen the viability of some of the options we've described. So if I just draw us to a close, thinking of the options described on the slide here, as I said, we can evidence a 5% growth in demand for gastrointestinal procedures and endoscopy, so we need to keep at pace with that growth in demand. And really, a consideration for the board, we have to be looking at a blend of two of these options in order to keep at pace with that growth in demand. Otherwise, we risk ourselves generating further waiting list backlogs. So the option of an initial proposal to develop that additional procedure room in Llanelli, that gives us opportunity to expand our infrastructure, with then the future option of increasing operating hours to evenings and weekends. But in 4 years' time, if that proposal is to take that long to be developed, we would also then need to be looking at that community model or indeed an alternative model of service expansion. Otherwise, we risk ourselves not keeping up pace to that demand growth I've described today. Thank you.
Thank you very much. That's been enormously helpful. Colleagues, thoughts or questions? Sarah.
Thank you. So I haven't seen reference in the material particularly around workforce recruitment. So I know for some of the other services we've talked to, they've said we can't recruit into these roles. Is that a challenge you face in this area, or are there staff there but we just aren't able to employ them currently?
It was an issue many years ago, but the National Endoscopy Programme, which has been in place for many years now, has looked at tailored training for endoscopy across all workforce elements. So we, in the 3 years I've been in post, we've always successfully been able to recruit to endoscopy nursing posts. Often we're looking at training our own as well, so healthcare support workers are now able to partake in tailored training to become a registrant working in endoscopy, which is excellent. And also, if we think of the clinical endoscopist function, again, we've had 3 clinical endoscopists partake in training over the last 3 years who were formerly our endoscopy nurses. So we've really worked hard to develop that career pathway within the service, which puts us in a place of greater resilience for future expansion, because if we're realistic, we, as many other services have touched on today, sometimes struggle to recruit to Withybush or Bronglice, but when we've looked at internal grow your own programmes, that's allowed us to enable that resilience to expand the service as is required. So the availability or the provision of staff, I would say, is not an issue, but I think that endoscopist post is where we may see challenges unless we invest in that internal grow your own programme, because we know we've got a high proportion of our consultants delivering endoscopy who are in that 50+ year age category. So if we're growing our own to keep a pace at that, we avoid having a gap in service provision then.
I'll just make a comment regarding endoscopy. So really with endoscopy, a lot of clinicians are delivering maybe 1-2 sessions a week. With endoscopy, really, it's around job planning. So when you have the real expert endoscopists, what you want them to be doing is more. So it's a model which England has. If you have bowel screeners, they do a lot more of the bowel screening, colonoscopies. So really it is. I think at the moment, this is more around gastroenterology, but it is about also recruiting consultants and really have job plans where endoscopy, really people are delivering more. So I do 4 or 5 sessions at least, and I have several colleagues like that. And if you have those delivering the core stuff, it makes a big difference. Plus, as you said, we have things around the nursing staff.
So just to come back to your question, I think what we require is additional funding to increase our workforce. It's not a workforce supply challenge. It's needing more to meet those expansion models that we've described.
Perfect, thank you.
Okay, just to clarify, we're not the bank of the NHS. We appreciate your financial challenges. I suppose this exercise is in terms of the service change and how this might impact on the wider population in those circumstances, notwithstanding the things you've said. Lisa.
Yeah, thank you. So in terms of the workforce, from the analysis that we've been able to undertake, it would require significant additional workforce. So we would need a very robust workforce plan, because we'd need more than 2 people being trained a year, because it would take a very long time numbers that we think are in this plan at the moment.
Great, okay. I'm going to come to Neil, but using Chairman's prerogative, I'm interested in the community development, the community provision element, because it feels to me, if we were to future-proof the kind of work that you're engaged in, increasingly it's likely to take place in communities in the future as technology evolves and the opportunity to mobilise screening services in all kinds of different places. I wonder whether you had a thought on that.
Yeah, no, that's right. I think a lot of this it's diagnostic. It is kind of high volume stuff, and a lot does happen in communities. There are these models in England, especially outside Europe, in America, and you can move a lot of stuff into the community, because what you want to separate is, really high volume diagnostic, very important cancer related work, to the emergency work, which is really how it's affected at the moment. And there are also newer ways, techniques which are coming through. The transnasal is something where you can do through the nose. It doesn't really require much sedation. People can be discharged. So there's always new developments coming through. But that really is a future. And that's why we said it's a model for something we have to develop, we have to look into. And maybe not something straight away, but definitely after 4 years.
Great. It feels to me that would be, having some coherent sense of what that might look like for your specialty as we think about the future would be enormously helpful. I think it would be really, really helpful. Neil.
Thank you. Well, you kind of asked the thing I was interested in. No, it's okay, don't apologise. It was 2 things. So just, again, for clarity, it feels like we're moving from an A to a B here as a direction of travel. I just wanted to make sure I got that right. And then it was around the community element, which plays into prevention, which we've touched upon today, but we haven't really majored on, which feels like, again, should be a really important part of our considerations. So I was curious about, is it a new site or a new service for communities. And I think that was
Yes.
kind of what your question was.
That's a good way of articulating it.
I don't think I need to labour that, but that was where my thinking was going. Thank you.
Yes.
So I would say it's a combination of the two. So it would allow us to expand service delivery, but there are many services that we're already delivering that don't necessarily need to be on an acute site. They need to be in an endoscopy theatre, but don't need to be at Glangwili or one of our other sites. And as Faiz has touched on, those new service methods within endoscopy, that lends itself even further to a non-acute setting for endoscopy.
Very good. Thank you very much. What we appreciate is that you've articulated where you think the demand is going to increase in the future and the degree to which that's going to increase. So I think your forethought around just workforce planning and understanding how that service could be developed to meet that demand is very much welcomed, and look forward to. The question is whether, as you formulated it, that's the best way to meet or satiate some of that demand coming down the track in the future.
Yeah, that's right, absolutely. Because at the moment we're relying, as you said, on waiting lists, insourcing, and really it isn't sustainable. It's very expensive. All they can be delivered, and we have very good staff within the health board delivering it. But I think it's something we realise that we can't keep doing it year on year.
And as well, we will very quickly reach a point where we will have saturated our available endoscopy theatre capacity. So the alternative options that have been proposed are all around how we prepare for that time and avoid them being in a situation where we don't have the right amount of capacity.
Very helpful. Diana, do you want to come in? And then I'm going to come to Phil.
Diolch. Thank you. Several times references to the bowel screening cancer colonoscopy services. And I just want to check, do you have any estimates which option will be decided, how much could we increase our performance, improve rather our performance, considering we meet about 40%, at best 45% of our patients that are referred for colonoscopy within the date are seen within 4 weeks or have an undertaken colonoscopy within 4 weeks. And we have only about 60% uptake, less than 60% uptake. Screening. So if we were to increase the uptake and if we were to improve our performance for colonoscopy waiting time for screening, have you entered any of these calculations in which of those options would enable best that?
So for options, we look at anything which increases capacity. So for bowel screening, I said there's big challenges right across Wales, across all the sites. And it needs to be delivered in 4 weeks. We're kind of 5 weeks, 6 weeks. I think a lot of health boards are even longer. But once you have increased capacity, then you can actually start doing more and more bowel screening now is happening compared to what used to come as a straighter test or patients coming through clinics. So that activity of bowel screening is going up. But as you said, as you have more capacity, we can actually make sure that we also are on time. And this is around the workforce as well. So there's only 4 bowel screening colonoscopists. We actually have more than probably other health boards. And it's making sure those individuals are doing more bowel screening, rather than having to do 3, 4 different, juggling different roles.
Indeed. Thank you. Phil?
Look, thanks very much. I suppose, of course, you're describing the increasing demand, which we're going to have to find different ways of managing that. I suppose it also means that every endoscopy we do has to be really of high value. And I think probably us, like all endoscopy units across the UK, would have a proportion where actually the value, when you screen it sort of properly, would probably be questionable. So I guess that has to be part of our thinking. I know it will be, but we're going to have to get even better at it. And maybe AI will help us.
Yeah, and the good news, it is a very big topic. And although the British Society of Gastroenterology, I don't think there's actually new guidelines coming through called low-yield endoscopy. And this is purely around it. And a lot of it, is around the gastroscopy for a lot of people with chronic upper GI symptoms. But also kind of control things around the lower GI, around the use of FIT. There are also some new tests coming through where even the FIT gets better. So the idea with endoscopy is we would be doing on the ones really needed, I think we'll never be able to stop some of these low-risk cases because it's a patient factor. A patient significantly affected by significant symptoms, going to GPs, A&E. Some might be doing, but the idea is to reduce that number to as low as possible.
Okay, Mark, and then I'm going to close the
As you
item.
probably have got, the discussion in endoscopy is different to other services. We are very lucky in Hywel Dda to have a service that reaches the highest standard. And that's been something that has been the case for a number of years. And despite all of that, we are still seeing that 5% increase every year. And there have been real significant changes. And the endoscopy team have been at the forefront of all the important changes as Fires has described. And they continue to do that. But despite that, we are still seeing the 5% increase. So change is absolutely still necessary.
Okay.
And as we said, we have been relied on for 15 years, waiting list initiatives, weekend working, which it has never been sustainable because it's not within how we should be providing our business.
Yeah. Thank you very much. That's been enormously helpful, and we'll obviously give it further consideration and make our decision tomorrow. But thank you very much for coming today and sharing your thoughts. Great. Okay, I'm going to move us on to radiology. Great. Okay. Okay. Thank you for joining us. When you are ready, if you'd like to share your thoughts. When you're ready.
Yes, thank you. I'm Dr. Khan, consultant radiologist and clinical lead for radiology.
You need to pull towards you.
That's fine, thank you. Sorry, I'm Dr. Khan, consultant radiologist and clinical lead for radiology. Case for a change in radiology is immensely important at this point. Within the radiology, the demand for imaging has grown exponentially over the years, and everyone is well aware that modern healthcare is heavily dependent on the imaging, and imaging is at the heart of the managed care nowadays. And in many pathways, imaging is the gold standard for the diagnosis and monitoring of the disease processes. The case for change has got a scope in radiology with respect to the recruitment challenges, because in the last few years we have seen that a lot of retirements and recruitment challenges of the substantive positions in our health board has significantly, increased our, our direction towards the outsourcing and locum staffing, and it has got its own, adverse effects. Overuse of agency and locums can lead to a poor quality of services, and obviously it is very expensive as well for the health board. And the standard of care is also not always expected. It also means that the substantive consultant radiologists, they are being overused, and the need for their training and their professional developments not up to the level, because they don't get enough time to develop themselves in their roles. So that has been a big problem currently. Delays in replacing our equipments has been another problem, and overloading of the current equipments because of the underfunding and space and state constraints to accommodate new equipments has increased the down times, which has adversely affected the waiting times, and it's a lot of heave and cry with respect to the patient's anxiety and their families. So in these three areas, which are of a serious concern for a radiology point of view, from the imaging point of view, is the staffing, equipment replacement, and obviously immensely increasing the workload. So these are the areas where we think that there is a case for change, and we have to work in these three main areas where we develop the plans for that, and then Sarah will going through the options and what best options we think that would bring the change for us.
Good afternoon, Sarah Proctor, Deputy Head of Radiology, Registered Radiographer. The four options were developed by the Options Development Group. Just to start with, that all four options do not affect emergency scanning at our four main sites. That will remain 24/7 access for all emergencies and inpatients. Also, that all four options identified closure of X-ray services at Llandudno and South Pems. Two of the options, B and D, look at increasing the number of planned outpatient scans we perform by extending the working day into evenings and weekends. One of those two options, option B, involves developing a new diagnostic hub. Options A and C do not change the number of planned diagnostic procedures, but look to centralising interventional radiology services, which is something that we do have issues with. On to Nikki.
Thanks so much, Sarah. So in terms of what we heard for in the questionnaire responses linked to the radiology service, so when we look at the groupings of NHS employees and other individuals, option B for both groupings was the preferred option, followed by option D. When you look at the third and fourth preference for NHS employees, that was option A, then option C. For other individuals, there was very little difference between option A and option C in terms of preference. So moving across to postcode responses and how people, what people's preference was based on nearest acute hospital site. For people living closest to Bronglais and Glangwili Hospital, option B was preferred, then option D, then option C, and then A. For people living closest to Prince Philip and Withybush Hospital, again, option B was the preference, then option D, followed by option A and option C. As we move on to the next slide, in terms of what we heard during our conversations and those open field questions within the questionnaire, one of the key things to note from the consultation was linked to Llandudno Hospital. So as Sarah talked about, in all options that we consulted on, there was a proposal to remove radiology services from Llandudno Hospital. We had a huge presence when we held our drop-in event with that community. There was certainly some misunderstanding linked to the potential closure of Llandudno Hospital, which is obviously not what the option was proposing. It was specifically linked to radiology services. But as well as that, during our conversations, we heard concern around the removal of radiology services and how that might impact the minor injury unit that was temporarily closed due to COVID. Moving on, there was also some confusion by some respondents around planned radiology services and emergency access, and people were worried about where they should go in an urgent and emergency situation. In terms of retention of the current status quo, so where services are currently being provided, there were some respondents that were keen for their for radiology services to be retained across all hospital sites, and particularly that was a strong theme linked to Llandudno, as I mentioned earlier. In terms of staffing assumptions, we heard very strongly from some staff working within radiology services that the consultation document suggesting that 12-hour shift patterns could be referable and help address some of the challenges with workforce, was not reflective of what some of the staff felt. And they felt it could negatively impact recruitment and retention of staff. And then finally, on improving access and capacity, there was general support for some if it actually results in improved access for patients. However, there was, as we heard previous services, concerns linked to extended hours and where services are brought together across fewer sites, and whether that can be realistically staffed and how that impacts our public and communities in terms of transport as well. So I'll hand back across to the service.
So there were a number of alternative options. We had quite a few, which were suggested by public and staff during the consultation. There were 4 of those which met hurdle criteria. So the first one is option 24. This is a variation of option B with no diagnostic hub. It would extend working days at all 4 sites and included the cancer focus at 2 sites. The cancer focus was to allow patients undergoing multiple tests during cancer diagnosis that they could have all their investigations on the same day. Option 25 is another variation of option B, but with a smaller diagnostic hub. As in option 24, extending the working day at all 4 sites and a diagnostic hub, but a smaller hub than the original option B. Next slide, please. Option 103. This is a mixture of option A and B. So there would be an extension of working day at 2 sites, a diagnostic hub, the cancer focus at 2 sites, and also the centralisation of inpatient interventional on 1 site. The last option was option 122, which is the current service configuration. The only difference was extension of the working week to 7 days a week of X-ray services at Cardigan Integrated Care Centre. Next slide, thank you. All 8 options were scored during a clinical-led options appraisal. The highest scoring option was 103, closely followed by option B. 103 scored the highest in 3 domains: safe, accessible and kind, and option B scored highly in sustainability, although to be mentioned that also option 103 was very close in sustainability as well. Next slide, please. The radiology service agree with the options appraisal group that 103 is the best option to tackle the issues identified in their case for change. The implementation of the plan would need to be staged due to requiring the building of a diagnostic hub. However, in the first 4 years, which it would take to build a hub, the plan would be able to start implementing with the extension of the working day at 2 sites and the centralisation of inpatient interventional services at 1 site. This would provide some stability, improve staffing levels and help to meet demand. Until the hub was implemented, there would still be reliance on outsourcing. However, this would be reduced over the 4 years. This option would allow the service to recruit and provide a more attractive configuration, particularly for interventional radiology. It would be easier to recruit and maintain a substantive service if it was based at 1 site for our most urgent patient, but allowed our non-emergency patients to have planned interventional at a hospital nearer their home. There is a risk that there will be an increase in inpatient transfers for interventional radiologists, but this is already happening in the service anyway, and it's not envisaged this would increase it greatly. So at present, lots of interventional patients need to be transferred to Glangwili at present. There is a risk that the workforce challenges would persist, particularly around interventional radiologists. They are difficult to recruit to. However, Centralisation of the service somewhat would help us to work more regionally with Swansea Bay, who are also having some issues with interventional radiology. It is a UK-wide issue. The longer-term phase, which in this option is the hub being built. Benefits are providing a purpose-built diagnostic hub would include improved retention and recruitment, and co-location of services would result in improvements in efficiencies. The hub will improve diagnostic waiting times to meet diagnostic targets for routine RTT patients and cancer patients. The risk is obviously the capital investment needed to build the hub. Next slide, please. So the key dependencies are, so patient travel. The removal of X-ray services at Llandovery Hospital will result in up to 27 patients per week having to travel further for X-ray. South Thames Hospital Service only recorded 2 attendances last year. The interdependencies are emergency services of all 4 sites will remain as they are and unchanged, which is that X-ray and CT services are provided 24/7. We have some equipment challenges, which the X-ray machines at Llandovery and South Thames would need to be replaced with digital technology in order to be used after July 26. This would require a Welsh Government funding allocation and would need to be prioritised above other essential equipment which is due for replacement. Just for context, that is at present the GGH CT scanner and the Withybush gamma camera, both of which are end of life and will significantly affect patient care and safety. We do feel that there would be some more regional working, so the regional diagnostic programme, which we are part of and work closely with, we need to consider how this can be combined to increase capacity and reduce risk across some of the services with some of that regional work that we could take part in. Thank you.
Okay. Thank you very much. Very helpful. Can you just clarify for me? So you indicated 27 patients per week X-rayed through Llandovery Hospital.
Yeah.
I thought it was only used 1 session a week.
Yeah. So it's 1 day, which that's the most that could be in. It's usually around 15, mostly because we do struggle for patients to attend Llandovery, even if they're offered the choice. We have open access X-ray at both Glangwili and PPH, and some patients would choose to do that rather than even if they lived in that area and were offered Llandovery.
So they choose more often to go to the other sites than to use Llandovery.
Partly, I think, because we only offer it 1 day a week, so some patients would want to be seen. So I do understand that Glangwili offers 7 day a week X-ray services, so that's more convenient for some patients.
I'm sure. Thank you for the clarification. Colleagues, questions?
I suppose it's back to the same question as I asked Lee earlier on. There's been quite a few of these now, same themes kind of regarding capital investment. And when it comes to tomorrow, with the decisions and looking forward, how much of that detail are we going to get? Because we need to be quite clear. There's quite a few options here that is reliant on capital monies being pumped in the next 4 years or so. So I just wanted to get that clarity thinking forward, because it's been made quite clear. I think it's which one was it? Option 103, I think, was was it the preferred one, kind of within this kind of within radiology, but also it requires quite a bit of capital injection. So
with the community hub ostensibly on the cards at some point in the near future. I don't know if you want to respond to that.
I'm happy to comment on it. So I think it's probably fair to say within radiology we have physical capacity at present to expand our activity. So that is why at the moment what we're describing is that we'd be looking to maximise the use of that physical capacity in the first instance. But similar to endoscopy, what we're looking to do here is get ahead of what we can forecast in terms of projected demand from the population, because obviously anything along the lines of a new hub which would be tens of millions of pounds potentially of investment, takes quite some time to get in place. So that's us thinking 5 years, or at least 4 years ahead, for endoscopy and radiology, and thinking about whether we would want to achieve that. There's a bit of a chicken and egg to these discussions. Yes. So in the first instance, we're testing boards' appetite and the services' view on whether that would be something we would aspire to, and if it is, then obviously we could commence a business case process, but that would be sometime in the future, and obviously subject to Welsh Government support.
Thanks.
So I think it goes back to my earlier point, which is what we're being asked to do as a board is to consider and evaluate each of these 9 services and provide a degree of endorsement for what we think is the right approach. That approach will then need to be subject to quite a lot of rigour in terms of its financial profile, in terms of all the challenges that will present as that enterprise is taken forward. So we're not saying this will be done by this date. At this level, what we're saying, everything you've just said, Lee, with the added fact that we have listened to the community in response to what the community would want to happen inside this space as well. So it's merely a license. In effect, we're writing a license for these services to be developed in this way, subject to the appropriate business cases and opportunities and challenges being met in the future to deliver them. You can come back
just
on that.
quickly on that then. So having listened to the discussion now, and some of the equipment will be running out, or will be past their lifetime by the end or middle of this year. How do we proceed then? Because there's some things that you have to make a decision on quite soon, but then we're also looking at the proposals moving forward. So there's that's also a chicken and egg, really, isn't it? But
that is not for us to consider. It is a moot point, and one we'll have to think about carefully. Yeah. And I dare say there's already work underway to capitalise or think about how we can replace that equipment. That is not for us to consider as part of our decision-making process, though. Eleanor.
Diolch, Cadeirydd. Very quickly, we're always looking at efficiency, and the move to 7 days a week across some sites. Do we have the capacity to deliver that, and would that have an impact on recruiting staff, either positively or negatively?
So we would require additional staff to be able to move to 7-day working. We already work 7 days. It's just that we're using staff are doing it as extra or doing on call, etc. We've got a service that's based on an on call, which is working at a level. I mean, years ago, people would come in to do a couple of patients a night. Now they're scanning 20 to 30 patients on some sites on their own. We have some safety concerns, a lot of lone working. So we heard loud and clear during the consultation that some of the staff were not happy with the term that staff would prefer 12-hour days. We do find that that is what's being asked for. So that is done in every hospital, apart from ours. So every hospital in Wales would be doing these kind of shifts, these kinds of shift systems rather than an on-call. We're rather behind in that
Thank you. That's really helpful to hear explicitly. Thank you.
And what we hear loud and clear from a lot of the radiographers is they want some flexibility. It's very difficult to be flexible with working times if you only work 9 to 5 Monday to Friday and the rest is overtime. So I think although there are staff who would not want to work 12-hour days, there are ways of working around that to allow them the flexibility to have days off, a bit more work-life balance. The radiographers do not have a work-life balance at the moment. They work nearly every weekend. It's not easy for them to take time off, even their leave sometimes. So I think it's the change scares some of the staff, but I think that there are a lot of positives with that. And yes, there are some staff that wouldn't like that, but there are a lot of staff that would.
And it would allow you to elongate the day.
Yes.
But it seems to me it's a 7-day rota in effect, isn't it, that allows as much flexibility as possible built into that process to meet the needs of staff.
Yeah. And building the well-being of staff.
Yeah. Of course, because 12-hour days are immensely long and challenging, and some people would want that, but I can clearly imagine others would not.
Yeah.
It doesn't matter if it brings benefits of having more days off per week. Sorry, Lisa, and then I'm going to come to Phil.
Yeah, thank you. So, yes, there are some significant numbers in here for workforce that we will need, and bearing in mind the challenges that we currently experience, which have been pulled out in the paper, it's something, again, that we'd need robust workforce planning around to be able to attract those staff.
And I suppose it begs the question of how do we create something sustainable inside this space? Because recruitment is not sustainable in itself. You know, you can only go back so many times to the market. How do we grow our own? How do we develop that culture of regeneration within this specialist service?
So we're desperate to grow our own within the radiography profession. At the moment, that's not offered in Wales. It is offered in England, but not in Wales. We have numbers of staff who already work for us at a band 3 level who would be wanting to undertake that training. They don't want to undertake the training as it is at the moment, which is a 3-year full-time degree in Cardiff. They want to be able to do that, and that's what we would really like to do. That we feel is that's the way out of the situation that we've got at the moment. We have struggled with radiographer recruitment, but we are now getting more applicants than we have places for, which is encouraging. What we're struggling with is staff who are trained, so we're having to take staff on, newly qualified, and training them up, which takes some time. I'll let Dr. Khan talk about radiologists, because we've been very successful with growing your own radiologists.
Yeah, from the radiology consultant's perspective, we have adopted a model where in the last 5 years we have recruited young consultant radiologists who are qualified from UK, but they are not trained from UK. And we picked them up, and then we are giving the required experience to them. And in 2 years' time, they are capable of applying for substantive positions. With this model, we have filled around 5 consultants through this model, and now 5 more locum consultants have been recruited, and they are in this process. So we found that this is a better model to generate our own consultants rather than relying on from the UK market, because it's very difficult to retain them and attract them because of the geographical limitations we have. So we are working on it, and then we have increased our capacity so far, but still we are far behind the standards. If I give you the example of this Swansea Bay, which is our nearest health board, they have got more or less similar level of population and activity. They have got 28 consultants working there for them, and we are working, our establishment is only 18 consultants. With some locums and some specialists we have attracted, now we have grown to 22 consultants at the moment. So we are far behind even from our nearest health board. So the establishment needs to be increased to cope with the demand we are having at the moment. So that is something which we can ask the board to consider, to increase the establishment, because whatever we are recruiting them, they are against the Everlight bills and that, but we don't have our actual establishment increased over the last 9 years.
Okay. Thank you for that case for increasing your establishment. I'm reassured in terms of what you've said about thinking around sustainability in the long term. I'm sure as a board we are, because we worry enormously that actually if we can't find a way to do that intrinsically within the organisation, then we're always going to be subject to market forces, and those are often financially very cruel.
Yeah, absolutely.
In terms of how we think about the future. So, but thank you for sharing that information with us. Maynard, I know you're coming in, and James, and then Phil, and then I'm going to close the item. James, do you want to come in first? Because I thought you might have a view on this, and then I'll come to Maynard. Oh, okay. Neil, come in. Sorry, go ahead. You come in. Fine.
Thank you, Chair. There we go. So it's just to, was raised. The second point is just to confirm and I suppose reassure the board that the conversations with Health Education Improvement Wales regards the apprenticeship scheme for radiographers as part of a wider workforce plan has already been undertaken. So just as we consider that as part of our considerations over the next day, it's an action that's been taken.
Very good. That's good to hear. Neil, did you want to come in?
Very quickly, thank you. Yes, sorry if I've missed this, but it seems to me as well that we've talked about Llandovery and South Pembrokeshire needing their equipment to be replaced by July. So if I'm reading that correctly, we're kind of at a decision point with that almost immediately, aren't we? And the second thing I just wanted to double check was the numbers at Llandovery. So I think that's about 1,400 a year. Again, apologies if I missed it. I don't know if that's a lot or not. So it was just a bit of clarification.
Okay.
Thank you.
Would you, before I come to Phil, would you like to clarify the issue on the numbers at Llandovery?
So yes, that's correct, and that is the maximum numbers. Really, it's in theory is less than that.
So that's the maximum that can be delivered on the basis of using the facility, the X-ray machine 1 day a week.
That's the maximum number of patients we can get to go to that site.
But I think the conversation there was that people, because of the lack of the rigidity around the provision of that, people choose to use the other facilities because there's more flexible time.
Just for context, we do about 10,000 X-ray examinations across the Health Board per month, so it's a very small number compared to that.
Very helpful. Yes, please.
Yeah, my point was partly in response to Rodri's question, really, because just in terms of the implementation of whatever we agreed tomorrow, as Lee said earlier, we will at some stage bring back an implementation plan for the whole programme, and for the points that are in the long term which require capital, of course they'll be subject to a business case process. For the decisions that are more about implementation and improvement, so more in the sort of the 2 to 4 years, there will be a range of dependencies. So some of them will be more complex in their delivery plan than others, I would anticipate. But on the point that the specific point that you've both raised about the machines coming up to the end of their use, I think in that situation, when we don't have a new machine arriving, the team will already have business continuity plans in place to look after the patients should those machines stop working, for example, tomorrow. So we do have those, I'm seeing nods from colleagues, we do have plans in place for that anyway. I suppose what we're being asked is to agree that as a service plan going forwards.
Thank you. I would just re-emphasise the point that obviously that's clearly material to thinking about the equipment in the future, but our decision here is about which way forward and which option we think is appropriate, and how we balance that against the voice of the community in terms of their contribution to understanding what we might do in this space as well. So that is our primary concern. As a board, we can leave the headache of machine replacement and licensing to the executive team, who will have to deal with that and come back to us in the near future. Thank you very much indeed. That's been enormously helpful. And yes, thank you for your time and your contribution.
Thank you.
In the interest of time, I'm now going to take us to our last item, which is the role of acute hospital sites. Nikki, I think you're leading on this. Great, okay.
Yeah, so I don't think we need to spend too much time...
Pull the microphone in, Alex.
Oh. I don't think we'll need to spend too much time on this today, because actually this is more something that will come through tomorrow. So this came about as a result of the options development process. So back before the consultation, we were looking at services, they were put together as a collection of the 9 services as a single option. And it put forward what it could look like across our hospital sites in options 1 to 4. What that meant as a result is that it indicated a picture of what that could mean for our hospital sites if you put all those changes together. And where we are now after the consultation with all these additional options that are coming as alternatives is that depending on the decisions that you make tomorrow, when they all get added up, they could have a cumulative effect. Now, what we did during the consultation is we actually asked the public, based on what the options could mean that were developed as part of the consultation, we believe that it could have particular impact at the sites and it could change how we plan future provision of care on those sites. So if we know that a site is likely to have more acute care delivered from there, that we'd want to make sure that the right services are co-located with them. Whereas if it was more of a high output community or day case provision, that we'd have like services with them as well. So that obviously will change depending on the decisions we got tomorrow. But I suppose it is worth noting that this came as a result of the options work. It wasn't something that led to the options work. So we didn't come forward with this view and say, right, can you look at services that conform to this? Rather, this is a finding of that bit of work. So I'll hand back over to Nikki now.
Thanks, Alex. So as part of the clinical service plan questionnaire, we had that question on the future roles of our hospital sites. And each of the acute hospital sites had a summary outlining, based on what we know, what we feel that future role could be for each of the 4 acute hospital sites. So you'll see on the slide that this is similar to urology in that it's not about options. Instead, it's around whether respondents either strongly agreed, or disagreed, or strongly disagreed, or didn't know. Just as a point of clarity, there were 82 respondents to this question that selected don't know, and you can see on the slide the split between NHS and employees and other individuals. They aren't being included in this response, aligned to obviously standard practice. So looking at what we heard, 4 groupings of NHS employees and other individuals, there were similarities with both groups tending to agree or strongly agree, making up 40% of the responses, whilst disagree or strongly disagree with the summaries of the future roles of the hospital site, making up another 40%, and then fewer than 20% of respondents to this question neither agreed nor disagreed with those summaries. So moving across to the next slide, when we look at what we heard based on nearest hospital sites, for those closest to Bwrdd and Withybush Hospital, more respondents indicated that they disagreed or strongly disagreed with the summaries for the future roles of the acute hospital sites. For those living closest to Glangwili and Prince Philip Hospital, more people indicated that they agree or strongly agreed with how the future roles of the hospital sites were summarised. So in terms of broader feedback that we heard during the consultation, one of the key themes we had linked to the future roles of the hospital site was around the urgent and planned care hospital. So there were frequent references around where we are at as a health board with that future acute sites, some questioning whether we will have a new hospital site, and there's been some general scepticism around whether it will be delivered. Travel and transport, again, was another key theme linked to the future roles of the hospital sites, and particularly we heard from respondents closest to Bwrdd and Withybush, who felt that by bringing together services not at their local hospital site would increase the number of unsafe transfers and also reduce local access for those local communities. The condition and suitability of our existing estate and infrastructure was also mentioned in relation to this question, particularly around Glangwili and the current state of the building, as as well as concerns around access. So car parking, for instance, was another thing that was raised. If we are bringing more services at Glangwili, will it have the capacity both in the hospital site, but also in terms of car parking was mentioned as well. And finally, and this is to a point that Alex touched upon, this idea of the cumulative. So when we're looking at 9 service changes, what the impact could be on those individual sites when you look at the decisions across all 9 and how that could impact those future roles was something that was also mentioned, with fears that it could place unsustainable pressure on some of our sites. And I'll hand back across to Alex.
So where we get to after the consultation then is that the findings, the question that we put out in those descriptions is probably still largely true. But what we see is that the hospitals would each have to play their own part within that wider network if you are bringing together services to fewer sites. So they still have that really crucial bit to play for a whole population, but it may not be that we're providing all the services, all the pathways on each of the sites. So to do that, we probably have to look at making sure, as in some of the options where they talk about health board-wide working, that there are those continuous professional development approaches. There's that ability to share skills between site teams, so they're able to remain skilled and capable of doing that job. But just as importantly, there's the travel and transport support there, not just for patients and their visitors, but also for our staff. If they're expected to move between sites, they're just as likely to require public transport as anybody else that's attending. And then lastly, and this goes back to a point that was made much earlier by Andrew, the consultation never looked at changing our emergency systems as part of the clinical services plan. So as part of the scope of the options, we said that we were not looking to make those changes and the options should support that. So the descriptions all look at still retaining the services they currently have there. So if people have an urgent and emergency need, they will still be able to go to the sites they currently do. And then depending on the options that pick for services, it may be that the sickest people have to travel to receive that care, depending on those descriptions. So that's the future also.
Thank you, Alex. Colleagues, any reflections or observations? Alice?
I think from a public perspective, there's a very natural desire to understand if things are coming out from a hospital and the health...
Could you pull the
oh, sorry.
To you?
I think from a public perspective, it's a very natural scepticism, actually, if we're talking about sustaining the hospitals, at the same time having 9 service changes, some of which will be taking things out from a particular hospital. What people will naturally want to know is, well, in order to sustain that hospital, what's going in then? And I think that's a very natural question that people will want to have a very clear answer about in terms of direction of travel.
Thank you very much. I mean, I think, I think as we work through those options today, we can see where some of those things will realign. So we can see that some things will move out, other things will move in. And we can see that across the four hospital sites. So I think, broadly speaking, there is some repurposing around those sites, and I think that comes through. I think the real challenge for us is going back to where I started the conversation this morning. Every hospital in the country will transform over the next decade. They are going to be so different from where they are now, and we've got to embrace that. We cannot, as a health board, say, well, actually, that's not impacting upon us in this part of Wales or in this part of the country, because it's going to impact on us for all the reasons I outlined in terms of increasing specialisation and advancement of medical knowledge, to the shift towards primary community services and the introduction of more AI automated and digital processes. So it's going to happen anyway. But I think to be honest, I think patient communities need to be able to understand what does that mean for them. And I'm not absolutely certain we've been clear in that. We can define clinically what we think those changes will be, but what does that mean for the patient? How does the patient experience that? How do people living in those communities be reassured by those changes? How do we offer an assurance that actually this hospital will continue to thrive because we absolutely need it to deliver the highest quality services, but that it will change. It will not be as it was in the future. And therein lies our challenge. Therein lies our challenge to give people that degree of reassurance, but to also embrace the fact that we will change, and we have to change in the future if we are to meet the demand for those services. And we've heard this afternoon how the demand is growing exponentially. We have to reform those services and repurpose them and think about how we deliver them differently. I've regularly heard an argument, you're just trying to save money, levelled at me when I've talked about these things. But that is not the purpose here. The purpose is to ensure the £1.4 billion we spend each year delivers the best possible outcome for our patients. And that will mean that sometimes those services will move to different areas, and it will mean sometimes those services are developed and thrived in different places. And we have to embrace that. We cannot stand outside of that. So it's never been an exercise in saving money. It's about spending our money well and in a way that we can be assured it's delivering the best possible healthcare. And I'd like to think that we continue to hold that as a core principle in terms of how we think about these things. I do think there's something about how do we work with our communities so they understand what do their hospitals mean and what's the plan for those hospitals, you know, both now and in the long term, because we need to give that assurance to people that it will still be there, it will still be delivering to their needs, but it will be different in terms of how we deliver that. Colleagues, any other thoughts or questions? Sarah.
So I guess this is just a reflection and a comment, really. We've heard from staff today about some of our most fragile services, where we really are struggling to deliver great outcomes for our patients. And I would just like to recognise and thank the staff who are keeping those services going right now in really difficult circumstances. You guys are doing an amazing piece of work. Thank you. Thank you, thank you, thank you.
Indeed. I think we would all endorse that and amplify that. Very much indeed. Colleagues, other thoughts or questions? I'm conscious we've had about 6 or 7 hours of hopefully mindful thinking around the kind of decisions we need to make tomorrow, looking at those 9 services. It's probably, unless people have forgot anything else they want to add to the conversation, it's probably a good time to close this part of the meeting and for us to spend the evening just reflecting and processing some of the core information we've kind of been exposed to today. Thank you very much for your attention, your energy, your time, your commitment, your passion, and your contribution to today's meeting. Thank you.